Everyone to sit down. Cool. Let's wait for the last ones. Awesome. Perfect. For anyone that doesn't know me, I am Natasha Nadar. I am the clinical nurse educator, and just thanking you all for coming for the second day of our nurses conference. We're going to start our day with a blessing, and our lovely Shruti is going to do that for us.
Thank you, Tash. I'm Shruti, if nobody knows me here, but some of them you do. I'm from Y Health Clinic. I'm one of the nurses there. So I've written a small prayer, Akarakia, in my own language, in Hindi. So I know lots of you know Hindi, but not many of you. But if you want, you can chase me afterwards for the English translation afterwards. So, सभी नर्सेस का अलर्सली इवेंट सेंटर में स्वागत है। आप सभी का धन्यवाद कि आप वीकेंड में अपना टाइम निकाल के यहाँ पे हमारे साथ एकत्रित हुए। हम अभी भोजन को ब्लेस करेंगे। हे ईश्वर, इस भोजन को अपना आशीष दें जो कि हम सब यहाँ पे एक साथ ग्रहण करेंगे। हे ईश्वर, उन हाथों को आशीष देना जिन हाथों ने इस भोजन को बनाया है, परोसा है और हम सब लोगों के लिए यहाँ पे रखा है। हे ईश्वर, इस भोजन को परोसने में जिनकी मेहनत लगी है, उन सब हाथों को, दिमागों को ब्लेस करना, आशीष देना। और हमें हर वक्त उन लोगों के बारे में याद रखाना जो रातों को भूखे सोते हैं, ताकि हम लोग इस भोजन को वेस्ट ना करें, व्यर्थ ना करें। हे प्रभु, हमारे इस भोजन को इतनी शक्ति देना कि इसे ग्रहण करने के बाद हमारी आत्मा और हमारा शरीर सशक्त हो। शुक्रिया, थैंक यू, बाय बाय।
Thank you, Shruti. Perfect, awesome. So just some health and safety stuff before we kick it off. If there is a fire exit is through this door. We're going to go around and meet in the grass area in the front. Please walk slowly, don't shove each other, leave your bags. The toilets are just through the side. We do have coffee and there's water on your tables. If you guys need a break, please just kind of get up and quietly help yourselves. There will be food served throughout the day as well. There is evaluation forms on everyone's tables. Please, if you can, fill them out from the very beginning. I do apologize, there is a little bit of shuffle of speakers, so you might just need to cross out names. Be open and honest. We want your proper feedback. Awesome. Perfect. So I'm going to present our next speaker, our amazing Alicia, who's going to present Lift the Lip and pediatric presentations.
Yes, please do really good feedback for me so I can put it in my portfolio. So I'm extremely nervous, even though I've met most of you before, but there is a lot of you here. So I am going to start with ko ai so who am I? Ko tarakiha toku maunga, ko taikarawa toku moana, ko moitangi toku awa, ko tinana toku waka, ko te rarawa toku iwi, ko hokokeha toku hapu, ko mātihitihi toku marae, ko Clark toku whānau, ko Melody toku mama, ko Clive toku papa, ko Alicia toku ingoa. So my mum whakapapa to the north and my dad is about 3 generations Kiwi. So that's a little bit about me and how we start things off. So we were supposed to have Lift the Lip yesterday, but unfortunately the presenter pulled out, but I really still wanted to go over oral health with you guys. It's something that our PHO has also wanted us to kind of carry out in primary health care, and we're funded to do it as well. So I thought it was quite important that we go over it. All right. So early childhood caries. Is anyone actually familiar with what early childhood caries are and what causes them and some of the complications around them? Everyone's fine with it? So, all right, so I'm still going to go over it slightly. An ECC is defined as the presence of one or more decayed, missing or filled teeth under the age of 6. Almost 50% of children under 5 years in New Zealand have some form of carry. And obviously this disproportionately affects Māori and Pacific. Now I'm not going to go over risk factors for Māori and Pacific because we're all extremely familiar with what those are, hopefully. I hope you all are very familiar with it. Between 2001 and 2016, we had almost 8,000 kids requiring GA for a treatment of an early childhood carry, which I thought was like a pretty large number. And primary teeth, most of you will know that they start erupting from the age of 6 months, with most of them erupted by 2 years. One of the dental surgeons in Middlemore Hospital did a paper around 2-year-olds. They have approximately 20 teeth, and he's removed 20 teeth from 2-year-olds. So he has done full extractions from 2-year-olds' mouths, which is all the more reason why I think that if we are doing vaccinations in clinic or we are doing kind of oral pain and paediatrics in the clinics, we should just lift the lip and have a look and see if there's anything we can do in terms of referrals or getting them to see a dental technician. So the causes of dental caries, again, late stage brushing of teeth, people being symptomatic versus getting preventative care, overconsumption of fermentable carbohydrates, so that's the things like fizzy drinks, sugary drinks, lollies, and demineralisation. So just like all the other parts of our body, the mouth also has its normal flora, and when that's disrupted, then we get the decay of the teeth. So one study, the Growing Up in New Zealand study, found that kids between 2 to 6 with severe early childhood caries consumed on average only 100 mils of sugary drinks more than those who didn't have any. So it's a very minimal amount of sugar-sweetened drinks that can cause severe dental decay in paediatric patients. Then brushing of teeth. So 80% of children with no caries brush their teeth at least twice a day, compared to children with one or more, which averaged at 6.5%. Only 78.6% of those with no caries had parent help with brushing teeth, and the ones with one or more caries only had 7.1% of them had parent help. So parent help is one of the biggest risk factors, so making sure that your patients are helping their kids brush teeth until they're at least 10 years old. I know it's an older age and we should expect our kids to be doing it, but... So again, you've got your developmental defects, plaque presence from toothbrushing, hyposalivation, so usually in patients or our kids that have respiratory illness who are mouth breathers, reduces the amount of saliva in the mouth, which is protective against plaque causing caries. So again, our kids with asthma, we can do lift the lip on them, or those ones who are probably on their pathway towards being diagnosed with asthma. So those ones that always come in with the bronchial symptoms. And infant feeding, again, please, when you see, I know it's difficult to approach parents, but when you see those parents in the waiting room with Ribena in the baby bottle, please try and say something or just kind of do lift the lip and explain what that could do to that child. So here we've got the stages of, pushing the wrong button. Here we've got the early childhood caries, the stages. So we've got normal healthy primary teeth, chalky with white spots, brown spots, and then we're starting to look into severe decay. So we've got 50% of our kids in New Zealand are in the brown spot and severe decay kind of category. So complications and the long-term impacts of ECCs is quality of life in childhood. So we're talking pain, infection, poor sleep, behavioural changes, missed school and failure to thrive. Kids with an ECC were on average a kg lighter than those without. And let's be honest, we do see quite a few kids with mouth pain that come in, even with sore throats, they've got tooth pain, but that's also in adults. Dental caries in primary dentition, so it's a strong indication that it will continue into adulthood. There's a misconception amongst parents or caregivers that just because they're baby teeth, they've got holes, they'll fall out, but it's a risk factor for developing ongoing problems in the adult teeth. It also leads on to poor general health in adulthood. So we've got the increased risk for cardiovascular disease, so that's your myocarditis, strokes and respiratory diseases. The respiratory diseases is two ways, because the respiratory disease patients are mouth breathers. So back and forth. I'm talking really fast and I'm going to go ahead of time. So, prevention. Now, I've written up here mammalian milks, and we were joking yesterday that could probably include like cat milk, but we're really not going to promote that. So we're looking at mammalian milks like cow's milk, or goat milk, or sheep milk, which we can buy over the counter at the supermarket. Has high concentrations of, where is it? Maybe that's in the next slide. So casein and kind of protective things in those. Regular dental checks. So again, we have free dental care in New Zealand from birth to 18 years. Been there for ages, still there. Spread the news, because for some reason people just don't know that it exists. So up until, I think, they're about 12, they go to the community clinics with talk teeth, and then 12 into 18, they go into the private clinics who claim back like we do with general practice consults, I'm guessing. So, with regular dental checks, got some numbers here. So 74.7 of those with no caries were seen by a dental therapist versus 8.4% of those with one or more caries, showing that only a very small number of children who may be symptomatic are seeing a dental therapist. Oh, here we go. The mammalian milk contains casein, calcium, and phosphate, which inhibits the demineralization and promotes remineralization of enamel. Now, I don't know how you guys feel about this. It could be a controversial topic, but fluoridated toothpaste and fluoridated water. Does everyone in this room use fluoridated toothpaste? Yes? I've got a picture of all of the toothpastes that have fluoride in them, we'll look at later. But it's got fluoride exposure has three major effects on teeth. One, it inhibits demineralization, drives remineralization, and in high concentrations inhibits bacteria's metabolism and decreases acid production, which is where oral bacteria like to live. So similar to how we would think about wound care, just orally. Ministry of Health recommends that children of all ages use what they say is 1,000 ppm fluoridated toothpaste, which is what we call adult toothpaste. So, and most child-friendly toothpastes are only 500 ppm, so we should realistically be using adult toothpaste on our kids just in a smear amount. So I thought that was an interesting thing. So we all spend a little bit of money on child toothpastes. but they're not doing any good for our kids. So this, you're probably familiar with this if you've actually been to the dentist recently, but these are the toothpastes that are fluoridated to the right levels versus the bottom ones, which we should be avoiding using. Does anyone use natural toothpaste? Not against you if you do. It's your own choice. But try and get the patients to use the fluoridated one. But yeah, because I think like even for me, the McLean's Milk Teeth is one of the toothpastes that you would always buy for your baby because you think that it's the best one, but it's not doing any good for them. So what is our role in oral health? Because we are nurses, not dental technicians or oral health physicians. We do lift the lip assessments, education, and we can do referrals to ARDS, so that's the Regional Dental Service. The ones who aren't in Auckland, you probably got another regional dental service that you can refer to. So I'm just going to play this little video around how to carry out the lift the lip assessment. I know it sounds like I'm asking you guys to do yet another assessment and you're already busy queue, but when you've got a screaming child, you can probably do a lift the lip assessment when you're looking at them.
This technique is useful for infants as they are sitting on their carer's lap and does not require a dental chair. The carer and the screener should sit face to face with their knees touching. Position the child in the carer's lap, preferably facing the carer as the child may feel more secure this way. Then slowly lower the child's head onto the screener's lap. Secure the child's head against the screener's abdomen and with gloved hands lift the lip. Alternatively, a toddler can sit in front of the carer, both facing the screener. The carer can position and steady the child around the chest during screening. It is important to support the head of the toddler to ensure safe, secure, and successful screening. Preschool children can lie flat on an examination table or sit in front of the carer, with both the child and the carer facing the screener so that the parent can help position and steady the child. When a carer's assistance is not available, the health practitioner can have the child sit on a chair in front of them. The child should be calm and steady while screening. A tongue depressor or toothbrush can be used to move the tongue and view the teeth. While screening, the screener should lift the lip with gloved hands and view the front and back of the upper front teeth, and then the entire mouth. Lift the lip checks are an opportunity to educate the whānau on how to lift the lip themselves. Get them involved in the screening by communicating with them throughout the appointment. Let the carer know what you are doing, why you're doing it, what you are looking for, and what you notice during the screening. Examination.
These technological challenges were just to save some time and go faster. Okay, so that was obviously quite pedantic. We don't have time to do that, I know that. But we do throat swabs. How many throat swabs do you think you guys have done in a day, approximately? Do you think it would just be like easy to look at the teeth while you do that? Because you can really see what's in there. Now the ARDS health scoring system goes from 1 to 6, and this is also represented in medtech, which I'll go through because I have to. So we've got healthy, chalky, top teeth decayed, including the gums, and upper crown exposed, roots exposed, and abscesses, and then deep decay with lower molars. So we're just going to score these. You guys are going to score them. Thank you. I've got chocolate. Only 3. But I did choose one of my favourite chocolates. So what do you guys think this one, based on 1 to 6, where would you score this? Who picks 2? Who picks 1? Okay, so this is 2. So the little arrows, you might not be able to see it so well, but there's little white chalky spots where those arrows are pointing to. No chocolates yet. Okay, what about this one? So this one is actually 1. I think it's just blurry. But there's no chalky spots, there's no... You're probably looking here, it does look a little bit brown, but it's just the blurriness of the thing. The next ones will be... Okay, where are we scoring this one? Who says 4? Who says 5? Does anyone say anything else? 6? No, so this is actually only 3, believe it or not. So if this is 3, could you imagine what 6 is? This is 6. So completely down to nothing. And unfortunately, this is the reality of oral health in New Zealand. So here you can see that there's deep decay in the molars, but also the front teeth are like gone. This one here. Yes, so this one is a 5 because of, like somebody over here pointed out, there was an abscess. Yes, I want you guys to use fluoridated toothpaste after eating the perky nanas. All right, and this one here. This one is a 4, just because the roots are starting to be exposed. So it's almost like recession of the gum, or like a like a receding hairline but a receding gum line in a paediatric patient. Okay, so now this is the part where I tell you how to do this in medtech. Has anyone actually used the screening tool in medtech before? Okay, so some people. Yes, again, it's another screening tool that you need to use, but it's very easy. We want to open patient screening. We want to search oral. We do this at 15 months and 4 years. We need to find out if the patient is enrolled with an ARDS clinic, and if not, we can do the referral. And then if they need to be referred to a dental technician. So there's only 3 things that we're looking at, but also we've done the decay score, which is the 1 to 6. So I'm going to stand here and say, yes, it's very easy for you guys to do, and not realise the reality of how that's going to impact your queue management. But now I can say I told you. Does anyone have any questions around how to input that into... No, so the finance team will... Oh, you'll send a referral when you open the enrolment form or the dental therapist referral. The finance team will download all of the stuff so that we can claim funding for that. More funding means better chances of bargaining. No, this is for all patients. It's just, are they enrolled in the ARDS service, so their local dental technician? Yeah, you can definitely do this in urgent care. Yeah, because in the urgent care clinics too, you will get your sore throats, and even if you started on something like the sore throats and then doing this on assessment on those patients, it should be okay. 15 months and 4 years. Yeah. It'll be like you can claim at 15 and 4 years, but if the patient's a little bit younger, I think that should be fine. I don't think you're going to get told off for it. But it'll be similar to the 45 Boostrix and the 65 Boostrix. Does that kind of answer your question? Yeah, that should be fine. Yeah. Yeah. Don't be too pedantic about it. As long if we could get 10 more lift the lip assessments done between now and a month's time, then my presentation is successful. Yeah, that should be fine. So we'll treat it as like a catch-up 15-month lift the lip. Don't ask me too many more questions about actual oral health because it would just be based on the patient saying, have you been to the dental nurse? Yes, no. If they say no, then you're just going to assume that they've never been referred. You can just give them you can either send the ARDS, give them the ARDS enrolment form. Yeah. So if you ask them what it is and they don't know, then we know that they've never been. Yeah. If they say yes and they've got like severe decay, then we're also going to be like, you're probably not enrolled. Any other questions that aren't specifically about oral health, because I'm not a dental nurse? Pamphlet given? Wouldn't have a clue. Somebody crazy made that template. We do have talk teeth cards, I think, in our local doctors' clinics. So if that's something that you would be interested in handing out or having on the poster, referring to a poster in the waiting room, that would be probably sufficient. But also printing out an ARDS enrolment form, I think, would be considered giving a pamphlet as well, because it's got quite a bit of information on it. Anything else? So the dental therapist referral will be referred to Talk Teeth. Once you submit, it'll go directly to Talk Teeth, so the community dental service. So it's 0800 Talk Teeth. Okay, on Health Ed, which is now goes by a different name. Yeah, no, whatever one says Talk Teeth, that's the one you want. Yeah. So ARDS and Auckland Regional Dental, that's just the short name for it. Yeah. So ARDS, the program is called Talk Teeth. Yeah. So not so long ago, even though I went to primary school like 25 years ago, gross, the nurse was at school, but they don't do that anymore. Not sure why, but probably staffing resources. Did you guys have another question? Oh, about me going to primary 25 years ago? And my primary school speeches have not prepared me to talk in front of this many people. Yeah.
But I find out we refer Helath to ARDS, but after a few months the patients do not have any dental.
Yeah, so that's, again, I can't really answer that question, but all we can assume is that they're completely swamped with the amount of patients they need to see, just like we are. Yeah.
So sometimes I just ask the patients, say like example now end of the year, I just ask them to go to one of the schools to see like head office to get the dental nurse number.
Yeah. And so for instance, where you are, in Papatoetoe or Tara, I would probably refer people to, there's one in Mangere and there's one in Botany. The little ARDS hubs where they can walk in, and hopefully when they smile at the receptionist, they might get bumped up. Yeah. Yeah. So that's also why I guess we should really lift the lip seriously, is that if we can convince parents that I know that you've got work, but look at these teeth, we'll try and, yeah, all right. Tash will write that down. Okay, so I've got 2 more chocolates and I don't want to eat them. So, what percentage of patients or children have help from parents to brush their teeth? Put your hand up if you want the chocolate and answer the question. No. So the ones that do have help. The ones that do have help. Oh, Tarita, you're too close to the screen. It's 74.6, but we'll round it up. And what ARDS score will we put a child with a tooth abscess? Hand up for the chocolate. 5? No. Oh, yes. Okay, got rid of the chocolate. That's good. All right. So that's a wrap for my presentation. And for the people who were here yesterday, we learnt a little bit of a waiata. So today we're going to learn another one. So if I can get you to all stand up. How many of you know Te Aroha? Good, okay. So we're just going to go through it. Tarita's going to help me.
Second line is te whakapono. And the next line is mā te rangi marie. Oh, kia ora. And the last one is tātou, tātou e. Oh, kia ora. So before we go into it, the beautiful Alicia will sing Te Aroha. Then we come in on the second line and we'll sing Te Whakapono. Next line. Me te rangi marie, tātou, tātou e. But Alicia will do the first part. She's our clinical lead. Aroha mai, so just the, I'm Tirita Hiki Omata, and I work at the lovely White Health with my charge nurse, which is Shruti, and she done the beautiful karakia this morning. So kia ora tātou. So we'll start off again. So we'll lead Te Aroha, and then you come in, whānau, and we'll sing it with you. But let's sing, eh? Not whisper. Kia ora. Okay, toru wha. Te aroha ano, te whakapono. Laura, me te rangi marie, tātou, tātou e. Ka pai, beautiful.
So, I think everyone just I'm just doing this bit. Oh, well, that's not on my page. So that's what the only difference is that platforms are different. We are trying very hard to set up our own e-portfolio, but until we do, and we really are working on it in the background with Manteria, because we need to get that working as well. But until then, it is a paper-based system, unfortunately. Okay, so why do we need a portfolio? Exactly. It's a very good point. Has anyone in the last 20 years, that's how long I've been doing a portfolio, has anyone been audited? Yep, me too. And what happens when you successfully get audited? How much time do we have until it could be audited again? 3 years, exactly. How often do you do a portfolio? Every 3 years. The levels of practice: competent, proficient, expert. So up until fairly recently, there's been a little less incentive in part of the group to do a competent portfolio because there wasn't any reward for that other than it's your work, you own it. And anyone can do a competent portfolio at any time. If you are stepping up to a proficient portfolio, and it's not an automatic thing, you don't automatically have to do an expert portfolio after you've done a proficient portfolio. Expert portfolio does take a lot of work, and we basically do the same as the DHBs. When we launch a few things at the beginning of next year, we will need to have an interview. Those of us, like Christine and myself, we all had expert portfolios back in the day, and we all had to have an interview as well as do all of the work. So you don't have to progress to that. To go up to expert, you're really contributing to organisational change, which means you should be producing resources and that sort of thing.
It doesn't always reflect the fantastic job that you do every day, because you might be an expert in lots of areas, but you don't want to commit to the study or the other things that are required. In an ideal world, we would have the majority, let me see if this works. We'd have the majority of our staff sitting on the top of a bell curve in the sort of proficient area of practice and portfolio. Currently, I think we have a flat line, but we're trying very hard to resuscitate that with all of your assistance. Hold on, let's just go back. So just to compare, if you get audited by Nursing Council, does anybody know how many weeks you get to submit that recertification audit? Yep, who said 6 weeks? Chocolate. 6 weeks. That's all the notification you get, because Nursing Council is assuming from that signature that we put on our annual APC that we're keeping things up to date. Yes, if you're moving house, having a baby, going on safari, they will give you an extension, but they do expect that we are keeping things up to date. In fact, the expectation of 20 hours of education, and they advise 1 reflection per year. I've worked it out, and it's 40 minutes a week, or about 2.5 to 3 hours a month, that we should commit to our education. Sometimes it's hard to find 40 minutes in a week, but maybe an extended break from the family with a cup of tea or coffee in the garden and a pen and paper, and you'll get there. So the Nursing Council audit, they want professional development record, a competence assessment from yourself and a peer or your charge nurse, so 2 competence assessments, reflections, and your hours of work. If we decide to do a portfolio, we need a professional development record, competence assessment times 2, reflections, hours of work, and of course a performance appraisal. So the list is looking very similar. Yes, there's a few more things in a portfolio, but if you do get audited and you haven't got a current portfolio, do the recertification audit, and we're happy to support you with that, but then maybe just do the next few steps, and then you've got your portfolio completed. The checklist for portfolio should start with your charge nurse support, or your nurse lead, depending on the size of your clinic, or one of us. We're all champions of portfolio. Nagdeep has a beautiful expert portfolio currently. Some of us, Alicia and I, are busy working on ours. Nagdeep might have to assess us at this rate. So start with that conversation with your charge nurse or nurse lead or one of us if you don't have that person.
Does that person supporting where you're aiming for?
Yes, that as well.
Make that appropriate.
Yep, very much. Thanks, Kate. Good question. Chocolate for Kate. Because, as I said, you can do a competent portfolio anytime. We're all happy for that just to be put onto the charge nurse's desk for that little bit that they need to do. But if you're going to do a proficient or expert, you should be having that conversation. And we've got a whole lot of documents and things for you at the end that will help that. So just a checklist of all the things. The one thing we do that's slightly different, and we add it to our performance review, and that's the technical competencies for urgent care. And Alicia has been working on a list for general practice as well. We can have that as part of the performance review, and it still allows us to be part of the national PDRP program. Is this going in and out? Let me just leave that there for a minute. Do you want to do your... So Nagdeep has been working on a couple of documents as well to help support you to find the right path. And I'll just hand over the microphone.
Hello. So I would like to add, first of all, like as Joanne mentioned, that we get 6 weeks time only in case we get audited, right? But it's a lot of work goes behind, you know. So if we all are updated with our PDRPs, it's going to help us a lot. Because we just don't have to consider that, yes, I can do it in 6 weeks. No. You have to give time to your peer. And it's lots of work goes in writing, like writing against each competency. They need to sit down and do for you as well. And your charge nurse as well. So you can't just expect them that do it in 2 weeks or 3 weeks, right? So that's why if you're all updated with your PDRPs and you get audited, no issue, right? It's all there. It's mechanics of completing performance review and portfolio. So it's a circle, I'll say, goes around. First of all, like say you are new as a new grad or you just started with a company. So it's in a year, like first, the beginning of the year you get goals, right? That you have to be a competent nurse in that area of practice, and you will have some goals, like you have to complete these trainings, you must perform competently in that area of practice, right? So in a year, you get performance review with your nurse lead. And then again, you plan for your next year's objectives. You discuss, have you achieved your goals in that year? And then you set new goals for the next year. And that's your performance appraisal or performance review. And after that, that decides, are you competent? All right, if you're already competent, maybe in next 3 years, that decides in your performance appraisal that have you achieved your goals, your trainings as a proficient, and then you, after the discussion, you decide to move your level of practice. Portfolio assessment. It's accreditation, definitely, that which level you are helps the increment, right? That will add up in your pay. And it's actually a guided reflection, I'll say. Like, I'm a competent, but to be proficient, I must perform at that level. I need to do these trainings and to be at that level, right? And it's reflection on your own practice. Because you know yourself better than anyone else. You can lie, but you know. Then practice. So it's improving, practicing based on as plans, as reflections. So you're sitting with your charge nurse, and she's discussing that you have done this really well, but we need to work on this. And definitely your reflection, like you know where you want to improve, right?
So what's a performance review? It's like, where am I at now, at the moment, right? It's first of all you. And what is required of me in my role? Where do I want to be in the future? Who can guide me? These are the questions for your reflection for yourself, right? It's planning to move forward. And then progression. How are you going to progress from one step to another, or just achieving your goals from one year to another? It's monitoring, discussion, learning, practicing, reflecting. Being proactive all the time at your work. And then again, reflect in a year. Measure, did I get there? If not, then why? What need to change for me to get there? Have a conversation with your seniors, with your charge nurse, okay? All right, so I will talk a little about the levels. It's okay? Yeah. So say you start, like if you're coming, yeah. If you're coming from any area, but not say urgent care or not primary health care, so there might be a different area of practice. But once you are in the area, so you have to be a competent nurse in 1 year. That means you're achieving those technical competencies to perform in that area of practice. So in that 1 year, there will be some trainings that you need to complete, some mandatory trainings, like say for primary healthcare, vaccination, right? So you must have that certification in 1 year, ACLS, all that kind of stuff. And also that you're performing competently, like clear, concise documentation, yeah, and following the guidelines, all that stuff. Competent, right? So you become competent. What's the next step now? Be a proficient. So how are you going to become proficient? When you are a coach to your team, a role model to your team, when you're guiding them, supporting them for everything. We always say, I'm a preceptor and I'm a proficient. No, you need more than that, right? You can be a preceptor, but you should be a role model in specific area as well. Like say for wound care, simple example, right? You're just not a competent to do wound care and choose the right dressings and all, but you must coach your team. You must guide them. These are the assessment, you must go and do this, okay? So you should be a person to go to. Like someone new to your team, someone has questions, they can go to you, okay? And then, so you should be a role model, coach, guidance, a support person. You are a proficient. And after that, expert. Expert, you should be expert in your practice, in your area, specific area. So that's why it has to be discussed. If you think, yeah, I want to work towards that, you need to set up your goals with your charge nurse, maybe for 1 year, 2 years, to achieve your trainings, to perform at that level, and to be an expert. So as expert, you should be making changes in the practice, like say, anything we're doing, and just like, no, these are not current guidelines, or this is new research, I'm gonna make a change in it. Supporting the team, leadership team, and supporting your team, running your own clinics. So it's a lot more to do in the expert. So, but yeah, it's nothing that you cannot do. So discuss with your charge nurses, your teams, and set up some goals and be there. That's it. Any questions? Yes? So you can do this at a competent level, right? Safe environment. But say proficient, you're coaching others that how the safe environment looks. As an expert, you should be like, we've been practicing like this, okay? But this is not safe practice. These are the current guidelines, and I'm gonna run this program as a leader, support my team, update the guidelines, policies, not just your clinic, communicate with others as well.
I'll just add into that. So that's where the organisational change comes in, because I see a lot of fantastic documents and portfolios, and people are using them at their clinic. But when you are starting to look at expert level, you're then submitting those documents to the clinical governance team, which includes some of the senior nurses as well, because that's the organisational change part of that. So if every clinic has one thing that they do better than any other clinic across the group, of course we want to see that, because that might not be the document that other clinics have developed. So that's where that comes in, but we can catch up on that. Does that make sense? Are there any other questions? Okay. Can I just ask if you could put your hand up if you've had an audit in your clinic this year? How many people have had an audit in their clinic? Okay. Fun times with lots of work to do. So PDRP programs get audited as well. So Nursing Council, that's how they check. So as PDRP leads, we kind of have to do an extra portfolio, and that's the one that Nursing Council audits. And we're going to do that again next year. So we would really like to have a lot more portfolios submitted before we're doing that. Can I also ask how many people have because they saw it in the bulletin or for any other reason, that there's a nursing team for us, that there's an email that you can just communicate directly rather than with us individually? Have you all seen the MSO Nursing at Tamaki Health email? Has anyone seen that? Okay, so because I've got way too much chocolate to pass around, we're going to put the chocolate on the table at the back. We've got a few examples of some of the documents. There's a page that's got the MSO Nursing at Tamaki Health email address. Underneath it, there is a little caption with a subject line. Does anybody know the joke about subject lines? Have you heard that one? No? There isn't one, I'm just joking. The subject line needs to start with PDRP. One of the most common subject lines that some of us get, and most of us in the nursing leadership team are getting 50 to 100 emails a day, we get things scanned from the printer. So the subject line says, "Do not reply." So it would be really good if everyone could scan anything that they need to scan to themselves, to reception, to their charge nurse, and then actually put something in the subject. We plan on doing quite a bit of education over the next few months, and we will try and do some sessions a bit like the one that was on Thursday night, where you can just catch up with us for half an hour or so and we can help you with portfolio. So if you would like to have some documents sent to your home address, please send us an email to MSO Nursing at Tamaki Health and put PDRP at the beginning of the subject line. And as we start getting all of the new updated documents online in about 2 weeks' time, because we will have to go and speak at another conference, but I don't think I've shared that with them yet. We will start sending those out as we put them onto Neuron, and then you can actually have a copy at home as well, if that makes sense. I'm not 100% sure on that, but we will advise where it's going to be. The documents might need to be just on Neuron, and if they are, everything will start with PDRP. So if you could email us, if you would like stuff sent to home, then I know, yeah. That we're sorting that out as part of it, but please don't go searching in S Drive and things for the documents, because there's about 25 old versions that are out of date in places like the S Drive, and we're trying to do a really, really clean sweep of everything going forward. So Nagdeep was talking about the levels of practice. So there's a level of practice document, and Nagdeep's created a lovely one that just gives you a little bit more guidance for domain 1, 2, 3, and 4, and at the 3 different levels. So that's really helpful because it just encourages that beginning leadership, coaching, etc. at proficient, through to the expert level which is contributing to organisational change. Excuse me. Any questions? Does anyone think we can have 50 portfolios to assess by the 1st of March next year? I mean, you can if you've got a background that's similar to what you're working in. As a general rule, I wouldn't accept a proficient portfolio from somebody in general practice or in urgent care if they hadn't worked about 3 years in that area. When people come into the organisation with a portfolio, the White Cross Collective says it needs to be substantially similar. And I always give the example because one of the places that I was visiting in my job at Auckland Hospital while I was away for 2 years was NICU. I've never been a NICU nurse, and if I had transferred there, I would expect to be a novice and I would expect to be competent, but because I've had expert portfolio previously, I would expect to get to that faster, but I could not take my expert portfolio to a brand new environment like that. But it is very much a case-by-case basis. Some people have had experience in ED, urgent care or general practice in the past, and just like Nagdeep and I and Shirley over there, we return, so you can take that into account as well. Does that make sense? It can be. Any other questions? Is it clearer or less clear?
I think the real message is expert is not expert clinically.
Yes, absolutely. Chris?
I think the message that's getting through from expert, a lot of people see expert as a clinical expert. That's not what it's about. An expert is being an expert at the organisation level, the management, the change, that's what we're saying. So a lot of people think they're expert because they're clinical experts. It's great we have clinical experts, and those are often the people that are working at proficient level, passing on that knowledge. But that doesn't mean that they're an expert nurse. As per, there are descriptors of it, and if you actually look at those descriptors, you can see that you're not there. And that was the other thing that wasn't mentioned, the difference. We actually have KPIs within White Cross, performance indicators, and they actually are, are really good indicators of those, which aren't necessarily on the Nursing Council audits. Will they be changing, or?
That's a good point, Christine. So previously, a competent, proficient or expert competencies had separate documents because the KPIs are slightly different. So NZNO and Nursing Council are working on an update at the moment, and one of the people who contributes to that, Angela Clark, has always in the past been our NZNO rep on our PDRP committee, and she's going to return to doing that, which is great. It's just so that everyone, all of us feel comfortable that we're ticking the boxes correctly with NZNO and Nursing Council, but they are working on the competencies at the moment, and I'm assuming they're looking critically at a sort of equitable focus as well, because things are quite out of date. Nothing's been updated since 2017. So, but that is a good point. There are slightly different KPIs to meet in the different levels. Any other questions? Yep, so the charge nurse portfolio is actually quite basic because you don't have to do the clinical expertise and then all of the contributing things because you're actually already doing that. And senior nurses and charge nurses in the DHB and in Tamaki Health don't get a pay incentive for doing that. It is a slightly simpler process than even a proficient portfolio, and that's because you should be setting that example that you've actually got one. So yes, a new charge nurse who had never done a portfolio before would do a charge nurse portfolio. Yeah. I have had people request that they do an expert portfolio as their first one, and I've just said no because they're new to the practice area and they don't even realise how much work is involved. We're very motivated by the financial incentive, which is completely normal because we all are. But when people are leaping straight to expert, what they're really leaping to is straight to the expert pay and giving themselves a lot of work to do. Any other questions? So please visit the table, have a wee look at the documents. Please send us an email at msonursing@Tamaki Health, because we have the lovely Jenny Reid that some of you know, who helps us with some of our admin, and she's going to help us with a lot more to do with PDRP. And we'll send you an acknowledgement to home, and as long as you're happy that we send a group email, we'll send out all the updated documents as we're putting them onto Neuron. And as Christine asked, we'll tell you exactly where they are, because I have an idea of where they should be. I just have to make sure that that's all okay. And yeah. No, if you email the MSO nursing email, we'll send it as well. Lots of people, I mean, you can still print it out at work, but there's no point in having a passionate moment that you're going to do your professional development record this weekend, because everyone's going to write down that they were here today and yesterday and then write a comment, aren't they? I am, maybe. Maybe next week. But there's no point in feeling passionate about doing something and then going to Neuron and you can't find the document. So we'll make it very clear where it's going to be once we find out ourselves. And hopefully we'll see you for an evening. Online is fine because we can share all the documents. And I haven't asked Rodney about that yet either, so we'll let you know possibly about the first week of December if there's nothing else on that week. And we'll do another portfolio catch-up and actually help you with writing the competencies, etc. Okay, any other questions? Okay, visit the table, get a chocolate, screenshot the MSO nursing at Tamaki Health, and we will reply next week. Thank you very much. Everybody stand up and have a wee stretch while the suturing people join us. And then Natasha will tell us what we're doing next.
No, 'cause I'll have. Settle down now and we'll start with the next presentation, then we can have a proper break afterwards. Okay. Perfect. So I'm introducing Nicola from Family Planning, and she's going to go through an overview of contraceptives for us.
Kia ora everyone. As Natasha said, I'm Nicola. I'm a nurse educator at Family Planning. I've only actually been in the education role for about 6 months now, so I'm still pretty new to this. First time speaking at a conference, but I have run a few courses, but those groups are a lot smaller. So bear with me if I suddenly get overwhelmed with anxiety or something like that. So I have been at family planning for nearly 4 years. I'm doing community nurse prescribing, inserting IUDs and removing them, inserting contraceptive implants and removing them, as well as starting people on contraception and taking cervical smears and things like that. Cervical screening, sorry. Is a show of hands, is anyone here a community nurse prescriber? Nice, cool. Is anyone here inserting Jadels or IUDs? Anyone interested in it or starting that pathway? Perfect, cool. All right, so we'll get into it. I do have a block of chocolate for one table at the end. There's going to be a little quiz. So you need, if you want to win a block of chocolate, you've got to make sure that at least one person on your table is listening, all right? Otherwise, your table's going to lose. Okay, so I'm sure a lot of us in this room have been on or know someone that's been on contraception before. We've got so many different types, yeah? We've got the depot injection, the IUDs, the oral contraceptive pills, emergency contraception, implants, IUDs, I think I said that one, as well as your things like your condoms and withdrawal technique, which is not very reliable. It's about 86% effective with correct use. So never be encouraging withdrawal, or like people like to call pulling out for contraception, because it is not reliable. All right. So we're going to start off with talking just about troubleshooting. So on contraception, unfortunately, one of the big side effects is often people have some sort of bleeding issue, yeah? And the first if someone presents with a bleeding issue, the first clinical assessment you need to do is rule out pregnancy and sexually transmitted infections. Even if the client or the patient thinks that they're at no or very, very low risk, that's always the first thing that you're going to need to rule out. If the bleeding doesn't settle with time or with treatment for chlamydia or with, another intervention, they will need further investigation. Because as we all know, there are other things that can be causing bleeding, like cervical abnormalities or endometrial abnormalities and all of that sort of stuff. So it's really important that we, if it isn't pregnancy, if it isn't an STI, we do that further investigation and probably have a look with a speculum. Is anyone here a cervical screener? A lot of you, I'm hoping, because you do primary health. Yeah, perfect. Cool. All right. So we're going to talk, you're probably asking, but they're on contraception, why would you be pregnant? But bleeding is always a sign of pregnancy. It can be a sign of pregnancy. And no contraception, apart from obviously not having sex, is 100%. So if you're having sex, there is always that chance that you could be pregnant, even if you're on a very, very reliable type of contraception. And what about, they just had a period, so they can't be pregnant. They had the period on the pill, or, they're on the copper IUD, they had a period, or, all these different things. Well, then you've got to think, was it a true period? Had they just used the emergency contraceptive pill and that's like initiated some sort of spotting? Was it a bleed on the contraception? Is the contraception within its limited time frame? Do they have the Jadel implant, contraceptive implant, and they're creeping onto that 6 years? Or is the depot just slightly overdue? There's so many different things, which is why we always need to rule out that pregnancy test and the STI check. Same with they're taking their contraceptive correctly. Like, are they doing that? Are they skipping pills here and there, or, not taking it within the recommended time frame? All of that sort of things. So there will be time to ask questions throughout this presentation as well. So if you do have questions, whether it's, maybe something a bit more personal or about a friend or a comment you want to make, that is fine. I'll ask you guys throughout if you've got questions or comments, all right? Cool. So we're going to start with the combined oral contraceptive pill, one of the more common types of contraception. So it's 2 hormones, yeah? So it's your estrogen and your progesterone. And how it works, I wasn't aware that I was going to have a mic, so, and also this room's a lot bigger than I thought, but I'm sure we all know basic anatomy. But when I was practicing with my partner, I kept pointing at my own uterus, and I didn't think that was appropriate. So I got a picture here. So the combined pill, the primary effect of it is that it stops ovulation. So it stops that egg coming out every month. And it also thins the blood lining of the endometrium, which can make your periods lighter and more manageable, which is really cool as well. And it also thickens up this the mucus in the cervix, and that's what's going to stop the sperm coming through, yeah? So as I'm sure a lot of us have probably been on this pill before or know someone, this is just a drawing, so, not super correct, but you'd usually have 3 weeks of hormonal pills and then 1 week of sugar pills. The sugar pills are what stimulate a bleed because of the withdrawal in the hormones. It's not a real period, yeah, because we've not ovulated, so it's not a real period. I don't think in New Zealand we've got any like this, but sometimes in the UK, they just have the 3 weeks of the hormonal pills, and they don't have a 4th week of sugar pills. So you don't need to have the sugar pills. There is no need to have the sugar pills or have a break on the combined pill. Okay, it's perfectly safe not to, and as I said, it thins that blood lining of the endometrium, so it's not like you need to have that release. So one issue with the combined pill is it does put people at increased risk of a blood clot, like our DVTs and our PEs. So people that aren't pregnant, not smoking, between 15 and 44, 2 out of 10,000 people are still going to get a blood clot. When you're pregnant, over 20 people in 10,000 will get a blood clot, and that's even higher postpartum. But on the pills, like the ones that we start people on, like our first choice, our first line, is 5 to 7 out of 10,000. So when you compare it to being pregnant, it is still really low risk of having a blood clot. And as you can see at the bottom there, the risk of having a blood clot is a lot higher in that first year of use of using the combined pill. So here you can see some of our funded ones. I'm not going to block this, am I? Okay. So your low oral con, oh, I forgot to fix that. It's not called low oral con 30, it's called oral con 30. You may know them as Levlin and Microgynon 20, or maybe Ava 20 and Ava 30. They're just always going through a brand change. I've been on and off contraception since I was 15, and yeah, I've had 3 of those different brands. As well as Norman and Brevinor. They're all of our second generation pills, so they're the ones that got that less risk of blood clots. So those are the ones that we like to start people on. Then you've got other funded ones like Mercilin and Jeanette, and they're a higher risk of blood clots. Something that I have noticed at family planning is GPs love to put people on Jeanette for not really any apparent reason. But as you can see, it's quite high of that blood clot risk when you compare it to the second generation. And as like an RN nurse prescriber or even as a GP, we shouldn't really be putting people on Jeanette, and it's not in the RN community prescribing list either. So, is anyone familiar with MEC categories? Yeah, cool. So you've got your MEC 1s, so medical eligibility criteria, sorry. MEC 1, this is what we use for starting people on contraception. Our doctors use it too. For contraception, it's all based on the UK Faculty of Sexual and Reproductive Health guidelines. So MEC 1 is like, oh yes, sweet as, person's got no contraindications, definitely, yeah, chuck them on that pill or that type of contraception, that's fine. MEC 2 is like, oh yeah, we'll monitor that, but they're all good, it's fine for them to be on that pill. MEC3 is where the risks of being on that pill or that type of contraception is then going to outweigh that benefit. So MEC2, we're still fine, we're going to monitor, but the benefits are still outweighing the risks. MEC3, we go on to the risks outweighing the benefit. And MEC4 is just completely contraindicated, yeah? So some major MEC4 categories that we've got for the combined pill is past or present circulatory disease, arterial or venous, disease of the liver, cirrhosis and jaundice, breast cancer, and migraines with aura. What I should have said before is the reason why the combined pill puts us at more at risk of a blood clot than the other contraceptives available is because of the combination of the estrogen and the progesterone and how it's processed in the liver. So that is one of the reasons why those are MEC4 categories, because it's going to increase that risk of blood clots a bit more. Does anyone in the room know what a migraine with aura is, or a focal migraine? Yeah, cool. Has anyone experienced one of those before? A few people. I feel sorry for you. It sounds horrible. So, for those that don't know, a migraine with aura or a focal migraine is when you have usually a visual disturbance occur before the actual migraine comes on. So that might look like one blurry spot, but the rest is clear, zigzag patterns. Sometimes people get like a tingling in the hand and it's just on one side, and then the migraine will come on. And because obviously this is saying that there's something maybe vascular going on in there, you don't want to put someone on the combined pill because it's going to put them at this increased risk of having a stroke, and obviously we don't want people having strokes, yeah? So if someone tells you that they're having migraine with aura or these sorts of migraines, you want to take them off that pill if they're already on it, or let your GP know. Same thing as, yeah? Yes, exactly. Sometimes they start while you're on the pill, and you would also want to stop that. In saying that migraine, if you're having migraine starting on the pill, whether they're focal or non-focal, if they started you when you were on the pill, on the combined pill that is, then you would want to be taken off the combined pill. But also remembering health literacy is a big thing. I'm sure you guys are aware of that within your practices. And sometimes I've had people, they don't know what a migraine is. So often I will actually talk about that and saying, do you ever have really, really bad headaches? I get them to talk to me about the headache, and I say, do you ever have funny things happen with your eyes before that headache comes on? Because I do my clinic in Papakura, and yeah, a lot of the time people aren't quite aware what a migraine is. Oh. So this is just a little more of an example of the MEC categories that we use. Something that is really important with the combined pill is if you've got a couple of arterial risk factors, it moves you from a MEC2 to a MEC3. So if you've got 2 or more of those arterial risk factors, your risk is going to go up, no longer going to be on that pill. So if someone's got a slight, if they've got a slightly elevated BMI, and then they were on the pill, and the next time they come see you, they've started smoking, too bad, can't be on the combined pill anymore. We're going to have to change that contraception, so we don't want that person having a blood clot or anything. Cool, so that sort of just repeats that same thing. So if they've got those multiple risk factors, we need to be more aware, and they're going to become that MEC3 status. So the pill is pretty cool because it is effective. So correct use is when you're taking a pill every day, you're not missing them, you're not forgetting them. And when you're skipping the sugar pills, so you're just going from, keep rotating those active hormonal tablets, the pill is 99% effective. So it is really good. But when you look at typical use, so that's forgetting a pill here and there, just doing whatever, it does go down to 92% effective. So that means 8 people in 100 are still going to get hapu, yeah? But it is good if you're taking it right, because, if you want to stop it, maybe you decide you don't like it anymore, you can just stop it. You know, you don't need an appointment or anything like that. You can control your bleeding. Some people like to have a period every month, and that is absolutely fine, and they are able to do that. Some people just want to skip it here and there, and some people want to not have it at all. And on the combined pill, you've got that, that there to help you. The combined pill can also help with acne sometimes. The reason that is because it's got that estrogen component in it that helps the skin, but also because it's stopping ovulation, your PMS is stopping, and often people get acne with their PMS. So you're stopping the PMS, so then you're stopping the acne. And as I was saying earlier, it can make your periods lighter and less painful, which is really good. The thing with the pill, or lots of different types of contraception, is when you look at 100 people on no contraception and 100 people on that type of pill, side effects like weight gain or mood changes actually happen to the same amount of people in each of those categories. So although someone might be like, you know, a lot of people think I gained weight with this or whatever, usually that's not the case. It's situational factors. However, sometimes people do come in and they're like, no, it's definitely this. And then it is that, and you should just take them off it, change that contraception. The other good thing with the combined pill is there's lots of different types, you know, as we saw in that previous slide. So if you don't like one type, that doesn't mean that the next type is also going to be, you're going to have the same effect. So if you like that concept of that pill, you can always change pills if that pill wasn't quite working for you. So you would have heard me a few times now saying that you can skip the sugar pills altogether, which personally I think is really cool. It's really good because it makes it more effective. You've got to miss 9 or more pills to be at risk of pregnancy. It also avoids the hormonal side effects that might happen in that pill-free interval, such as heavy periods, painful periods, increase in headaches, things like that. Sometimes, you'll see I've got that little plaster there about the troubleshooting. So if someone has prolonged breakthrough bleeding when continuously pill taking, they can have a short free pill interval. So sometimes you might have a little bit of build-up happen there, and just having like a 4-day break, no hormonal pills, helps to just get rid of that. Because if there's build-up in there, it's going to come out somehow, and that just helps to sort of reset it and get back onto skipping those sugar pills immediately. Obviously, you'd also do that pregnancy test and an STI check too. Cool. Does anyone have questions about the combined pill? Or any questions at all? No? Sweet, I just also need some water. Cool. People heard of the progesterone-only pill before? Yeah. Progesterone-only pill is really good. Often it's something that we start people on when they're breastfeeding. And also if they've got contraindications to the combined pill. Because of those advantages there's no blood clot risk. It's very safe for people with contraindications to estrogen. It can be used if you're breastfeeding. It's also reversible, so if you want to stop it, you can stop it. You just throw those pills in the bin. And there's very, very few side effects of the progesterone-only pill. So as the name states, it is just progesterone. That's the only thing that's in it. What it does is it thickens up the mucus in the cervix, and that stops the sperm coming up. For most people, they're still going to ovulate every month. For the Cerazette, which unfortunately is not funded, it costs about $15 a month. That one, most people don't ovulate, so that does stop that ovulation. Sometimes people might find they don't ovulate on the funded ones, and then they might find that they have, you know, no periods or just a period very light or things like that. And for some people, the Noriday might have the effect of the thinning of the endometrium, so they might end up with lighter periods as well. So you can see these MEC charts again. So MEC for malignancy of the breast and pregnancy. Obviously, you don't want someone on contraception if they're already pregnant and they know they're pregnant. MEC 3, you've got your liver disease and enzyme inducers and lamotrigine use. So enzyme inducers, that's also an issue with the combined pill, and that's because they affect that metabolism of those pills, and then they become not effective in the body. And we obviously don't want to be putting someone on a type of contraception that's not going to work because they're on an enzyme inducer. So we've got one of our Band-Aids again. So sometimes people on the Noriday, they might have quite a regular bleeding, which is very annoying, or any sort of annoying bleeding for them. And what you can do for the Noriday and the Microlute is they can take 2 tablets a day rather than just 1, and that helps to make that endometrium a bit more stable and hopefully help out that bleeding. Any questions about a progesterone-only pill? No? Any questions about anything so far? Yes? Yeah, so it's actually kind of better to take it BD twice a day, because the Noriday, I should have told you this earlier, has got a 3-hour window. So you've got to take it same time every day with the Noriday and the Microlute. Whereas Cerazette, the non-funded one, is a 12-hour window. So it's a lot nicer, but it's not funded. So the 3-hour window, if you're taking it BD when you're taking 2 tablets, your window pretty much becomes non-existent because you're taking it at 7 a.m. and 7 p.m. So if you're taking 2 Noriday tablets a day, better to do it BD rather than once a day. But yeah, 3-hour window on the Noriday. Yeah? You can do it as a script. I'm trying to remember if it's on the community nurse prescribing chart. Noriday is, but I'm not sure if it's on for BD. What was that? Yeah, I'm not sure if it's on the community nurse prescribing. I would have to get back to you, or we could just look at the thing ourselves. And but you can, no, you must be able to. I'm sure I did it like a couple of months ago. And no one got back to me, so it must be fine. But it is pretty good. The pharmacy doesn't call you up or anything unless you've done it in like a weird way, and they might call you and be like, oh, you've prescribed this, slightly funny. But it's fine. You can just do it twice a day, either BD, or you could write 2 tablets daily, and that's still fine. You can just tell the client to have it twice a day. I mean BD. Yeah. Yeah? Yeah. Yeah, for sure. Yeah, that's a really good point. So if we go back to my example of the MEC charts, so these exist for all the different types of contraception, yeah? So pretty much you're talking to the client about the options. So if they're a MEC 1 for everything, you're still going to talk to them about, the POP in this 3-hour window, but you don't have this risk of blood clots and blah, 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 blah. Whereas you've got this one, you can skip your periods and it's really good, and you've got a longer time frame and that sort of thing. So it's just about that education. In just like a little side note, so vaping isn't on as a risk factor. Yeah. So sometimes I'll have people and they're vaping, a lot, and then they'll have one other MEC 2 risk factor. And so technically they're a MEC 2. And then I talk to them about how we don't know about the risks of vaping, and, maybe that is going to put them at more increased risk of a blood clot starting the COC. So giving them that option, giving them that information, and then the case that I'm thinking about, she went for the POP because she was a bit worried about the vaping and the risks and how that might increase the risk. But technically, it's not a risk. Vaping's not a risk factor. Did that even answer your question? Okay, cool. Yeah, so the progesterone-only pill, this funded ones, so the Noriday and the Microlute, they are, depending on what research you look at, it's about 1 to 3 people in 100 getting pregnant with correct use. With typical use, so for getting your 3-hour window, things like that, it's also 92%, so 8 people in 100, so the same as the COC when we're looking at typical use. With the Noriday, it's usually the age you are, the more effective it is. I'm not sure what the science behind that is. It could just be maybe the hormones work more when you're older, or the fact that your fertility goes downhill anyway, all of those sorts of things. Yeah. Any other questions? Yeah? Cool. What a great question. So, with the COC, with the combined pill, if you forget this one, it depends how many you've forgotten. This is where it gets a bit more complicated, and if you guys are more interested in prescribing or working understanding orders for contraception, there is actually a family planning certificate, and that can mean that you're a prescriber for contraception under the nursing prescribing. So COC, if you miss one tablet, you can still take it the next day at the same time with the other tablet, so taking the 2 at the time. But it all depends on where you are in the packet of if you're going to be safe or you're not going to be safe, or if you're going to need that emergency contraceptive. With the POP, there's not a huge amount of, taking it at the same time. If you've fully missed it and you're waking up the next morning and you're taking your POP, not really any point taking 2 at a time. But if you forgot it by a couple of hours, so let's say you're taking it at 7 o'clock in the morning and then your 3 hours would be 10, but you're taking it at 12 at lunch, you could take it then when you remember, but then you've got to take it on time the next 2 days, and 2 days till you're safe, whereas the combined pill is 7 days until you're safe if you miss pills at a certain time of the packet, which is where I'd recommend you do the third course, because the combined pill can be a bit complicated. Any other questions? Yeah? That is a big question. Yeah. Is it all right if we put that question on hold and do it at the end? But can you please remember it if I forget? Because sometimes I forget things. Okay, cool. But we will get back to that if both of us remember. Okay. Any other questions? No? Cool. Okay. The depot. The Depo-Provera is a large dose progesterone, usually given into the bum. I'm sure heaps of you do this in your practice, yeah, doing the injections. And it's given every 13 weeks is when we're meant to be giving it now. And if you're after 14 weeks, that's when you're not safe anymore. So if someone comes in at 13 weeks and 5 days, they are still safe from the depot. They don't need to follow the 7-day rule or anything like that. So if you guys do work understanding orders and your doctors are telling you differently or anything like that, make sure you have that conversation. It can be given at 10 weeks if needed, usually if people are bleeding around that due time. So what the depot is doing is it's stopping us from ovulating, and it's going to thin the endometrium, and eventually your periods are going to stop altogether while you're on that contraception. It can take about 4 to 5 injections before your bleeding stops altogether. Some people are going to continue to have annoying spotting and things like that. So you can see our MEC charts here. We've got MEC 2 for under 18 years old, and pretty obvious ones like previous anaphylaxis to depot. Obviously you're not going to give it, or if you're pregnant. So the reason why the MEC 2 under 18 is there is because there are some very slight issues with bone density on the depot. However, between the ages of 11 and 14 is when you get your peak bone mass, And then on the depot as well, after 2 years, when you're not on the depot anymore, your bone density is going to be at the same level as it was if you'd never started the depot in the first place. So it's really not that big a deal. And also for Māori and Pacifica, it's also not an issue. Other problems with the depot is that it can take a while for your periods to get back to normal. So if you had someone coming in and they're like, I'm planning on having a baby next year, and it's, August or October like it is now, you'd probably be like, oh, maybe depot's not the best choice for you right now, because it's an average of a year, right? So that means some people are going to take a year and a half, but some people are going to take 6 months. And that's because it just takes a while for the depot to fully get out of the system and then for your cycles to start regularly, that word, again. The other thing is, you know how I was saying before about 100 people not on contraception, 100 people on, and the same amount of side effects happen on both those groups? Depot, weight changes, that's the only one that's like it is proven that you have weight changes on the depot. Most people would be gaining weight. Sometimes you have people that lose weight. Usually it makes you more hungry, and then you eat more, and then obviously you gain weight. However, in that same thing, it can still be situational changes. For example, when I started the depot was my 3rd year of nursing at school, university. And I also was a poor student, living away from home. Got a new boyfriend who was not a poor student, and we had takeaways all the time. Started the depot and I gained 20 kilos. Was it the depot? Was it the boyfriend and the eating a lot of food? I would say it's probably the second, yeah. And you can see up there 70% of people are amenorrheic, so no periods, after 4 injections. So that means you've still got that 30% that are going to have random bleeding here and there. Down there we've got my little Band-Aid. I was saying this one before as well. If someone has bleeding issues before the due time, so before that 13-week mark, you can actually give that injection at 10 weeks. That little, big dose of progesterone helps to stabilize that endometrium to hopefully stop that bleeding again. Also, sometimes people do find the bleeding quite annoying, so they might want to start the combined pill or Provera. Do we all know what Provera is? It's like a very low dose of progesterone, very, very low dose, and that will also help to stabilize that endometrium. Cool. Any questions about the depot? Yeah, why would we not recommend it? There's always a switch to longer, yeah. But the depot is still really good because it's easy, you just come in once a while, especially if you've got like community services card or you're under 22 or whatever, if it's going to be cheap for you. I know some GPs give it for like $10, which is really good. So yeah, it is really good contraception. Don't need to remember something every day, but not as invasive as the LARC procedures, yeah. Any other questions about the depot? Sorry, can you repeat that? Not usually. This is again an equity issue, right, and a staffing issue of everywhere. I've had one friend that a dodgy doctor just gave it to her once, but that was obviously not meant to have happened. But yeah, usually it's just calling around to get that appointment. Yeah. Yeah, it is on PSO. Yeah. I didn't hear that, but I think you said something about after hours clinics have it, and to do a pregnancy test first. Oh, perfect, look at that. But imagine waiting an hour at urgent care just to get depot injection. 5 hours, even worse. But you got to do what you got to do. Any other questions about the depot? Yeah, for sure. Yeah, that is a very good question. So for those that didn't hear that, is you always hear things that you shouldn't be on it for a long time and blah, 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 blah. Depots, I've noticed, has been a lot on TikTok lately as well about bad things about the depot. But it comes, the reason why there's that belief or rumour that you shouldn't be on it for more than 2 years is that bone density issue. It should just be reviewed every 2 years. Obviously, if someone's BMI is suddenly, non-existent and they've been on the depot, well, maybe, no, it's time, but you review those sorts of things every time someone comes in for a repeat. Yeah, but no, it's not really a big deal. The other MEC age, which I didn't have on there, I think it's 40, no, I think it's 50. It's either 45 or 50 years old is where the depot, again, and that's because you're starting to go through menopause, you've got that lack of estrogen, and so your bone density is already getting affected. So on the depot, on top of that, that's where it's becoming an issue. Yeah, Natasha? So if they're late, they can get it any time. You just do that pregnancy test, make sure they're not pregnant, and then you give it. And if there is pregnancy risk, what we do at family planning and what we recommend on our CERT course is that you talk about fetal abnormalities. So, if they'd had unprotected sex a week ago, not showing up on the pregnancy test yet, you go, hey, do you want to have this depot injection today? If you do, it's what we call no known fetal abnormalities. So if you did happen to be pregnant, there's no known risk to that pregnancy, and I'll give you a pregnancy test to do in 3 weeks' time. And maybe I always give them 2 because pregnancy tests are expensive, so I give them 2, and maybe another one a bit later. And obviously, if you are pregnant, you do come in, and we'd go from there. But there is no harm, no known keyword, known harm to the pregnancy. 10 weeks, sometime that's under the nursing prescribing. But doctors and sometimes will do it a little bit earlier. But if you're going earlier than 9 weeks, it's a bit, ooh, yeah. Yeah? As long as they want, as long as there's no issues. Nope. Yes, so that's where it's what I was talking about before with the reducing in estrogen. So it's when you get, I've forgotten if it's 45 or 50, but that's, do you think it's 50? Yeah, 50 years old is where you don't really want to be on it anymore. 50 plus on depot. That sounds like your doctor's problem. And the doctor's like, oh, it's all good. That's a little bit alarming. I wouldn't. I'm sorry, I can't answer that question. Can anyone answer that question? How often the doctor needs to renew that prescription for the depot? Once a year. Right. So which is every year, isn't it? Every 4 depots. For me, because I'm doing the depot, I'm not, I'm also doing the depot and the prescription at every appointment. So it's a bit different for me, but most people in the room, saying every year you'd need that repeat prescription if you're working under a standing order. Yeah? Yeah. No, so they would start them in combination, and it would just be temporary, just to help settle that bleeding. Yeah. Any other questions? Cool. Yeah, about the 50 years old plus thing. It could be lots of other things, like if they're on menopause hormone replacement therapy, maybe it's their option for the endometrial protection. Maybe they've had their menopause blood tests and it's not showing up. Yeah, I mean, that would be definitely out of my scope of practice. I would be booking them in with one of our doctors at family planning for a review if they came to me and they were 50 or 51. Yeah. Yeah? Yes. So sometimes gynecologists will have, and that's okay, they're a gynecologist, they're an expert in their field. They might have someone on depot on a very short cycle, or they might be on depot and another contraception. And obviously that's as per the gynecologist, so that's fine. Yeah. Any other questions about depot? Cool. All right, where'd my little clicky go? So we're going to move on to Jadel implant now. I'm going to pass around some. Please don't take them out of the packet because I borrowed the demos. I've only got 4. So pass them around when you've finished looking at it. Pass it to the next table if that table doesn't have one. So they don't actually look like that, they feel like that, but they're white. So you'll see that there's 2 in that packet. And on this picture, there's just 1. In New Zealand, we have 2. This picture is incorrect for New Zealand. Other countries like Australia, the UK, the US, they just have 1, which is fine. But when it's 1 rod, it only lasts for 3 years, whereas the Jadel lasts for 5 years. So yeah, as you can see, it goes about there. To be honest, this is a bit in the middle. It should be going down a little bit. That's a little bit... Yeah, in that little archy, that little bit between your bicep and your tricep needs to be a bit lower than that. So, it's a slow release progesterone, and what it does, the primary action is that it thickens up the cervical mucus, and that's going to stop the sperm coming through. And it also affects ovulation. It might not stop it completely, but it affects it from being like a viable egg coming out. It is good. So this is under our category of long-acting reversible contraception, yeah? And it is really good because once you put it in, you can pretty much forget about it. It's also really effective. It's more effective than tubal ligation. It's not more effective than vasectomy though, so vasectomy is still the best choice, but unfortunately not funded. But yeah, really, really effective. First 4 years, 1 in 1,000 people getting pregnant. In that 5th year, it's still more effective than the contraceptive pill. One issue with the Jadel, and I'm sure you guys might have had someone or know someone that's presented with bleeding issues on the Jadel before. It is a nuisance. And that's because it can make that endometrium unstable. So the blood might be building up and then coming out, and the bleeding can change within that 5 years. So some people will, have a great 5 years. They just have their normal period. It's perfect. Some people might start off having really annoying bleeding, and then it might get better, and then it might get annoying again. Or some people just have like a random 2-week period every 3 months. Some people just bleed all the time. And you don't know who's going to be who, but it is very annoying. And as you can see there as well, some people have no periods, which is also great. Or they might have no periods for 3 years, and then they start having annoying bleeding. Different for everyone. 14% of people will have spotting or irregular bleeding with the Jadel. And as you can see, 1 in 7 people discontinue due to bleeding issues. So you've got to think that that's 1 in 7 that are coming in and getting it taken out because of the bleeding issues. How many other people are just not coming in and having the bleeding issues? I have a lot of clients that come in after that 5 years to get it changed, but you find out that they have been like spotting that whole time, which is a long time, and I don't know how they survive with that. Troubleshooting, obviously you're going to do your PT and your STI check, but you can use the combined pill or Provera to help stabilize the endometrium, help control it, and then that will either put them back into a rhythm of having a normal period or no period at all. So, for inserting the Jadel, you obviously numb the area first with some lidocaine, and then you do a little cut on the arm, very small one. Then I'm not passing this around because it would be a bit dangerous, but you've got a very big gauge needle. Anyone administered Zoladex before? Yeah, similar gauge to that Zoladex, but you're inserting it superficially, so just under the skin. You're putting it through, putting one rod in, taking it most of the way out, putting the next rod in, and they'll work in 7 days. And then you just suture it up. So you don't do sutures, you just use the little steri strips, yeah? So really easy to put in, and some people do find it a bit invasive, most people don't. Just like anything with a bit of local anaesthetic, you still feel touch and things like that, but you don't really feel any pain. Any questions about the Jadel? Yeah? 7 days. Rule of thumb's always 7 days, even though technically Noriday is 2 days, but you're never going to go wrong telling someone something takes 7 days to work. Any other questions? Cool. All right. So now my personal fave is the IUDs, or intrauterine contraceptives. So we've got two types. We've got our non-hormonal and we've got our hormonal. So I'm gonna pass around, or probably presuming Natasha's gonna come back up and pass around, the copper IUDs. I've got a couple of different types in here. Oh, I thought I got 3. I must have only bought 2. Don't worry, they've not been used. Maybe pass around these 2. I'll also get her to pass around the inserting thingies. Oh, yeah. Yes, so it's not difficult, unless you can't see them. So, sorry, not see them. If you can't feel them, then it's difficult to take them out. So what you do for a removal is you just do a little bit of xylocaine, a little bit of xylocaine just around the insertion site. Depending who you ask, some people have tools, some people will use vasectomy forceps to help remove them. Sometimes you can feel them, and you can just sort of feel them on your finger, and you just cut, and then they pop out. And then you put suture on. Unfortunately, it's not very often, but yes, sometimes it does happen. So you are meant to keep the dressing on for a few days afterwards to help prevent that, but sometimes they do just come out. And it's about 1 in a million that they end up somewhere else. You know, going the other way and ending up in the armpit is about a 1 in a million chance. Yeah. So next year, hopefully early next year, we'll be doing a LARC workshop for implant insertion and removal. So yeah, hopefully we'll be onto that early next year. And if any of you are interested in becoming an implant inserter or remover, and hopefully you can get support from your workplace to come onto those workshops. All right. Cool. Did you have a question? Oh, I thought your hand was up, Natasha. No? Yeah? Oh, okay. Any other questions about Jadel? Yeah? It depends where they've moved to. So sometimes they say they've moved, you go have a look at them and they seem completely fine, and then that's fine. But if they're suddenly in the armpit, not fine. You know what I mean? It depends when you palpate them, you know? If you palpate them and it like shoots up to, you know, up the wazoo, no, not okay. But if it's just moving around a bit, that's absolutely fine. Yeah. Yeah? So, because I work in South Auckland, we've got slightly different prices for everyone than the rest of the country. So in South Auckland, for an insertion and removal, because remember, I'm the nurse, I'm not the reception, so I don't charge anyone. So it's $35 for the appointment, and then I think it's an extra $10 or $15 for the dressing stuff. In Central Auckland, I want to say it's $60 for the appointment, but don't quote me on that. But if you've got a community services card, it's $5. Regardless, no dressing fee. If you're under 22, it's free, no dressing fee. And do you guys have quantiles? Yeah? So Q5 is $15, $5 for the appointment, $10 for the dressing fee. Sweet. Any other questions? Yeah? Yeah. I mean, it's probably fine, but obviously if they don't want it on their arm, they don't want it on their arm, just do it on the other arm. Not really. Unless they do find that the pressure can, because very occasionally you'll have people that say it can be a little bit sore sometimes, and then I would recommend doing the blood pressure on the other arm, but it's not, if they're fine, it's fine. Any other questions? Cool. We have more questions at the very end, so if you remember something, you're like, oh, I have to ask that. It's fine, you can ask at the end as well. Okay, IUDs. So, where's my little thing so I'm not pointing at my tummy for you guys? So, the copper IUD, which are being passed around, as you can see, sometimes there's one of them that looks real medieval with its little umbrella little thing. Looks a bit scary. The Wellington clinics love that one. It's so easy to put in, and they think that people don't have as much issues. It is horrible coming out, so I don't like putting in that one. I like putting in the T-shaped ones. Anyways, how the copper IUD works is that sperm don't like copper, so pretty much they go in there, they get damaged, they die away, done. No hormones in it, but it does cause a bit of an inflammatory response. So it can irritate that blood lining, and then it can make your periods heavier or more painful or longer, or all three of those things, which isn't great. If you have the copper IUD inserted after 40, it can stay until after menopause, so that is great. But yeah, really good if you don't have heavy periods or even slightly heavy periods, because it has got that no hormones. It's really effective, 99% effective. Yeah, and just real easy. Once it's in, you can pretty much forget about it. Then you've got your hormonal IUDs. So, I'll pass around these for you. So these ones come in their little shadow box. You can take it out of the little box, it's fine. But make sure you put it back in before you pass it. All right, so the Marinas, they are really, really good. What they do is they thicken up the mucus in the cervix, so that's going to stop that sperm coming up, and they also thin the endometrium, so they're going to make your periods lighter, more manageable, and a lot of people won't have a period at all. But you still ovulate every month, so you still have that egg coming out every month, so you still have some sort of cycle. You might just not have that period blood, which is really good because it's very, very low in hormones. A lot of the time, it is also used for treatment for heavy menstrual bleeding. So it was about November 2019 that it became funded for contraceptive use. So that is really good. We put in quite a lot. It can stay in, if inserted when you're 45, can stay in until after menopause, unless you start menopause hormone replacement therapy, and then it would need to be changed at that 5 years for that endometrial protection. So as you can see, 16% of people are amenorrheic at that first year. So that's really good. And 57% have oligomenorrhea, which is where you just have very rare menses, or it might be just spotting and things like that. Irregular bleeding is really common at the beginning, sometimes for that first 6 months. And that's just because anytime that lining gets too thick, the blood sort of just comes out again, and it takes it a wee while to settle in there. Then you've got the JDS. The JDS is really good for people that are very, very, very hesitant about hormones, but not wanting that risk of the heavy periods on the copper IUD. And also if people's uterus is slightly on the smaller side, then sometimes people will put in the JDS as an alternative. As you can see, it's even lower hormones than the Mirena, so it is pretty much no hormones in it. You'll see down there that in the third year, 12% of women experience amenorrhea, and the JDS only lasts for 3 years. So that's not as good for the amenorrhea as the Mirena. And also 22% at that third year is still experiencing infrequent bleeding. So for bleeding management, it's not the best, device. The Mirena is a lot better for that and lasts for 5 years. So these are our MECs. Obviously, you're not going to put it in if someone's pregnant, if you already know that they're pregnant, if they've got pelvic inflammatory disease. Chlamydia and gonorrhea is on there. That would be if you know about it, yeah? Because if you're going to put it in and you're doing a swab at the same time and they're asymptomatic, that would be okay. And then you're just going to treat the chlamydia or the gono or the trich or whatever it is once that result comes back. And undiagnosed bleeding. So someone's bleeding all the time. If they've got bleeding between their periods or bleeding after sex, often they would need that further investigation before that. So you can see the little, like how long they last as well. There was a little rumour going around that the Mirena is going to be licensed for longer soon, for 8 years. However, for bleeding management would still be 5 years. And that is still just a rumour at this stage. So who knows when that will happen. Complications, always complications with anything, right? So there's that 1 in 100 risk of infection during the insertion. There's a 1 in 1,000 risk of perforation. So that's when we insert the IUD, we're going to damage the uterus wall, or the IUD is going to end up somewhere else in the abdomen, and then you would need a small surgical procedure to have it removed. That risk is a lot higher if you're breastfeeding. It goes up to 1 in 200. So there's a 1 in 20 chance of it falling out. It might just chill out in the cervical canal, or it might fall out altogether, which is a bit annoying. And very unlikely you're going to get pregnant on it. So it's about 6 in 1,000 on the copper, 4 in 1,000 on the Mirena, and 8 in 1,000 on the JDS. If you did happen to get pregnant on it, it is more likely to be an ectopic pregnancy, yeah, where the pregnancy develops in the tube, not a pregnancy that you can go through with. Cool. So, oops. So where did I put my sound? Oh. I must have left my sound at home. But what we do for the Mirenas, well, pretty much any IUD to insert them, is first of all, we obviously do a bimanual examination, insert the speculum, and then we put on something called a teneculum. Do any of you familiar with what a teneculum is? It's like surgical sponges, but they've got like little nasty little sharp clippies on them. Yeah. That sums it up. So we're putting that onto the cervix, and then we pull, because you know how the uterus is a bit bent? We want to try straighten it up to insert the device. So we're pulling on that teneculum to try straighten it up. And then once we've done that, we will use a sound, just a long sterile stick with a slight bend in it, to measure the uterus, make sure how long it is. Then we match up this with how long our sound said. We put that, oh, I knew this would happen on today. So that should go like this, so we don't put it in with it looking like a T, because that would be nasty. So you put it in like that, you do some little things, it goes into that when it's in the uterus, and then like that, and you pull it out all together, cut the strings. Obviously, if you can look that up online. That wasn't a very good demonstration of that. Harder to do with a big group of people and no model to do it on. But yeah, very good. And I know some of us are grimacing, thinking how horrible that sounds. And we don't give, most of the time, there's no like sedation or anesthetic. Sometimes people will have local anesthetic on the cervix. That can help for if you need dilatation, so if you need the os to open up a bit more, it can help that, but it doesn't stop the cramps of the uterus, because they're going to happen regardless. But to be honest, most people are fine, and most people just need Panadol and ibuprofen. But everyone is different, so you'll sometimes have that person that lies there like nothing's going on and everything's fine, and then next client you have has to lie down for an hour afterwards and thinks it was the worst thing ever, and you really just don't know who's walking into your room and what they're going to be like. And same with, when my sister had it in, I thought she was going to be terrible, because she's like cries when she like gets a paper cut, and so I thought she was going to be horrible, and she was like, oh, it was fine. So you just really don't know. Even she thought she was going to be bad, and she was fine. So you just don't know what people's pain tolerance is going to be with it. Yeah, I think some clinics provide NOS. Yeah, and sometimes if people are really like, if they really need this for medical purposes. I know Auckland Hospital, I think, sometimes puts it in under general, but a very quick procedure to have it put under general. It takes less than 5 minutes, and same with the local anaesthetic. Sometimes I find when the docs, because we don't do the local, just our doctors do, and sometimes I find like by the time they've put the local in, you could have put in the whole marina. So, yeah. But again, different for everyone. Obviously, Natasha found it horrible, or slash thinks it would be horrible, but some people are fine. There we go. It was bad, is what she said. Cool. Sweet. So every different, I don't know if you looked at these ones, but every different one you put in slightly differently. Apart from the marina and the JDS, they go in the same way. All right. Any questions about intrauterine contraception? No? Sweet. All right. So, yeah? No, it's usually, well, when I first started family planning, they told me that they think it's more with the copper IUD that falls out. And then it would be because you're having those heavier, more painful periods, and then the cramps of the uterus is just pushing it out. However, the Bayer, the owner of the marina, maker, they still have that 1 in 20 statistic as well. Sometimes maybe if it was a little bit low-lying, it might be the reason, but often it's just luck of the draw, unfortunately. Sorry? I agree. It doesn't seem like 1 in 20 in practice. So in practice, it does not seem like 1 in 20. But yeah, according to the, data, it is. Yeah? So if they're coming into the clinic and you're a speculum inserter, the best way would be to put in the speculum. But if they want to check them at home by themselves, they can do that. So they'd put their fingers into their vagina, aiming for like your tailbone, lower back area. The cervix feels like the tip of your nose. So once you find the thing that feels like your nose, you want to go around it, because if you're just feeling in one bit of your cervix, you're not going to feel the strings because they curl around that cervix, yeah? And so if you're just up there, not feeling it, and you want to go around the cervix, and you should feel the strings, we often explain that it feels like fishing wire. Sometimes I tell my clients that they could get their partner to put it in. Not put it in. God, I can't imagine anything worse. To check the strings, because they've got a bit more range, to look around your vagina and feel your cervix. But yeah, that's how you can tell them to check their own strings. Yeah, gone fishing. Literally, because it feels like fishing wire, right? Any other questions about the IUCs? No? Cool. So emergency contraceptive pill, levonorgestrel is what it's called now. It used to be called something else. I've already forgotten what it was called. Postinor. Anyone here got that authorization from Nursing Council to give that? And if you didn't know, that is a thing. Yeah, cool. But you're a nurse prescriber too, right? So you don't need that authorization from Nursing Council. There's like this thing, and you can get it specifically just for the emergency contraceptive pill. I think it's pretty easy to do, maybe. But yeah, definitely good if maybe you're working in urgent care, and then that's something that you could provide for your clients to come in if that's what they've come in for. ECP is really readily available now. Chemist Warehouse, I think, gives it for $10. So that's really good. But obviously sometimes, the pharmacy's not open, or someone lives somewhere else, or they don't have $10, or lots of different things. So what the levonorgestrel ECP does is it delays ovulation, so it's going to make us ovulate slightly later in the cycle, and it may interfere with sperm mobility, so hopefully changing up how those sperms are swimming so they can't get to that egg. It's licensed to take up to 72 hours after unprotected sexual intercourse, but there's evidence that it works at 96 hours. But after that 96 hours, there is no difference to having the ECP to the chances that you would have got pregnant without the ECP. So unfortunately, it has shown to be less effective for people with a weight over 70 kilos and or BMI over 26. Which is a lot of people, probably the majority of people. You can offer 2 tablets. There's some evidence that might help those levels to delay ovulation and affect the sperm mobility. But it is better to offer the post-coital IUD, so that's where the copper IUD is inserted in an emergency scenario, which is 99% effective for someone of any weight. The problem with that is that there's a lot of rules with the copper and when you can insert it for emergency contraception. So there needs to be no other risk of pregnancy. So you can either have it inserted within 5 days of the earliest possible ovulation, which would be day 19 of a 28-day cycle, or within 5 days of a single episode of unprotected sexual course within a cycle. So if someone's not having cycles because they were late for their depot, they're 15 weeks after their depot, they haven't been having a cycle. So according to the Aotearoa New Zealand contraceptive guidelines, they wouldn't be able to have that post-coital IUD. Or if someone doesn't know their cycles, if they come in and they're just having tons of unprotected sex and they're like, for some reason they want the copper IUD this time, but they don't know where they are in their cycle. So no go. They can't have that because they can't already be pregnant from, sex 2 weeks ago or something. That wouldn't come up on a pregnancy test. Am I making sense, or have I just gone on a bit just then? Yeah? Yes, very good question. And that is where you hope that it's going to affect that sperm mobility. Well, I think it is wise to find out where in the cycle they are, because that's not going to go to, to harm, because maybe they're day 27 of a 28-day cycle, and you can tell them that, you don't really need this. But again, it's about, do they track their cycles? Are they a reliable cycle tracker? all of these sorts of things, because some people aren't very good at tracking cycles, or are their cycles irregular. And also it comes down to two things. If the client wants it, it's not going to do any harm to give it, unless they've got anaphylaxis to progesterone or something. And also, if in doubt, give it out. Yeah. But yeah, always good to work out the cycle as well, because then you can maybe offer them the postcoital IUD as well, if your practice or somewhere like family planning that does them. But if no one in your area does the postcoital IUD, don't be talking about it, otherwise you're offering something that doesn't exist. Yeah. Any other questions? Or you just give them two at the same time. So 2 one-off tablets. If you vomit, if you're having 1 or 2 and you vomit within 3 hours of taking them, you give them a repeat dose. Yeah. Any other questions? Cool. So this is where I wanted to go back to your question about the under 16s. Which, yeah, just because it is another consideration. So was your question about what we should put them on, or was it? Yeah. Okay. Cool. So the legal stuff is obviously very, very deep. But I'm sure most of us know, about like if you're under 16 and you want an abortion and you don't have parental consent, you can still get that abortion, yeah? And it's basically the same with contraception. If you're under 16 and you want contraception, you want contraception. So it goes down to a bit more detail than that about Gillick or Fraser competence. Make sure that that young person's best interests are satisfied, yeah? Just because we're providing them with contraception does not mean we're encouraging them to have sex when they're under 16, yeah? We're just making sure that they're safe. They've already made that choice to have sex, and that's fine. And yeah, we just want them to be safe with that. So about the encouraging, or what we should encourage, was why I wanted to leave this, because we do sometimes have bias, especially towards long-acting reversible contraception. So, rangatahi come into the appointment and you're like, oh, the implant's going to be the best for you. It lasts for 5 years. You'll finish school and, it will still be working and blah, 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 blah. But really, we just need to talk about all the options with the patient or the client and get them to make the informed choice, yeah? Because if a rangatahi is coming to your appointment wanting to start contraception, either with or without guardian what is it called? Consent. They're obviously already making that really, wise, and, they obviously already, are taking that initiative to come in to see you. So, yeah, they can make an informed choice about the contraception they want. The lark bias also comes in with after abortion, same thing. People are like, oh, well, we'll chuck in a IUD when we're doing your surgical termination, or we'll put the implant in, or you've got to have the depot before you leave. And that's another bias thing, I'm sure we're all aware of bias in other sense as well, like racial bias and things like that, and that we need to check that bias at the door when we see a client about whatever, and contraception is the same. Did that kind of answer that in a roundabout way? Yeah. Another thing that I learned kind of recently within my family planning journey is contraceptive gatekeeping. So that's, I'm the person that removes implants, I'm the person that removes IUDs. You can't really do those things by yourself, and so they come into me, and if I say no, then, that's a barrier in place. Obviously, I don't say no, but it is something that you need to be aware of. And I remember when I first started removing Jadels, I'd be like, why do you want it out? And the clients would always give me they try to give you so much reason about why they want it out. And I realized that I must be making them feel like they're not allowed it out. So now my thing is, why do you want it out? Do you hate it? Do you not like it? Do you want a baby? I try to make it, I'm fully happy to take it out today. I'm just interested to know why, because if it's that bleeding issues with the Jadel, there is something that maybe we could do to help. So really important to be aware of that when you're a remover of long-acting contraception. But then in that same thing, you've got guardianship issues. So if someone is, maybe got fetal alcohol or some sort of an intellectual disability, and they might have that guardian, legal guardian, and they come in to get their contraceptive removed, but they don't have their legal guardian there, then obviously it's another situation where you'd probably need to redo that, get them come in at another time with their guardian so you can have that conversation with everyone, yeah? But yeah, just something to, be aware of with contraception and all of that sort of stuff. Does anyone have any comments or questions or maybe stories that they want to share about anything to do with contraception, really? No? Yes? Terrible. Oh, it depends where you're based. Are you in Auckland? Are you in central Auckland? Yeah, I think it's pretty bad there. Fully understand this issue, and that's an issue that every day I'm in clinic, I face. And working in Papakura, sometimes you've got these people coming from Takapuna just because Papakura was the soonest appointment. But then it's our Papakura wahine that is, unfortunately, us, just like most other organisations, short-staffed, don't have the right people trained and all of that sort of stuff. But I would encourage you, if you have people that are wanting an appointment with family planning, they can actually sometimes call up every day and be like, was there any cancellations today? Can I get that done? Or also just walking into the clinic. Maybe not so, Henderson maybe okay, Takapuna Newmarket not so good with the walk-ins, as in because people come to their appointments. But Manukau and Papakura, often we have that high DNA rate, so you can actually sort of just come in and, if they're happy to wait for an hour, there might be a DNA and they might get seen. But obviously still booking that appointment even if it's for 3 months in advance, so then it's there if it doesn't happen. I always tell my Papakura clients, look, if you need your depot or you need a pill repeat or whatever, just come on in because we might be able to see you that day. But unfortunately that is the case. I think Natasha said someone here is from Christchurch, and I think the wait time at that family planning is 3 months or something stupid. Yeah, so unfortunately we're, lacking in that sort of stuff too, which sucks. Auckland Sexual Health can sometimes do stuff, and also, there's a LARC clinic with, I forgot what Auckland DHB is called now, but whatever Auckland DHB is called, they do some LARC clinics as well, so those are some other revenues that you can get that stuff done. Maybe universities. Other GPs sometimes do it, but I don't know what you guys are charging for implants and IUDs, but sometimes it's through the roof expensive. And so family planning or these other places can make it a bit more affordable. Any other questions, comments, concerns? Yeah? No. We've got we've got one male doctor in the... Actually, I think in the whole of family planning, and he works in Henderson. He's in Takapuna. He's really nice. Yeah. That was an interesting question. Yes. Are you talking about on a contraception, sexual health base? For sexual health, Auckland Sexual Health is amazing. If you can't get hold of them, you could try family planning. We're probably your next best option for sexual health concerns. For contraception, you can call us. Sometimes people do that. I've had a few calls from school nurses around the country just trying to put something past someone, and you can call us. Unfortunately, it's an issue of if we're in clinic and then they've got to get someone to call you back, so it's not quite an urgent thing. Obviously, you've got Healthline. I've never called Healthline for anything. I don't know how good they are. Yeah. Any other questions? Yeah? Was the 15-year-old a non-res? The 15-year-old was too? Ah. I don't know either. I could get back to you on that if you like. I've forgotten what our rules are for the under 22 non-residents. If you want me to answer that, just write your email down, and I can email you what our rule is for that. Yeah. Yeah, non-res is always an issue. It's like, I don't know what it is, a lot of money to get things done at family planning as well. Maybe Auckland Medical Aid Society might be a bit better for that. Yeah, they can still get the appointment, it's just expensive. Yeah. They just have to pay them at the pharmacy as well. They've got to pay a non-res price. Yeah, most of the time they do. Sometimes they don't. Yeah. Any other questions? Cool. All right. So I think the next one. Oh no, not yet. So what is to come in the future? You know, there's a lot of contraception that's not available in New Zealand that I'm sure we might have seen on movies or TV shows like the patch and things like that. You know, or is things like that Cerazette, which is a really great option, ever going to be funded? Who knows? Who will ever know? Hopefully at some point we've got more availability for that sort of stuff. Maybe one day a man will take a pill. Hands up if you would trust a man taking a pill for contraception. Look, even he's not putting his hand up. So that sums it up. Do you really not trust yourself? Okay, we're up to speed quiz time. It's not really a speed quiz, but kind of, because if you want to win the block of chocolate, it's Mera Creamy Whitakers, then you need to be the first table to answer all the questions, but you need to still get them all right. So I want all tables to finish. So once you're finished, put your hand up, and I'll write it down, so let's try to remember, and then we'll make sure you got all the questions right, and if you got them all right, then you get the block of chocolate. Just creamy milk. This is what you can get. You could probably share it with a table next to you if you want to cheat, but not if you want to eat the whole thing. Ready? Okay, what contraception is 100% effective? No, you've got to answer all 5 of the questions. Write them down. Write them down. What are the first 2 investigations recommended for someone presenting with bleeding issues on contraception? Is your question 2. When does the depot injection stop being effective? How many different intrauterine devices types of intrauterine devices are there? On the combined pill, it is better to have the sugar pills every 3 packets, true or false. So once you've finished, perfect. Okay, I'll remember you guys, then the back table. Oh my gosh, it's going too quickly. 1, 2, 3, 4. Okay, we've got 4 tables done. 1, 2, 3, 4. Just for that table in front, intrauterine devices types. Okay, you guys are 5. 1, 2, 3, 4, 5. Six. Yeah, I agree that question 4 is, you could get away with having question 4 2 correct answers. Okay, so depending what you've got for question 4, you may or may not be right, table 1, all right? Anyone else want, okay, what are you guys, 7? I think you're table number 7. You were 6. So the one behind you is 7, right? Any other tables want to participate? Or should I get to the answers? Yeah, you're number 7. You're table number 7. All right, table number 1. What is your answer for what contraception is 100% effective? Cool. 2, what are the first, abstinence for those person. Oh no, I shouldn't tell you the answers in case the second table doesn't know them. 2, what are the first 2 investigations recommended for someone presenting with bleeding issues on contraception? Cool. And when does the Depo-Provera injection stop being effective? 14, cool. And how many different intrauterine devices are there? 10 out of 10. And 5, on the combined pill, it is better to have the sugar pills every 3 packets. Perfect. Sorry, everyone. They got the chocolate. So if you didn't hear the answers, number 1 is abstinence. 2 is pregnancy test and STI check. 3 is 14 weeks. Question 4, how many different intrauterine devices are there? That's why I said it's a bit thing. 2 non-hormonal and hormonal, or if you answered it the other way, you could say copper IUDs, Mirena, and JDS. Both ways correct. I understand I didn't ask that in a very great way. And on the combined pill, it is better to have the sugar pills every 3 packets. True or false? False. Nice. Did every other table get those correct? Cool. That's great. You're doing better than my partner, so that's good. Cool, so these are just some of the other courses that we've got. Some of you might already be familiar with them. So as I said, we've got that family planning certificate in contraception and sexual health. There is a Ministry of Health funding for that one, and that's the one that means you're able to prescribe contraception under the RN community prescribing, or also helps you to work under those standing orders. So if you can get support from your workplace, that's a really good it's a 3-day workshop, but you've got to do some stuff at home as well, so I think they call it a 4-day workshop. We've also got our conduct cervical screening. We'll be having 4 of those next year, hopefully plotting those courses soon, so they will be run by me, as well as the Auckland CERT courses will most likely be run by me. Then we've got this RN prescribing, which is very similar to that CERT. Then we've got our online ones, which are just like a little overview. The emergency contraception is the one that can help you get authorised through the Nursing Council to provide ECP. And then we've got our workshops to come in 2024. We've got lots of health promotion and education courses as well that you might find interesting, including ones on sexuality and gender diversity. Sweet. So I've had a great time talking to you guys today. Wasn't as scary as I thought, but still a little bit. Does anyone have any other questions or anything? Yeah? Oh, vasectomies is the best option ever, but it's like $500. So there's SNP, and there are certain GPs do them. Yeah, Vasman, I think that's Waikato, isn't it? Oh, Ascot and Waikato. And also, I think it's counties, DHB. You can get it funded postpartum. I think up to 6 months with a referral from your midwife. Vasectomy is great, but you've got to use another type of contraception for 3 months afterwards, because you've got to do that test of clearance. Other thing with vasectomy is if you're ever encouraging a patient or maybe a partner to get it done, they often think it's going to stop working altogether, but it still works
and just no sperm come out, but everything else works exactly the same. I'm a great believer for vasectomy. If you're finished with your families, if you're not finished with your family, it can be reversed, but it's expensive. Yeah. Any other questions? Cool. You guys have a great conference.
I was hoping the food would be out, but we'll take a mini break and I'll see where that's at.
Everyone's still waiting. Tēnā rā koutou katoa. Ka pai. He mihi tuatahi kia rātou kua kōrero ngā kōrero, kei te mihi, kei te mihi, kei te mihi. Kia koutou e noho I mua I au. Ngā mihi nunui ki a koutou, mō koutou aroha, o koutou manaaki, o koutou tiaki a tātou iwi, huri no I te motu, mai te herenga waka, huri no ki te tonga. Nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko wai au, who am I? So the easiest way for me to explain who I am is in pictogram. Okay, so, ko taranaki te maunga, ko tangohoi te awa, ko wharepuni te marae. Ko ngā rua ine, ko tongarero, ruapehu, ngā maunga, ko whanganui te awa, ko tirorangi te marae. Ko ngā pai maunga o ruahine, ko rangi tikai te awa, ko hauati te marae. Ara, I've just explained the three marae, the main marae. I come from about 12, but they didn't fit on the slide, so I had to shorten it down to the ones that I affiliate with most. Ko ko kauman rawa ko huhana o ku mātua, ko me kaire tōku tāne, te kau o Māua Tamariki. So, my parents are Coleman and Baurangi. Dad's from Taranaki, mum's from the awa o Whanganui. My partner is Michael, and he is Ngāti Hāmoa, or Samoan. Those are all our kids. There's 10 of them all up, and I couldn't fit the mokos in, because there's 13 and a half. So we're pretty good with our whakapapa and how it's running so far. So that's just to explain who I am on the personal level. Ko waio anō. I work in the wellness support team, and I am their equity lead. So, why am I here? Oh, hang on, let's try this. Okay, so, trigger warning. This is not like your normal te tiriti o waitangi session. Okay, I'm going to ask questions of you, and I'm going to get you to actually have some kōrero around what the Treaty of Waitangi means for you. Okay, I don't do lectures. Please, if there's something that's burning in your little hands as a question, shoot your hand up. Hopefully I've got the answers. If not, I'll get back to you at a later date. I will go and search those answers, okay? I do not profess to be a know-it-all of all things treaty. I know quite a bit, but I don't know everything. Okay, my background is I taught for 20 odd years as a secondary school teacher, and this was one of my main focus, te tiriti o Waitangi. I do most of the training of te tiriti o Waitangi for our health coaches that come into your clinics. We still have work to do. Kapai, I've named this te checking the fine print. Okay, how many have actually done some kind of course, workshop, session on Te Treaty o Waitangi, or the Treaty of Waitangi? Excellent. How many of you did it in the last 5 years? Yay. Cool. What did they tell you? What was one of the main things? What were the principles? How many are there? 5. Okay, the 3 Ps are gone. Okay, if I hear a 3P, we're going to get 5 principles thrown back at you. Okay, so we'll do an update on that, because there's still many clinicians and non-clinicians that still pull out the 3 Ps. Okay, that was updated in 2019, and it was actually reviewed in 2021. So, why are we here? So, we're going to look at, this is the start of a discussion. It's not the end of the discussion, it is the start. Okay? So if you want to learn anything extra, that is upon you. If you want any guidance to learn anything extra, feel free to ask questions. There are many courses, and they're amazing. Okay. We're going to start with the scenario. He taonga tuku iho. Okay, a treasured gift passed down. No matter where you're from in the world, this is the most treasured gift that exists at the moment. Okay, you have never seen panic like a person who does not have their charger and they watch their phone charge go from 5% to 3%. To 2%. You know, those ones that go through your clinic going, have you got a charger? Have you got a charger? I need a charger. My life is ending. Ara, the most treasured gift in the world. Okay? And if you really want to upset your children, hide their charger. It's great to see their panic. So, let's pretend you have got the last charger in the world. Okay? No one else has got it. Last charger in the world. And then you have, can I borrow you for a moment? A handsome colleague who wants to share your charger. Okay? Now, looks very trustworthy, yes? Absolutely. So, I'm going to hand this treasured charger to him. Okay? We are happy as. We share the charger. Wonderful. He uses the charger, I use the charger. We have a great amicable relationship. Okay? And then, can I borrow you? Thank you. The side. Whee! It's like a dance. And then we have someone else who needs the charger. Now, my handsome colleague offers to share the charger. Okay? No problem, huh? I wasn't part of the discussion. All good. Can I borrow you? I like this. People take my hand. There you go. Then we have another person who needs the charger. They're willing to share the charger. Oh, yeah. My phone's okay. It's all right. They're still sharing the charger. My phone slowly going down. Okay. I can do this. I can make it work. We're working in partnership. No problem. Ka pai? Sorry, I do a lot of this. Thank you. Then another person comes along and they share the charger between all of them. My phone's going flat. I think I need my charger. So I go to my handsome colleague. Can I have my charger, please? He doesn't have my charger. He's given my charger to someone else. But I want my charger back. You lost it. Someone's going to lose it soon. No charger. But my phone's flat. You'll look for it. Very political answer, isn't it? I'll look for it. Ka pai. Can you take a seat, please? Now that charger translates into land, waterways, reo, sovereignty. At no point was the original person part of the discussion. They had an agreement with the first colleague, no matter how handsome he is, if he hasn't got it, he hasn't got it. Okay? That is basically te tiriti o Waitangi in 2 minutes. Okay? No matter how many times you translate it, no matter what version you are looking at, that is the intent of the Treaty o Waitangi. Okay, so remember all of those papers you read and all of those essays you wrote? I just explained it in 2 minutes. Okay? So, keeping that in mind, that is your, okay, we know what the intent of the treaty is. I'm not going to give you the whole preamble this, Article 1 this, Article 2 this, because most of you have actually done a bit of treaty work. Ka pai? Some interesting facts. Now, some of this kōrero that's going to come out today is going to be challenging to you. It's going to make you uncomfortable, because I'm going to ask a few quite pointed questions every now and then. Okay, it's not a personal attack. It is to get further understanding and to get those kōrero going, those challenging conversations. So, these are facts. They are not made up. They are not inference. This is what actually happened. So, in the 1830s, the British government decided they needed to protect Māori people. We were fine until then. British settlers and trade, especially from the French, who had an interest in taking over New Zealand. The actual fact was the French were bringing a treaty as well. They were literally 2 weeks behind the British. So we could have been speaking that beautiful language. Oui, oui. So, good old Governor Hobson began writing the treaty. I love this. Where did he begin writing the treaty? On the boat on the way over. Okay? So, to secure British power. And the treaty was translated by Henry Williams and his son. More so his son. Henry Williams was basically whāngai, or informally adopted by the local iwi, and his son was raised with all the other tamariki within the pā. Okay, so his son was basically fluent, and he had a great understanding of the reo. That's why they did the translations. The treaty was written in both English and Māori. We knew this. Translations are not the same. We knew this too. Now, the reason we know this is because there are certain words that there in no way would any Indigenous people agree to. Would you give up all rights to your language in your own country? You can't go to Japan and say to them, don't be Japanese. You cannot be samurai. You cannot practice your values. Every day, we are told that in one way or another. You must do things our way. The Māori version of the treaty, this is quite relevant. The Māori version of the treaty was signed on the 6th of February. What happens on the 6th of February? Holiday. Okay? Most of us take it. Some of those who are in urgent care, you're doing public holiday service, and I'm going to say it's service. That was where the first signings were. That was not where the last signings were. Okay? Many more chiefs signed copies of the Māori version of the treaty. And yet our government still says that the English version is the relevant one. When you sign a contract for whatever, the legal document is the one that you sign. Is that not right? Funny. Not when it comes to the Treaty of Waitangi. Now, there are a few things that we don't do here in New Zealand. So there is two major international laws in regards to signing treaties and the legal documents of treaties. One of them is the Magna Carta. How many of you actually heard of the Magna Carta? Cool. And the other one is Preparatoa. I learnt that. In both of those international laws, it recognises that the treaty that is written in the Indigenous language is the legal document. So if you look at the treaty, the the version that was signed by Māori, and this is not all Māori, but the ones that did sign it, 80% of them signed the Māori version. According to international law, the Māori version is the legal document. Here in New Zealand, there is legislation that says we do not recognise international law, treaty law. Thus, they still recognise that the English version is the relevant one. Hold that. The British announced supreme power over New Zealand on the 21st of May, 1840. It's only a couple of months. How can you say you have supreme power within months? Thinking. Doesn't like me. There, nope. So, we came into a, we've already discussed that there's actually 5 principles. In 2019, the Whole Water Report came out. Does anyone know what the Whole Water Report is? Excellent. So, the Whole Water Report is a report that's done for primary health care, or for healthcare, and it is done by the Waitangi Tribunal for Te Whatu Ora, or back then Ministry of Health. Okay, so they did a review. So those who studied earlier can remember the 3 Ps. Okay, can I have it? What were the 3 Ps? Yep. Okay, so it's not that the 3 Ps are now irrelevant, they have been absorbed and been made more succinct. Okay, so the first one, tino ranga tiratanga. The next one, equity. Third one, active protection. Fourth one, options. And the 5th one, partnership. This is an expectation of all primary health care kaimahi. So, on your table, you have a very, very expensive and very, very high-tech piece of paper that has a A, E, I, or U. So you've got either A, E, I, or U. That is the principle that you're going to look at and have a kōrero about in your table. Okay, which is why I asked you to split up a little bit. Kapo? So, looking at your little piece of paper, you can see which of these is yours. So your first question, translate what your principle means in plain English. So in plain English, you can kōrero, what does your principle mean in plain English? Because this is the legal speak, or the academic speak. What does that mean in plain English? I'll give you 3 minutes. I didn't even see you there. Oh, because I was sitting over there. How are you?
You doing well?
Oh, yeah, I'm still standing. This time. Yeah, take a photo and take it back. One more minute. So whilst you're doing that, I'll roll into the next question. What does that look like in your setting, in your clinic, in your life? What does your principle look like? So now we're looking past the words. We've gone to the understanding. Now we're looking at how does this look like in real life? How does the principle that I've just translated into proper English look like? How does it manifest itself? No, they'll figure it out as time goes on. So what this does is it activates them taking it from just a principle to, okay, what does that actually mean, to this is what it looks like. Yeah. Or I tell them what's best for them. No. That's why breaking it down like this has to be collected. Yeah. This is something they don't give at uni. No. Stop it. By the way, you will be feeding this back to the whole room. So it might be a good idea to write things down and to choose your kai kōrero or the person who will be giving the feedback. How are we going? You done really well? No, I think everyone's doing well. The thing is, you have to understand it. This is why it's been broken down. These are the 5 principles, and here you go. I can write a 6,000 word essay about it, but I can't tell you. When I was a kid, What was your reason? What was your understanding of the program? Because there's a lot of problems to it. There's a lot. I mean, I guess our South is the lowest. They don't have that So anyone who works within the healthcare system as a healthcare provider. So what are you protecting? Patients or co-patients? Remember, we're doing treating Waikiki. It says up there who you like, okay? So we already know the health inequities in regards to markets. Okay, we have the stats. The stats are not only given to us in our clinics, they're given to us as a country. It's in the media, it's in the government. Everything is about health inequities. Okay, so active protection is how can you actively protect someone who has inequities?
Sorry, coming out.
Yeah.
Because Joanne's running out from
So that's protection in terms of what
Resolution 3 as well.
Okay.
I've specifically told them to save it up. And Rishi's going to have a list of names. So she's just going to keep your stats for this tip very soon. Put everything together. Yeah. I told them that Rishi's going to be there. I did give them a like that back to the front.
Did some people not get there? But because it was all in one.
Recognise utilising those services, you know, that they may or may not need. Make sense? Yes.
Yeah. No one heard the like leave it part.
I know. It's okay. It's okay. You're diabetic. You're on high cholesterol. You're going to die of a heart attack. I'm not going to hit any of those numbers. So, you know, like that, the act of protection is someone says to the GP, is that where you have to start? Can you not start with the So the act of protection is you can actually go to the doctor and just have a word, respectfully. Is that the way we need to start our conversation? That's it. So just looking at that. And then the other thing is do our policies. Do our policies suit Māori or do they suit non-Māori? It's not easy, I know. Are we okay? You keep looking at me going.
No, I was listening.
Okay, our next question. I know, it's like a test. What can you see yourself doing better? Now, I truly believe you all do amazing jobs in our clinics, and sometimes under the worst circumstance. Okay, it is not easy having someone who is aggressive, who is angry, who is in your face. That's what you sometimes have to deal with. I'm aware of that. Okay? But what can you see yourself doing? This is a tweak. What is something you can do better? So you're already good process in you yourself or you your clinic. What can you see yourself doing better to embrace your principle in your daily work process? I know it's not easy. So endearing and invitational. Not the first time I've been asked, by the way. Love it. Are we finished? We got this. Okay, next question. Just a reminder, there are no bad answers. No bad answers or wrong answers. You want to chew on it? It's up to you. Probably not as yummy, but okay. We're all sorted. We got this. We got this. So what we're going to do is there's one more question. Sorry, can I get you to log in? I'm so sorry. Yep, I have. I don't want to take up too much time. Okay, I know that it seems like I'm rushing you along, but they all kind of blend into each other. Your last question is, how can you encourage those who you work with to be better, to better action your principle? How can you encourage those you work with to better action your principle? Just a reminder that encouragement is done respectfully. We do not encourage violence. Very respectfully. No, it's all right. I'm just listening. I'm not. She's testing you. So the best one is to say, look, I'm really going to fact this up. Yeah. And I apologise before I start. However, I'd really like to learn to say it better. Is that correct? Yep. Yep. And if not, yeah. 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 Cool. You've given it a go? Yeah. 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 Rather than don't. Yep. Absolutely try, but whether you either way, you can't be 100% right. Even I get it wrong. Yeah. Wee wee's about as far as I know. The rest of that French I know is not allowed. Yeah, exactly. So there's lots of ways you can try. Doing nothing is the worst. How's that? So yeah. Yeah. Well, if their perception of you is so bad, then maybe they could go and see a wellness advisor. I know one. Or a health coach. But wait, I've got a great person for you. Here you go, knock, knock, knock. There you go. That one's yours. I get Ariana, and I'm like, how can you get it right at the end of it, but not at the front? Yeah. Yeah. Actually, it's Greek. Oh, is it? Yeah. So, Ariana, it was Poseidon's sister. Yeah, but Māori adopted it earlier. So you got Ariana. Yeah. And then, but Māori have adopted the name as Ariana. And depending on which side of my family. Pardon? Adrian. And then Ariana. Ariana. Oh yeah, so depending on where I'm from. So if I'm from Maniapoto, I'm Ariana. If I'm from Wanganui, I'm Ariana. If you are someone who I consider a friend, I'm Ari. It is like the yeah. Yeah. And then if you're someone who has a hearing disability or you just don't want to call me by my real name, I'm Aria. Aria. Angel.
I wouldn't do much effort.
Yeah. So it just depends. But I don't get upset. My children. My daughter's boyfriend, he's American, and he wanted to impress us and had to be able to say her name, her whole name, which is not an easy feat. So even Marty, I am that mother. I sit them down, I give them a little tell you. If you can say her name properly, I'm impressed. So he learned for about a month before he came to me and said, Mum, I got it. And I went, what have you got? And he goes, her name is Utakota Kuruwai Mai Te Mamai Tanga Kōreranga. And I went, me, that's all right. You don't want to give them too much. You want to keep them on their toes. Yeah, absolutely. 4 daughters, I've got to make sure they're on their toes. Okay, our time is up. Hopefully you have got your answers to all your questions. Now just take into account that some of your questions may blend, so there might be more, less to kōrero about or to feedback about. So, can I have the kai kōrero, so your people who are giving the feedback, can I have you up here please, because it's easier to find you. Come on. Come on, there. It hates me. It hates me. Can.
I don't know why it does.
No. Back. Back. Okay. Oh, look at these fantastic looking people. These are your people. So can I have a round of applause, please, for these very brave people who are on your behalf? Brave. Oh, wow. You're that group. Awesome. So, what I need from you as our kai kōrero, as our speakers, is I need you to just give me which letter, so whether it's A, E, I, or U, and you'll be tested on that part, and then which heading. And then I'd like you to give feedback on your answers to the questions. Now take into account, these are your answers. These are not my answers. I've done this on purpose. Okay? Because it's not all about me unless you're in my house. Okay? Then it is. So this is all about you. We're going to start here.
We're a team. Oh my goodness. I've been speaking on this all day.
Are we doing? So we got A, tēnā ranga tērā tanga, which is that is looking at, thank you, sovereignty, kind of that, what words do we write down exactly? Equality, self-determination. It's looking at the kind of independence, being able to take control and leadership of your health, your waka. So it is that you are leading, you are determining where the waka goes, but we are paddling for you. Some examples. I was just saying that I had an example yesterday in our clinic with a 14-year-old Māori guy who had a really nasty cut to his leg, which the doctor sutured up. And I said to him, you're going to have to keep off this and rest it, not be weight bearing. And he looked at me and he's like, nah. And I kind of was like, he's not going to get any good outcome from this. He doesn't really care about wound care and getting this to heal well. But thankfully his nan was sitting next to him and she listened to me and she was then telling him what I was saying. So I kind of redirected a little bit and used her as well to try and help, because it's really hard, we were just talking about, it's really hard to get independence and people taking, that self-determining their care if they don't necessarily have the knowledge or the understanding of what's going to give a good outcome, and how do we project our knowledge of a good outcome onto them when they just don't really care. It means they can't play rugby, it means that they can't do what they would normally do. So I think it was kind of realising that there was a channel here through family to help with being able to support and encourage and help him realise the importance of how this was going to get a good outcome in the end. What we can see doing better. Do you want to do those ones? Sure. Have you got anything?
I've got these ones. Go for it. We had not taking it personally or getting offended, respecting people's beliefs and spending the time to actually educate our patients and understand what their kind of background is or the reasoning behind their views, and trying to kind of incorporate that into our care.
I think our last one was, once again, encouraging those you work with. We assumed that was colleagues. We're not sure if that's what it was, to get a better action. A lot of it's just education, I think. It's kind of helping people to see different perspectives and kind of working alongside each other to, kind of express maybe what the patient's saying and so that you can get that joint outcome in the end.
And call them out on their bullshit.
Thank you very much. I'd like it noted that last statement wasn't mine, okay? Usually is, but that wasn't mine.
Yeah, so in our team, we are letter E, so that's equity. So the first question, the principle of equity, which requires the Crown to commit achieving equitable health outcomes for Maori. So the first question, translate what your principle means in plain English. So basically it's achieving equal outcome in all aspects, like healthcare services and how you talk to the patients. Yeah, and what do you call this? So you, for example, if there's a patient talking to you in a different language and you don't understand them, you offer them an interpreter. So so that's achieving equity. Now for the second task, so what does that look like in your setting? So give 2 examples. So first example would be recalls that are prioritizing Pacific and Maori, and then quintile 5. And the second example would be ignoring stereotypes about patient care services. Like for example, we assume when someone comes in, we assume that they know about health education. Like we think that they have insight about this kind of procedure. So it's always best to not prejudge the patients that comes in our doors, in the clinics, in whatever background. Yeah. So number 3, what can you see yourself doing better to embrace your principle in your daily work process? So in our team, we have discussed that we have to address issues with equity. And if we have to reflect on biases, and as nurses, we can, put ourselves of the shoes of the patient. Like, for example, we have to empathize and you know, put ourselves in their situation. What if it's us who's in that kind of situation? And the last one would be encourage and support whānau coming into the clinic, which we have been doing already for years. So that's the third one. And the last one would be, how can you encourage those you work with to better action your principle? So first, education. So about equity, if you have a new staff coming in, so you know, you educate them if they're not aware about it, so increase awareness. And then also if you see someone doing deeds about equity, so you thank them, you recognize them, and then you appreciate them. And the other one would be for staff, like we have gatherings, like once a month gatherings. So yeah, that's all. Thank you.
We also had and our understanding was allowing Māori to make decisions on their healthcare with understanding, with some education. Sorry. And our two examples for that was we've got a GP nurse who's a Māori GP nurse, and she finds that when she asks the patients to come back for their smears or their vaccinations, that they believe in her and they're very happy for them to come back in. So basically having someone that they can identify with and they have faith in what they're saying and they can believe in them. And our other example was letting people make decisions on their own, giving them choices and options. So we in our clinic, for example, when often we have large Māori family groups come in and there's a long wait, we'll give them options. We'll say to them, you know, how far away do you live? Do you live around the block? You know, and if the patient isn't that unwell and has got a low triage score, we'll allow them to go home and we'll ring them to come back in time. Or we'll say, look, there's a park just around the corner, and we'll give them examples of where the park is. Or we've got a mall across the road, and we'll say, would you like to go and have a walk around or maybe get yourself a drink? So that they don't have to sit there in a large group in a tiny waiting room and wait, and just make life a little bit easier for them. Number 3, what we can see ourselves doing better. Our answer was being able to have more flexibility in our clinic to deliver our healthcare, and that may mean giving more staff so we've got the time to be more flexible, like instead of making an appointment, have a Saturday morning where people can come in and have their smears or their vaccinations, and you know, have a dressing clinic. But we can't do this with the resources that we've got now, so ideally we would like more resources. And how to encourage other people to believe in us, and we just think that we would like people to actually sit back and listen to what our Māori patients are actually saying and just hear what they're saying so that we can actually make changes. Okay, that's us in a nutshell. Thank you.
So ours one is O easy for option. So every day we got say like choices. So same apply in our clinic. It is an accident and medical center. We always give options to our patients if possible. So once they step into the say like clinic, they can choose which doctor they want to see. But we need to give some information to them. Certain doctor may need to wait for a long time or whatever. So same give them option. They can choose what say like medical treatment they want to choose, or say like under the condition that we give some background knowledge for them. For example, if one patient's come for high cholesterol issues, after the doctors say like explain what's the daily life, say like lifestyle, diet or exercise, all this background information has been explained. And then the cholesterol level is high, so doctors may prescribe some Western medicine to them. But finally, patients still believe that, oh, I think herbal medicine may be better for my condition. So doctor may say like for us or doctors still would need to tell them, say like, what's the potential risks of it. So if you go for it, better to have regular review before you go for it. Same, we give them options and choice. So people will know pro and cons. And then for number 2, another example is, say like, when patients turn up at 10 p.m. for, say like, 1 week, maybe upper respiratory tract problem, cold and runny nose, but prefer to come at 10 p.m., okay? So, but we still got, say like, maybe 10 or a dozen patients waiting for one doctor. So what we do is, say like, because say like you're sick for so long, I would check your vital first. If your vital is not that good, of course, you can stay and check, say like, examine or say like treat by our doctors. But if the vital is, say like quite normal, you got 2 options. Number 1, if the vital is fine, you can say like come back tomorrow. We try our best to arrange, say like not necessary to be an appointment. Maybe when you come, we put down your name. So same, say like wait for the doctor, maybe not that long. Number 2 options, say like if you feel worse tonight, you can go to Middlemore. Because at that time, doctors still got long queue. If you wait, it can be, say like maybe until 1 a.m. or whatever. So give them choice. Of course, for us, we need to explain to them before they go home some tips how to improve their condition. Say like if just common cold or whatever, say like ask them the most important things that you need to have a good rest before, say like good rest rather than wait here with so many patients that got similar conditions. Fluid or whatever. So some tips for them. So when they go home, they feel more comfortable. So that's very actual example. Anyway, I go through with it for many times. And then, so task 3 is, say like, how can we do it better? So options. When you give option to patients, I think we need to think about in a few ways. Need to be attitude-wise, should be non-judgmental, because say like can't say that if you choose Chinese say like herbal medicine, you may say like maybe 1 week later you may come back because it's definitely not help. So I think the attitude should be say like helpful, non-judgmental, or say like welcome for their options, but make sure they need regular review. So also respect their choice. Yes, mainly say like surrounding one word, I think attitude. And then number 4, task 4 is how to improve it, is how to improve ourselves or with our colleagues. Is I think on and off we need to discuss with the colleagues, maybe simply, and morning 5 minutes huddles. Oh, they already remind me, don't say cuddle, but I still forgot. I'm very nervous anyway. Anyway, huddle. So we can say like talk about some issue may arise within the clinic, so everyone will know rather than I just talk to you, so only 2 of us knows. So huddles, and also say like on and off evaluation, maybe charge nurse or senior nurse may say like on and off discuss. And of course, education makes you know more. You can give better option for patients. I think that's it. Thank you.
Our letter was I, And it talks about active protection, the principle of active protection, which requires the Crown to act to the fullest extent to achieve equitable health outcomes for Māori. So we were talking about, equitable health, active protection, having information on their worldview, equal access to service, thinking about their values, not making assumptions about what they need, actually asking them what they need for their health service delivery and not making assumptions about how that should be done. Task 2. What does it look like in real life? Well, we like to think that I have a warm welcome when they come into our clinic, that we are open to questions, that we involve whānau and not make assumptions about what we think they need. Find out what's important to them and their whānau. Know what services are available in our community and know what things perhaps that are not doing so well in our community. I don't know what I meant by that. Informing them what's available in the community, broadening our assessment to include other things like we were talking about before. If they come in for a sore throat, checking their teeth out, referring them on, grabbing the opportunity to check that their immunisations are up to date and that their auntie's here and actually needs a smear, so we'll organise that for her. So just taking the opportunity and keeping the door open, making it a place they want to come back to. Task 3. What can you see yourself doing better? Well, we talked about the use of...
improving our use of te reo. We get really good responses when we use or even attempt to use te reo with our children and with their parents. In all our rooms, we have, our triage rooms at least, we have a lot of very simple words. And even if I go, oh, and I look at the word and I come back and I say it to the child and they just come alive. And I think that's something that we can all improve on. And it was really about, checking our own bias. I think making our clinics a safe place to come to, building those relationships with our community so people know that they are very welcome. And sometimes if people aren't coping, and this is across the board, really sort of fast-tracking people through our clinic if there's some other barriers to being there. Is that pretty much it? And task 4, in terms of spreading that through our team, I think role modelling is always the first port of call, right? I think also, I've just come to me, we talk about health and safety at our staff meetings and our management meetings. I think we should talk about, also have a little section where every month we talk about how we're doing in terms of equity, health equity and outcomes, how we're going. Just hearing the team, what's been going on over the last month and encouraging staff to be comfortable talking about these things and listening to each other. I think that's a really important thing. Yeah, just opening dialogue, always good.
R1 was also I, and it's exactly what they said, so that's my piece. No. Okay. Kia ora everyone. My name is El. Ako po ay isang Pilipino. Dumating po ako dito noong 2009 and nagabuak ijay nga to ti Pilipinas. So I just said my name is El and I arrived in New Zealand from the Philippines in 2009 and I've been practicing as a nurse since. I am representing our brilliant group here, and I'd just like to mention their names because there's only a few of us. There's Sandra, Giselle, and Tracy. And R1 is also, as I said, from letter I, that's active protection. And so we thought, who's the people involved in active protection? Well, the crown here is us as clinicians. And then who are we protecting? It's the Maori people. And we put it down as what this means for us is about engagement with the Maori people and having proactive measures. So it extends beyond mere protection. It's us engaging with them and connecting with them. And number two, what does that look like in our setting? We've given a few examples here, and even just asking how their names are properly pronounced, and obviously doing that properly or appropriately or correctly, and utilizing resources around us like wellness advisors and health coaches. Even doing screening and making sure, as our colleagues have mentioned, that they get information and they get offered immunizations or screening for CVD risks and that. Or even at a higher level, you've heard my name mentioned about the CQIs, and if you're intending to do advanced studies in the future, definitely recommend that because you will need it. And those CQIs tend to address issues of equity. Number three, what can you see, what can we do better? We talked about, and our colleagues have mentioned it as well, not imposing our own judgments. We talked about cultural safety, being aware of our personal bias. And in the course of my training this year, I remember this example from a general practitioner whom he realized he doesn't prescribe, for example, statin therapy for a Maori patient because he's thinking he's probably not going to take it anyway. So it's being awareness of those implicit biases that we have as clinicians, and understanding that we come from different cultures, just not making assumptions. And this next one is closely tied to number three, is how can we encourage that in our workplace? And we talked about talking about these things with our colleagues, having positive talks, role modeling it, and maybe even have, as you said, huddles and having meetings and being inclusive in those meetings and including our other colleagues in the team. And if they've missed out, maybe somebody can make notes and post it on the note board so they know what's being talked about.
Hello, everybody. I'm Shruti. I'm one of the community iron prescribers out in West. So our topic is equity. The alphabet is E. So the first task is, what is it in the simplified English? So equity, as per our group we discussed, is creating more opportunities to achieve the desired health outcomes for the people who are in more need of it. For example, if a person needs health support in case of medication, health education, providing it at the best level of understanding to their level, keeping in mind the health literacy, keeping in mind the resources they are having. So simplify, if I do simplified language, it is creating more opportunities for the people who are in more need to achieve desired health outcomes. So second task for us is, what does it look like in your setting? I guess it is very good, but we still have to achieve the ideal situation. So we still doing, I can think of two examples here. Recently in May, we arranged a Wahine Health Day. It was on a Saturday. So in West Auckland, we 5 or 6 nurses, including somebody from the DHP as well, they came, and we offered cervical smears, immunizations, HPV immunizations particularly were more reinforced to all the people out there in West. So I really, really appreciate the effort of all the nurses who presented on a weekend on that day to give their services at best. So the second example I could think about is, we recently participated in the CQI project for HPV, promoting immunization for those who are 9 to 14 age group, and Maori Pacifica particularly. So achieving equitable outcomes, because why particularly Maori Pacifica? Because they were the group who were having the least outcomes of immunization among that age group. So we promoted Maori Pacifica by actually giving them health educations, talking them, peer reviews, discussion among us, how can we improve it. And if a patient is coming, also for their reason, some health issue, we asking if they need any immunization among their family, anybody who is 9 to 14, encouraging the person or the patient to bring their own whānau to get the immunizations done. So that was really good. I guess those 2 examples, they fit in this task 2. Task 3, what can you see yourself doing better to embrace your principle? I guess here, the health education plus training the staff is very important, because engaging the services from practitioners, they not only the general practitioners, but nurse practitioners and RN prescribers to make most use out of them. So for example, if there are 50 people standing out waiting for their appointment, we can actually use the resources like nurse prescribers, encourage them to see more and more patients as they can, and increase the outcomes for the patient, health outcomes for the patients. So I guess making the most use out of the available resources. Task 4, how can you encourage those you work with to better action your principle? I think I would reiterate what Alice said. So encouraging those having day-to-day basic, these small discussions with your peer group, how can we make things better? What did not work yesterday? What can we do to make it better today? So simple discussion every day, 5 minutes in the beginning of the shift, I think can make a big difference here. Yeah, that's it. Thank you with me.
Right, so we got letter U, which is partnership. So in our group, we discussed that partnership must, it means we must work equally between both the parties. So our points were like work together and bring in and involve everybody who's in the room for the service delivery. For example, including clinician, patient, whānau, and the nurses all together. The second question, how does it look like in our setting? We have signage in different languages. Translation services are available. Also, we use informed consents with patients and families, pamphlets. Yeah, third question is what can you see yourself doing better? Being advocate of the patients, educating staff for cultural safety and stuff in future. Sorry, I'm just reading what was written by my team. Number 4, how can you encourage those? So lead by example, use language more, learn pronunciation. If you can't speak, you still speak, even if you get corrected by others. So that's all. Thank you.
Hi, my name is Christy, and our group, we got O for option. So it's option is for the Crown to provide properly resource kaupapa to Maori health and disability services. So to translate it to plain English would be a fully informed and provide options to patient. And number 2, I can give you 2 examples in my clinical setting. One of them is just like when patient calling or turning up to book for a GP appointment, depending on the patient availability time, then they can have the option with the GP that they would like to see, or if they have any woman health, that we have a female GP to help with them. The other option is for a person that would have a high lipid blood result. After we inform them about the result and the option for starting on lipid lowering treatment, they have the choice if they would like to be treated with pharmacologically or have a healthy diet and exercise, so they can have an option to choose not to be treated with medication. So number 3, what can we see ourselves in doing a better in embracing the principle in our daily work? We can listening to the patient to understand them more. We can use easy language to provide the information. We making the time to the patient using cultural safety. Provide access to Maori Ronga. Did I say that right? Sorry. Maori Rongoa. Yes. And Whakapanau Ngatanga. Yeah. Making connection. Yep. So number 4, how we can encourage those work with, to make a better action. And your principle is mean we keep learning it from day to day, or some have events like this, study day, conference, and actively participate. What else do we have? Supporting each other for a learning.
And it's more like normalizing it in our daily practice, not making it specific, like, we're going to do it today. So it's normalizing our everyday daily practice.
Thank you. Well done. Thank you. So just look around at your table. Thank your colleagues, because that kōrero came from you. So well done, all of you. Thank you so much. Now, you can hug it out later. Okay, you can have a group cuddle. I like that concept, except for when I'm having bad days, don't touch me. Okay, so you only concentrated on one principle. Okay, and look how much you learned with that one principle. Okay, if we had the time, so if this was a 5-day conference, I could come back every day and we could do a different principle each day. But obviously that's not realistic. So, where does Te Tiriti o Waitangi fit into equitable outcomes? Because that's basically what we're looking at, isn't it? Equitable outcomes. That is our job, that everyone gets quality health care, no matter who they are. But where does Te Tiriti o Waitangi fit into that? So, te tiro whakamua ki te tiro whakamuri ki te haere whakamua. We must look to the past to move forward. The reason we do that is that we don't repeat our past mistakes. Because we're all human, sometimes we're not perfect. Okay? In fact, sometimes we're imperfectly perfect, if that makes sense. An example, I am constantly, far from being perfect, constantly pulling my foot out of my mouth to put the other one in. Never been known as the most PC of people. But I try not to repeat my mistakes. If we make a mistake, own it. It's in the past. Learn from it. Moving forward. Better equitable outcomes happen when we adopt better equitable behaviours. When we become better practitioners, clinical or otherwise, we, by consequence, get better equitable outcomes. When we form long-term relationships with our whaiora, with our patients, with each other, it already increases the equitable outcomes. Trusting patients are more likely to come back to you before they need an ambulance. As nurses, You are their first clinical contact. And you make a huge difference on not only how their day goes, but how their life goes, how they see the health system, how they see people of your ethnicity, how they see your gender. You hold so much in that one interaction. If it goes negatively, you put them in a space of risk. Everyone has a bad day. Sometimes we have to just smile and wave just to get through the day. Or, if needed, tap out and get someone else to cover you. When we're having a bad day, we need to make sure that it doesn't affect our whānau. Take into account, if it was your aunt, your favourite aunt, or your favourite uncle, or your favourite koro, or your favourite nanny who was standing in front of you, how would you like them to be treated? Because when it breaks down the family. You are our change. Cultural confidence versus cultural competence. Look at those definitions. Culture is defined so many ways. The things that change are the confidence versus competence. Confident people do not judge. Confident people do not withdraw. Confident people do not make things about them. Competent people have a finish line. It is a tick box. I am competent because I can do this, 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 this. Are we heading towards cultural competence or cultural confidence? Which provides a better practice for those we serve? Becoming a mana enhancing practitioner. Just yell out, what's mana? Essence, respect, empowering, everything. Mana is what makes you you. Mana is your awesomeness, it's your stardom, it's your skill, it is your whakapapa, it is your upbringing. I don't stand here as just me. You've already seen I stand here as a mother of 10. I stand here as a partner. I stand here as 1 in 7 siblings. I stand here as a representative of my tupuna. That's a lot to hold for mana. And I know that I'm cuddly, but still a lot to hold within one person. Okay? Everyone holds mana. Every single person, no matter where you come from, what you come from, and where you're going. Okay? So if you need to ask yourself, as a practitioner, am I giving the person that I am interacting with, be it staff member, kaimahi, or whaiora, am I giving them an experience that uplifts their mana? And you can see it in their face. No matter how they come to you, you have the choice to make it a mana-enhancing interaction. If you are not doing that, you are mana-diminishing. There is no in-between. If your interaction is not mana-enhancing, then your interaction is mana-diminishing. And as a person, you need to ask yourself, who am I to do that? This is not what I want for my nanny. This is not what I want for my mokopuna. I want us all to be mana enhancing. Here is the other thing, and this might mean, this is a bit of a thing one. If you are in a interaction with a staff member and they are yelling at you, they are devaluing you, you feel little, the mana diminishing part of that process is on them, not you. You can still hold your mana while someone tries to take it from you. You cannot give another person mana when you don't have it yourself. Okay? So try and make every interaction you have, and some days it's harder than others, as mana enhancing as possible. No matter who you're dealing with, whether it's a 2-year-old, a 20-year-old, or a 70-year-old. Make that process very mana enhancing. A challenge. This is the last part, my last slide. One of the best questions I ever heard, and I took it to heart, was by Moana Maniapoto. She asked a panel of guest speakers at the Equalised State of Play event here in Auckland. Did anyone go to that? It had Jacinda Ardern, Ruby Tui, Natalie Portman, and Fatma, who was the treasurer, I think, of the Football World Cup. And her one, and my whittle or my challenge to you is, how are you going to be a great ancestor for your future mokopuna? How are you going to be a great ancestor for your mokopuna? What point of difference are you going to make? Nō reira, tēnā koutou, kia ora koutou katoa. Thank you.
That's just a side note. If you don't want to present next year, you get nice gifts. Thank you. That's all right. Amazing. We've just got one more presentation and then we'll break for lunch. Sure. I feel like I've got your presentation as a PDF for some reason.
Okay.
That's strange.
Doesn't matter, does it? Does it matter?
No, I'm just wondering if we can. I wonder if we can make it like full-ish. Oh, I guess that's the.
That'll be it.
Do you need help? Perfect, guys. So I've got Mikhail Noonan, who's going to be presenting common presentations in children and adolescents.
Hi, kia ora, ko Mikhail tēnei. Can I get everyone to stand up? Because I'm talking about children and youth, so stand up, everyone. And I want you just to wiggle your bottom, just to move around a bit. Cool. Now I want you to turn to the person beside you and tell them what your maybe nickname was as a child within your house or home or with your friends. Okay, cool. Okay, guys, you could whistle. Okay, now we can sit down. Okay, so I did some learning objectives. You know, my academic part, I thought I should kind of look vaguely academic. So this is the academic bit. So identify common pediatric and adolescent presentations and awareness of differential diagnosis. So this is obviously quite a quick kind of thing. There's definitely going to be stuff that I haven't covered for you, but these are just kind of the really common things. So I'm just going to tell you a bit about me. So I am Mikkel, and I've got a background in paediatric ICU. Overseas, I worked in New York and back in Starship, and I came back to New Zealand and did community-based home care at Kids First, and also then went back and worked in a paediatric cardiac team in Guatemala. Did four years back and forth doing that, which was amazing. And so I qualified, tell me when I qualified? I qualified in 2010 as a nurse practitioner. I was number 80, which is kind of exciting because we're up to about almost close to 800, and I believe we have a nurse practitioner intern here, which is very exciting. Good luck for your panel. So I started off in primary care in a general practice, just seeing kids, and it was fantastic. But I kind of got to the realization that actually I wasn't providing great kind of equity and access, because I would see children up to the age of 18, but in fact I wasn't seeing mums. And it was a bit of a barrier, really, because they'd come in and they'd kind of ask questions, and I was like, you're over 18, I can't do it. So I decided that actually, you know, to really encourage equity and access, I needed to actually expand my skills. So I expanded to lifespan, which has been fantastic. It was a bit of a learning curve. So I, in 2020, in January, I started the first greenfield, so I started from scratch with no patients, a practice in Glen Innes. It's a nurse practitioner owned and run practice, and I am currently just by myself. I've had a couple of nurse practitioners with me, and they've kind of moved on, and I'm about to get, I'm hoping, a brand new nurse practitioner who's going to panel shortly, and I have enrolled nurses. And it's been really interesting and really challenging. So it's kind of cool to be in front of a room of nurses, because nurses rock, and we truly are the new kind of healthcare. Like, people need to stand up, we need to be really vocal, and we need to show our place in healthcare, because we do it every day, and we do at the lion's share of it. So kudos to all of you, and big claps. Thank you. I also do clinics in high schools in South Auckland. I do that once a week, and I'm starting next year to do some clinics in intermediate schools. So kind of still do quite a lot of child and youth stuff, which is really cool. And I'm currently on, which is really interesting, I'm the independent on the Te Whatu Ora subcommittee for primary care, population health and hospital special services, which is actually really nice to have a nurse. I'm the nursing voice, which is really good. And I've just got onto an editorial board for an American journal of Pediatric Healthcare, which is also interesting, but I hope they don't ask me to write anything. Okay, so I support nurse practitioner interns. I've had 5 through my practice this year, which has been really interesting. So I also have been supporting some nurse prescribers. So I'd really encourage people to really think about doing the nurse practitioner training, because we really need more of you, and I think that we are part of the solution for New Zealand's healthcare. Okay, so this is, I kind of believe that most of you don't do a lot of kids, is that right? Does anyone do lots of kids? Awesome, so kind of maybe a third. Okay, so, hold on, did I go? Yeah, so this one is the systematic approach initial assessment. We all do it with adults really well. So we kind of see them in the waiting room, we kind of get an idea of their colour, what they look like, are they comfortable, what are they breathing like, kind of what's their interaction with someone else. So really important. important to do that with kids as well. Like, are they playing? Are they, because often by the time you go out to get them, suddenly that kind of playing child or watching something on the phone has gone and they're kind of like, ugh. So it's really important to do that initial look. So a parent's general impression and work of breathing, which actually you can see, and circulation to skin. So what do they, like what colour are they? So really kind of start ingraining, because you do it all the time with adults, like we do it automatically, so really start kind of really thinking also with kids. And it's the same with often, you know, when you see a child maybe who's coming in with, you know, the irritable hip or something like that, or a sore leg or something, just seeing what they walk like. Like I often like kind of really gun it up to my room and then kind of stand back and look at them coming in, because that makes quite a difference. Because, you know, sometimes you'll find that the child actually walks fine, but the parent or the caregiver with them is really concerned about it, which is great, but maybe it isn't there all the time. It's really important to have some concept of stages of development. So I'd really encourage people who maybe aren't so au fait with kids to actually have this somewhere, just to kind of have some knowledge of what is normal for age, because that does make a difference with what you're seeing. So, you know, sometimes, for example, you might have, I mean, I've seen a parent who's come in who said to me that they're like kind of a year, like, I don't know, 14-month-old child was now not toilet trained. Well, actually, that's not that normal to have a 14-month-old boy toilet trained at that age. So it's really good. So essentially, they kind of had some toileting system working for them, which was fantastic, but now it was changed. So it's really important to know the stages of development. What are you doing? Okay. Oh, okay. Never mind. Okay. Next one. Okay, so ears are really common. Like we see well, everyone's got them obviously, so they are really common. But we see so many children coming in with ear problems. And so, a few questions. So what does everyone think this is? So who thinks it's a normal tympanic membrane? Okay. Who thinks it might be acute otitis media? Who thinks it's a otitis media with effusion? And who thinks it's eustachian tube dysfunction? Okay, so it is actually, so this is a child who is about an 8-month-old. They've come in with pain, and mum has talked about tugging of the ears. So the questions that you really need to ask are, how long has it gone on for? Have they had any medication, paracetamol, or anything over the counter, or anything that was left at home, like any other antibiotics that maybe they hadn't completed? Like, that's really quite important to ask. And obviously allergies. And then also eating, drinking and output, to check what that is. So in fact, that actually is, as most of you who quietly put up your hands just in front of you, it actually is acute otitis media with effusion. And I don't know how many of you are looking at ears, but I can remember when I first started, I was like, I can't see an ear, they all look the same. My advice to you is, if you want to get good at it, look at every single ear that comes in, whether it's a 2-week-old or a 105. Just look at all the ears, because they look really different. And I think in some ways, some people's ears are just easier to look in, but just look in them all. I used to, we moved with our family to Vietnam for 3 years, and I worked there, and I was amazed. Like, Vietnamese ears seem really easy to look in, and that might just be gross generalisation, but it's really interesting, and I don't know whether there is a cultural component. So, look in ears. So with the ears and kind of anything else, it's also really, this is a really good record to have somewhere in your practice. You know what's normal paediatric vital signs, because often we kind of forget what they are depending on the age. I have to say, I really don't do blood pressures too often on kids. Occasionally I will do them. The group that probably paediatric-wise has the most blood pressures done on them are actually our ADHD kids because they need it for their Ritalin. But on the whole, I don't, and I've used to at Starship be the educator for peds cardiology, and we still don't actually do a lot. All right, so don't stress about the BP because often it is quite difficult to get a child to sit, but the other stuff really know it and know it well. So with the ears, there's 90% of children will have had an ear infection within their first 5 years of life. So it's really common. And a lot of it is around education. So it's education and health literacy for families. So really encouraging you to talk to families about what they look like and what they need to do, and also the things that we can do to prevent ear infections. So some of the things that we can do to prevent ear infections are encouraging breastfeeding for as long as possible, not secondhand smoke is a real risk factor for ear infections, so really encouraging people not to be smoking around children, and more than not smoking around children, actually not smoking, because many families will say, but I smoke outside, and that's fabulous, but actually it's still on your hair and it's still on your skin. So in fact, the secondhand smoke is still being received by the child. And if you remember the slide before, or this slide, if you can see, a child is breathing 2 or 3 times what we're breathing, so there's that much more exposure. So it's really important to really encourage people to take their child's health and kind of maybe almost kind of reframe about why it would be a really good thing to stop smoking. Okay. The other one is, there was something I found really interesting, that after the age of 1, if you have a child who is using a dummy and bottle feeding, they also have, it's kind of the dummy and bottle feeding, they also have a higher risk of ear infections. So just also encouraging families not to prop children up with the bottle in the corner of the couch or anything like that, because that also can encourage ear infections. Okay. And the tugging on the ear, we often hear that children have been pulling on the ears, and pulling on the ears sometimes can actually be, with little babies, they've actually discovered their ears, and it can actually just feel good, but sometimes it actually is, they're pulling on the ears because they're trying to get the eustachian tube to kind of change position a bit to see if that might help with the pain. I mean, I'm not quite sure how you'd know which one it is, but just know that that's 2 kind of things out there. All right. The other thing that we see a lot of is eye infections. I don't think I've got a picture of the eye. No, I haven't. Hold on. So eye infections, so conjunctivitis, really common, and it's often kind of nose eye or mouth eye as the infection cause. There's not a lot we do for it. Obviously, in small children, we just treat it. Sorry. And we don't actually decide, we don't work out whether it's bacterial or viral. It just gets treated with medication, either drops or cream. The key with the drops is they're really difficult to put on babies, as many of you will know. The easiest way to do it is to just put it just on the corner of the eye, and then the infant or child will blink, and then the eye drops go in. That's the much easier way. Otherwise, you end up getting a screaming child, a stressed parent, and just sweaty hands. All right, so that's kind of a little trick. So with ear infections, the guidelines say that if they're febrile and upset and kind of in pain, to treat. It's really worth looking at the tympanic membranes, because often some of these kids aren't particularly upset, but they're really red, angry, bulging eardrums. We don't want those eardrums to burst. So I particularly will, on a Friday, would treat ear infections, because actually I don't want them to burst, and I also am trying not to give you guys in urgent care more work. All right, so just kind of thinking about, and the situation, also just the situation, do they have access to a car, do they have access to a phone, what is there for that child and family to be able to encourage this child's well-being. Okay, so I'm hoping this is going to work. This is just a breathing. We'll see. This might be a little bit. So this is just a breathing video. Like, I just wanted you to hear it. So we'll wait and see if it's going to work. So the other thing that we see huge amounts of is cough. So cough is, cough is probably kind of after ears is probably the next most common thing I see. And it's whether it's kind of cough for, so the same. How long have they had the cough for? Is it keeping them awake at night? When is the time that you notice it most often and most frequently? And of course, what does it sound like? So don't worry, if it's not working, it's fine. I can talk. So it is the leading reason that we see people in primary care. So the differential diagnoses for cough, of course, is pneumonia, croup, epiglottitis, although we don't see as much of that anymore, which is fantastic. And asthma and bronchiolitis are the most common ones. So it really is just thinking about what the cough sounds like and also what the child looks like. So you're looking at, in an infant, the anterior fontanelle, whether that's flat and soft or sunken. So with the infant, are they nasal flaring, head bobbing, tracheal tug, and indrawing in the ribs? And those are really good skills to actually teach the parent, because that's fine, don't worry. Those are really good skills just to make sure, because that's, we want to be able to enable parents to be able to look after their children really well, and some of it is around actually us providing education there for confidence, and also I often will, not really, it sounds a bit demeaning, but kind of congratulating parents, because one, I don't think that we encourage parents enough that they're doing a beautiful job with their children. Like, as a parent, you don't get a lot of positive feedback. So I think it's, if we have a parent who's brought a child in, it's, I think it's really good to give some positive feedback saying you're doing a really good job. And also just looking at their mouth and like how moist is their mouth, because often they'll say they haven't drunken, but actually you look in their mouth and their mouth looks great and they're dribbling, perfect. So, so there's a lot of education I do around any of the cough or breathing things. Asthma's not diagnosed under the age of 2, even though you might think it, but we don't diagnose under the age of 2. If we are doing something kind of with asthma or an exercise-induced wheeze, which we see quite a lot. So exercise-induced wheeze is kids who might run around and then get really wheezy. So it's not asthma, it's just around maybe either exercise or a virus-induced wheeze, so it'll just be a short term. Please make sure that you show parents and demonstrate parents and get them to demonstrate back to you how to use a spacer and the inhaler while they're with you. It's really important. And also using the resources that we have. So we've got Auckland Health Pathways and Asthma Auckland. They both have care plans for home, which I would really encourage you to print out, go through it with a parent and write the child's name on and what we're giving. Asthma Auckland also does, for the asthmatic children, they will do home visits, and I highly recommend that we access that, because it's fantastic for a family to be able to have that knowledge given within their own home, because they're able to get a lot more, so one, to hear and also to retain a lot more information in the home than they are in a healthcare setting. Okay. Bronchiolitis, of course, we're still in bronchiolitis season, it feels like. So bronchiolitis is those kind of 6 months, even up to 1 year old that comes in coughing. They sound absolutely terrible. You know why the parent's there. They often have white ring kind of ribbons from their nose. That's and it's quite a wet sounding cough. There is nothing to do for those children. It is purely supportive care. So it's really important to teach parents what they're looking for. On the Auckland Health Pathways, at the bottom of it, under the Starship site, under bronchiolitis, there's some really good parent handouts, and I would really encourage you to print those out and give them to the parent. And just to really explain, when would you want to see that child back, or when would you want that whānau to take this child to hospital? So really quite concrete, like if they're not having wet nappies, they're taking less than, kind of half of what they normally do, they're sucking in their ribs, they're nasal flaring, if they're little babies, they're doing the head bobbing, those are warning signs, okay? So those are the things that we're really looking for. In New Zealand, unfortunately, every year we do have some asthma deaths every year. So really encouraging people to come back after, for example, if they've had an inhaler, that we see them every 2 to 3 weeks. I also think it's a good idea to put it as a recall at 3 months to make sure that these children have still got their inhalers ongoing. Okay. Oh, there. Sorry. Thank you. Okay, so this is just a presentation of a child, of an infant. So coryzal symptoms, signs of respiratory distress, dyspnea, tachypnea. So you're going to know this because you have used the little thing that tells you what the normal is for this age range. Okay, poor feeding, mild fever under 39. Some apneas, wheezes and crackles. So this is a child that you might be considering that you might need to send into hospital if they truly look like this. But kind of have a look at have a look and see. And it's also just making sure that we ask things like, do you have a car? Do you have access to a car? So that, it's all very well, because there's often families who might have access to a car, but actually there is no petrol in the car, or the car, in fact, is not at the home during the day because someone's using it. So really just asking, this is about access, this is about equity. We need to really make sure that we're providing wraparound kind of thoughts about what we're going to do with this child, okay? This is really hard to see, sorry guys. So this is asthma, so I can't even read it myself. So it's kind of looking at, and this is from somewhere really bright. So this is from kind of the asthma pathway. So it's just about, is it a typical asthma? Is it atypical? And just kind of really telling you kind of how often you're going to see this child and follow up. But I really encourage every child who leaves your practice with an inhaler needs an asthma action plan. That really should just be basic care. And I know for many of you it probably is, but it actually in primary care isn't as frequent as we should be doing it. Oh, and another one you can't see. So this is just about assessing severity. These are really, Waitemata DHB did some really best care bundles, and this is kind of one of the outcomes of these best care bundles. So it's actually really good. Sometimes I think it's, like you see these children, they look really terrible, but actually when you stop and count do their temperatures and count respiratory rate, actually it's not as bad as you think, or it's actually worse. So this is quite a good thing because you can see whether it's mild, moderate, severe. We're not doing life-threatening, but let's just do mild or moderate. So it's kind of what their SATs are, what their respiratory rate is, and what they're looking like. And sometimes it's quite nice to have kind of like a guideline or a checklist to go by because it can get quite stressful. So I would really encourage kind of the use of these tools. So this is the asthma action plan, in case you haven't seen it, but most of you have. There's a few different ones around, but kind of doesn't really matter which one, just use one, okay? Okay, skin. We see a lot of skin as well, and I find skin quite difficult, really, because it never looks like what it does in the book. Like you've kind of learnt the stuff. So DermNet is my friend, and so having a look, I don't know how the light-wise, but having a look at some of these pictures, kind of looking at what you think these could be. So does anyone have any idea what the one on the left might be? What's that? No, not meningitis. No. It's probably more like, I mean, I did do it, but now I did it so long I can't remember what it was. But I think it could be, chickenpox. Yeah, chickenpox is a really, I actually don't see as much chickenpox. And I'm not sure it's because there's not as much around, or is it because parents are actually that much more educated and know that there's nothing we do? What's that? Yeah, that's true. But still, some of those older kids haven't been vaccinated, and you still think, but yeah, you're right, it is vaccination. Yeah, and the next one, I think, the next one is kind of some kind of eczema with scratch marks, which is really common. So kind of scratch marks or dermographism, so those kids that come in that have got interesting skin and you scratch it and the scratch remains for a while. And then the final one is just an erythema from who knows what cause. So they're all really different. I mean, the main thing is that we undress a child who we're concerned about meningitis. We undress them and we look in every nook and cranny to make sure that there is nothing there. We're definitely, I haven't seen, touch wood, a meningitis for several years now, which is fantastic. And now that we're vaccinating pretty much everybody under 5, it will be less and less. So really important to encourage vaccinations, as an aside, for all of our children, and doing the catch-ups for Bexsero. So this one is, okay, what's the middle one's really easy to see. What's the middle one? What's that? Impetigo, yeah. School sores are impetigo. It's the yellow crusty bit is kind of the main thing. And I think, from what I can tell, the one on the right, on your right, is a early kind of boily type thing, abscess boil, and the feet is hand, foot and mouth, or Coxsackie virus. I've also got, and I'm sure lots of you got that, there's a lovely poster that's got all of the childhood things and when they are infectious and when they're not infectious and all of those kinds of things. That's also a really good thing to have up. One, to remind you, because sometimes there is stuff like this we forget, but also it's quite good to actually show parents. I often will pull up DermNet and go through those pictures with parents to say, doesn't look like this, but this is what I think it is. A lot of the time with skin, I do exclusion. So I go through what it's not, what I definitely know it's not, because often we were talking, you talked about it in your last kind of, in the last talk about, one, it's expectations. We need to manage whānau expectations, but also just listening. Like sometimes I say to people, what are you concerned about? Like, what do you think it could be? Because if I don't address that issue, they're still going to walk away and think, oh, she's not very good. She doesn't know what I'm worried about. So I often will say, what actually is it that you're concerned about? And sometimes you're like, okay, look, it absolutely isn't this. Or sometimes you're like, oh, okay, actually you're right. That's a really good thing to think about, but it's less likely because of, or actually it is. You're completely right. You've got it on one. Well done, whānau, on this one. So really important. But I think it just shows you just how different skin is. In the respect, it just looks so different in so many different people. So the one on the right, what does everyone think that one is? Huh? Yeah, ringworm. Really, and it seems to, I seem to have seen a few kids recently who state they've had no exposure to animals or older children, and in fact infants with ringworm. Unsure where they're getting it from, but it's easy to treat. It's not life-threatening, so that's kind of cool. Okay, so the big thing, of course, is kind of medication-wise, asking families, have the infant or child had medications? Any that have been prescribed or not prescribed to that particular child, any over-the-counter, any kind of family or herbal remedies. And there's nothing wrong with them, but we just need to know what they are and what people have been using. When I worked in New York City, we had a child that was incredibly unwell and ended up in our ICU with some kind of toxicology type stuff in the end, and we had absolutely no idea what it was. And I think times have thankfully changed. I think healthcare on the whole is a bit more interested and open to people doing different things. And in fact, it was some herbal medicine that the family had got, and it, in fact, they were a lovely Chinese family, and they'd imported it from China. And I'm sure it was probably fine for Granny, but it wasn't for the 6-month-old. So. Okay, the other kind of big area is mental health. So this is through the eyes of adolescents, and I actually think it's a really cool picture because I think it describes the chaos for many of our young people these days, and just how it's really complicated and there's just so much going on. And I do see a reasonable amount of mental health. The other way that mental health often presents is abdominal pain. So we see quite a bit of abdominal pain, and often that can be functional abdominal pain, which it could just be functional, so that's around constipation or toileting. Obviously it could be in some of our child and adolescents, it also could be appendicitis. So that's why, for example, really checking out what that young person is doing, kind of walking, are they standing, are these children eating, have they lost weight, all kinds of, like doing the tests like the psoas, where you get them to push up their knee, and then the obturator one, where you pull their knee over to see if there's any pain. Those are really quite definitive, and obviously temperature. So that's kind of the abdominal pain that kind of goes with mental health, often, not all the time. Or that could actually just be an appendicitis in that regard. So mental health, we're definitely seeing a lot more young people and adults diagnosed with ADHD, and being neurodiverse and gender dysphoria, which unfortunately also comes with some degree of mental health. So it's really important to do HEADS assessment. Do people who are seeing young people do HEADS assessments? So HEADS is pretty easy to do. So H is home, E is education or training. So are they in school or are they in training, like are they doing a course or alt ed or something else? A is activities, kind of what are they interested in, what do they do? Also ask what did they used to do, that's quite a good one. D is drugs and alcohol. Please ask about vaping. I'm really upset, one, with what New Zealand's done with vaping, but two, how many young people I see who never smoked cigarettes but are now vaping. The other thing with vaping, which I learnt this week, you guys might already know this, but vaping is really bad for gum disease. Vaping and gum disease are going to be really connected, and we're going to see probably in the next 20 years a huge amount of people with gum disease because of vaping. It decreases blood flow to the gums. And kind of on that dental thing, please make sure that you lift the lip, look at the teeth, the two top teeth. What do they look like? Have these children been seen by the free dental service up to the age of 13, and then that teen dental service up to the age of 18. Please make sure that any teenagers you see, you really encourage them to be seen by dental, because it is really important, and it is free up to the age of 18, so let's make the most of it. D, I'm up to D, drugs. S is sexuality, so asking, do you have a boyfriend or a girlfriend? What pronoun do you want me to use? And, what do you identify? How do you identify? And if there's kind of a yes to any of those kinds of questions, you might want to ask about sex. Are you having intercourse? Or have you ever had? Because often I've, well, not often, but I've done it a few times. I've said, are you having sex? And they look at you and go, of course not, miss, I'm talking to you, which is fine, but it's kind of like, it's not right now. I'm talking about, have you ever had sex? So if they've ever had sex, at the high school that I do a clinic at, we've really been pushing this year. So anyone who identifies as ever having sex, we're getting them to do STIs just to make sure if we can just decrease chlamydia rates. Also, this is the age group where we need to talk about HPV. So 14 to 26, really encouraging HPV vaccines as well. Then and then around sex is contraception. And I don't know kind of what other areas do, but in Auckland, they had the LARC clinic, the long-acting reversible contraception clinic, has several places around Auckland that provides free LARC placement. And in fact, they come to my clinic once a week and do Jadel. I do Jadels, but they do the Marinas and IUDs. So it's cheaper than going to family planning, so really access those services as well. Sex, and then the next one is safety. So asking young people, do they feel safe in all aspects of their life? So that's, do you feel safe at home? Do you feel safe at school? And do you feel safe online? Okay, so online bullying is huge, and we need to really kind of bring it out and talk to people about it. If we ask the questions, it normalises maybe feeling comfortable to then talk to us. And when we talked about, like, for example, family violence, we know that we need to ask the same question about 7 times before, in fact, people will open up and actually talk to us about the environment that they're in. So it's really important to routinely do these. And also, of course, kind of going back about 10 steps now, but when you have an adolescent in your room, the first thing that you need to say to them is, this is confidential. What gets said in this room stays in this room unless, and it's the unless is 3 unlesses, unless you're harming yourself, someone is harming you, or you're harming someone else. And we would then come up with a plan of what we're going to do to keep you safe. But we need to say that to every young person. We, of course, as health professionals, assume that everyone knows it's confidential. They don't, and teenagers particularly don't. So make sure that we kind of talk to them about that. And also just having an awareness, if you're working with young people and contraception, about the GILIC competence. So children as young as 14 can be considered GILIC competent and can say that they want to have contraception without parental advice. And that, I think, is my talk. Thank you very much. Does anyone have any questions? Burning questions?
Come on, love. You know how postpartum, when the mother is in the postpartum area, they are discouraged for breastfeeding in the lying position. Is that advisable?
No, it's fine. So postpartum women lying down to breastfeed, no, we often do encourage it, especially if they have, if women have a lot of flow, that can be a really good way of kind of decreasing flow, because otherwise for that infant it's kind of like they've been stuck under Niagara Falls. So often kind of lying down, that can help. So no, that's fine. It's lying down and almost being unsupervised. So kind of propping a child up in a corner of a couch with a bottle propped up. That's not, because most women don't breastfeed lying down every single time. So no, it's fine. Yep. And also just important, just for those 6-week-old babies that you're seeing and maybe doing the 6-week check, is please do an Edinburgh postnatal depression score on all new mums. Because what do they say? 40% of new mums will have some degree of postnatal depression, and we do have services available. Maternal mental health is fantastic, so let's utilise the services that we've got. Pardon me? Cool. Thank you. Oh, yeah. Sorry, one more question from... Can she can probably still have it. Can she access the services? Unsure. But most women will show signs much earlier on. It may become much more present later on, and also because people are looking a bit more. But yeah, I would really encourage people to really use the skills, because we want, we really want to work hard to make the first 1,000 days the best that we can for all babies, and particularly our Māori and Pacific babies. So the first 1,000 days is really important. So we really need to engage well. We need to get the services that are available in the community to be working with people. Thank you.
Thank you so much. I do appreciate it. That's a little gift from us. Yes. Thank you so much. Thank you. Awesome, guys. Thank you. I know we've been running a bit late on time, so I will ask that you guys can grab your food, and then we might kind of do like a eating continue on, if that's okay with everyone.
Yeah, she is. All of our education educator team. So she's a good.
Okay. Is it a yes? Oh, here you go. Try not to trip over this. Now, is this working? Yes. Hi, so we're going to get started. My name's Deborah and this is Jackie. So as we were just introduced, we're the CNSs at the National Burn Centre. We're mindful that we are running a teeny tiny bit behind time, but we are going to stay on schedule, so we will still finish our session at 4, so we're not holding you up any longer. Ooh. Anywho, while the screen is blank, I'll still talk. A couple of things. I know that some of you were at the GP workshop that we held at Middlemore not that long ago, so some of the content will be familiar, but some of it is a little bit different. But you may have some questions from last time that you didn't get answered, so we're happy to be interrupted as we go through the session if you've got any questions. I just also want to be clear that we've got photographs of burn injuries, as you would expect. Often when we present, the feedback is there wasn't prior warning that there were going to be images of some burns. So, as in the title, Burn Care, there will be some pictures. We've tried to make them relevant to you guys. So we haven't got these big enormous burns of 50, 60, 70% of the body. We've tried to make it relevant to a burn. I think most of the photos will be relevant to a burn that you might see in your own practice. And in fact, some of them are burns that have been referred into us from primary health. So hopefully it won't be too irrelevant to your day-to-day practice. This is basically what we're going to cover. So a little bit of an introduction to the National Burn Centre and how we operate. Looking at burn size and depth so that when a patient comes into your practice, you'll be able to have a look at that burn and figure out how big it is, and a little bit of a guesstimate of what that depth is like, because obviously the burn depth is going to dictate or guide your treatment. We've been asked specifically to put in some non-accidental injury content in this talk, so we've got a little bit of information about some burn-specific things to look out for and some pictures. We're going to talk about wound care, and within that we're going to look at cleaning the wound, blister management and dressings, and then when to refer on to someone else, whether that's maybe district nurses or maybe into the hospital. So the first slide is really an overview of the burn service across the country. So we have 4 regional burn units. We've got 1 national burn centre, so the National Burn Centre is based at Middlemore Hospital, and that encompasses not just the burn ward itself, but also the intensive care and the children's ward. So we're kind of, as a team and as a service, we're kind of spread across several areas. And the concept behind the regional burn units and the National Burn Centre is that no matter where you are in the country, no matter what burn injury you have, you should have the same care and the same treatment opportunities. And so the units, so the 4 units in the National Burn Centre combined are the National Burn Service. And what that means is that we really have a collaborative approach to burn care. Everything is delivered from a multidisciplinary approach, and we have a number of ways in which we manage to do that, and that's through communicating, coordinated research, audits, education, and some nationally consistent guidelines. So if you were to go on the National Burn Service website, there are some resources there and some management guidelines, and anything that sits on that website has been agreed upon by the 4 units. And so it just means that we've talked about the equity of care and accessibility, and this is just a way of making sure that people with a burn injury get the same care no matter where they live. an overview of, oh, my circles aren't there. This is just an overview of the types of injuries, kind of epidemiology, I guess. It's a very busy slide, and I did have some circles drawn on there, but for some reason they're not on the screen. Really looking at the things that are relevant to you guys. And so I think this one is the adults. And so just over 40% of patients that turn up to our unit, or admitted to hospital, with an injury as an adult are flame burns, and then another common mechanism is scald burns. The mean ages of the adult patients that come through is in their 40s, and they're mostly male. And this is the paediatric one. So we know that most of the patients that turn up under 16 years of age that turn up with a burn injury are scald injuries. And the second, one of the other more common injuries is contact burns. So for little children, we've just had an absolute run of kids under 2 in the last, I don't know, maybe month, with really, really nasty contact burns to the palms of their hands where they've touched oven doors. So even something as what you would think is something as benign as your oven door can cause a really significant burn to a child's palm aspect of his hand. Stovetops and the odd fireplace as well. So really nasty injuries that have almost very long-lasting impact on the functionality of a hand. Most of the burns with our children, as you would expect, happen in the home. We've got down the back, if you wanted to take any before you leave, some burn prevention posters. There's some posters, there are some little pamphlets, and there's a set of magnets. You can help yourself to them. You can take them, share at your practice with your patients, take them home and share the magnets with your families. Anything we can do to minimise the risk and the impact of these burn injuries is fabulous. We have a really clear pathway of referring into the regional burn centres, and so the little poster with the National Burn Centre criteria, that's almost irrelevant to you guys, because anything with any patients that turn up with an enormous burn, you're going to call an ambulance and they're going to get out of your place of business very swiftly. But the other one on your left-hand side, those are the smaller burns that will present to your practice, and those are just a list of considerations, just some prompts when you might think to refer into hospital, into Middlemore to the burn unit. And we've got some of these, this is all available on the website, you're not going to remember it all now, but there's some really clear guidelines as to who we would like to have referred to us if they do turn up to you. And we'll talk a little bit at the end of this about some other patients that you might consider referring into hospital. And referral doesn't necessarily mean transfer. It might be a discussion with either Jackie or myself, or with the plastics registrar on call for some advice. And it also may mean maybe coming to an outpatient clinic for follow-up. We run a number of clinics depending on where the patient, which clinic the patient ends up in. And so we run multidisciplinary clinics. So we have occupational therapists, physiotherapists, place specialists, psychologists, surgeons, nurses, and sometimes a pharmacist. So for those patients that have complex injuries, and it doesn't have to be a big burn to be complex, it's kind of like a one-stop shop. So it's nice that patients and families don't have to move around different areas to get what they need to be treated. The next few slides are looking at how you figure out how big a burn is, how deep the wound is, and then I've already talked about that, then informing your treatment. We're not expecting you to remember any of the detail of these, but again, I'll refer you back to the National Burn Service website because it has all of this information on there. And down on the back table, I've left some little cards with a trauma app details on it, and it's a New South Wales trauma app.
And you can load that on your phone, and that's quite useful as well because it has the details of how to work out the size of a burn, and it has the links to the National Burn Service website as well. So you'll see all of this information and some other treatment guidelines as well. Basically what you're looking at there is working out the total body surface area will tell you how big the burn is. And again, for the patients that come to you, if it's a big burn, you don't even need to calculate it, you need to get them out and into hospital. But for those smaller ones, so by smaller I'm meaning on a child maybe 5%, and on an adult maybe 10% and less. These are some formats that you can use to calculate, but probably in your own practice, the easiest way is to use the child's hand. So the palmar aspect of the hand is 1%. So for the patients that are coming to you, I suspect the ones that you're going to keep and continue to see and reassess and treat are probably ones that you can figure out the TBSA very quickly just with the patient's hand. And that will give you a bit of an idea of what you're going to need to do moving forward. The other thing that you need to assess when the patient comes in is how deep the burn is. Because again, it's going to inform your treatment moving forward. If it's a burn that you think is going to heal within 2 weeks, then you can keep them. If you think it's going to take longer than 2 weeks, then you need to refer them in for specialist care. A burn that takes longer than 2 weeks to heal is going to maybe actually need a skin graft or some sort of surgical intervention, but it may well need some specialised scar management as well. So to figure out how deep the burn is, back in 1947, Jackson figured out this way of looking at how your skin responds to heat. And so this little diagram, the blackened area there is the area of the skin that's closest to the heat source. So basically that's an area that is potentially quite deep. The area that you might see that's blistered when a patient turns up to your practice or is black or is thick white eschar. And then there's some surrounding areas, and I'm not going to go into a lot of detail with this, but the take-home message is that there are some things that we can do immediately to minimise the risk of the burn becoming bigger and becoming deeper. And the one thing that is kind of easy but kind of not is burn first aid. And does anybody know what the recommended gold standard of burn first aid is? 20 minutes of cool running water. And we know through research that if you deliver good first aid, then the burn injury has a better chance of healing. So it's going to be not as big and not as deep. And 20 minutes is a pretty long time, particularly if it's an 18-month-old that's sore and is a bit screamy. So sometimes what you need to do is do a little bit, have a break, and do a little bit more. Again, I can appreciate that that's not easy, but from the impact on that burn injury, it will improve outcomes for the patient. So if you can work through that, then it just means that the burn has a better chance of not needing an operation for it to heal.
Is there like a time frame where that no longer becomes relevant?
There most certainly is. Yes, yes, perfect. Good question. So there is, absolutely. So we know that it's effective. It's most effective immediately, but you have a 3-hour window of opportunity. So if patients do not come in straight away, then you've got 3 hours to do that, yeah. So I think, I don't know, I don't know, I don't work in primary care, but I suspect most people would turn up within 3 hours or even like the next day, and then it's irrelevant the next day. So that's really scald burns. There are one other real exception to that, and that's if it's a chemical burn. And if it's a chemical burn, that's a different first aid treatment. You're actually trying to flush away and dilute that chemical. And so you're wanting to continue to flush the chemical away until the skin reaches a neutral pH. So that's slightly different. This 20 minutes is your stock standard thermal burn. So by thermal burns, we mean a heat source, so like a scald, a flame, a contact burn, that kind of thing. I think that's all for... I guess the other thing to mention, particularly with children, is you do, and elderly as well, you do need to be careful that you are keeping the patient warm. So what we say is cool the burn and warm the patient, because you don't want people getting hypothermic. And we do see that sometimes if patients have been cooled a little bit long at home and then come into the hospital. Generally, these are bigger burns, of course. So just be wary of that hypothermia as well. But you certainly have that 3-hour window to make a big difference for that patient. You can cool for longer than that if you wish, and we have lots of patients that end up putting their hands in a bucket of water after you've done your running water cooling in a bucket of water, and that's more for pain relief. And I know my colleague Jackie here burnt her foot a long time ago and had her foot in a bucket for an extended period of time. That's about pain relief. 3 hours. So that's about pain relief rather than cooling the burn. So no, as long as it's not icy cold water. And I know that you would see patients present with all sorts of things that they've cooled with. So ice is no good because it does constrict those blood vessels, and it's going to constrict the oxygenation to the area. But, you know, I mean, you would have seen too, I guess, flour and butter and Vicks and toothpaste. All of those things, apart from not necessarily cooling the burn, they can damage the skin and be really difficult and painful to clean off as well. So just keep it simple with the cool running water. I'm thinking what we're up to next so we can preempt it. Oh, is that too long on one side? Oh, sorry. I need to talk faster. And this is just a little piece of I guess, interest, just really to highlight that you don't need super, super hot water to cause a full thickness burn. And so looking at that, the temperature, the 69 degrees, it only takes 1 second to cause a full thickness burn. So if you think of, you know, boiling your water for your cup of tea or coffee, that's 100 degrees. If you're pouring your drink and then somebody comes along and spills it on themselves, that's going to be hotter than that 69 degrees. And so you're going to get a full thickness burn very, very quickly. When you're thinking particularly of children with their delicate thin skin, and adults as well. And then when you're looking at a temperature of 50, it's going to take 30 seconds to get a full thickness burn. And if you're talking about tap water temperature of 45, it's many, many seconds. And so that heat in that cup of tea or that coffee is going to potentially cause a really nasty burn. So we do a lot of, obviously when patients turn up to us, they're already burnt, but we do a lot of burn prevention really around temperatures and the difference between and the impact between that temperature and the damage that it can do in a really, really short period of time. So that's thinking about the size of the burn. Now we're going to talk briefly about the depth of the burn. And there's a pretty picture and there's a really simple table to look at, but the reality, it's a bit like those rashes and things that we heard about before. In the book, they look okay, but when you've got a patient in front of you, it's very different. And there's a lot of skill that's required to figure out how deep a burn is. And when a patient first presents, it's really quite difficult to figure out the burn depth. And so even for people like ourselves that have been working in burns for like 30 years, it's still hard at that point, that on, you know, day of presentation, so day 0 of injury. There's some helpful hints in that chart. Again, this information is on our website. And so what we're looking at is we're looking at the colour of the wound bed. We're looking at, are there any blisters? Is there any capillary refill? And is there any sensation? But the other thing that we're going to be asking patients is the history and how they got burnt. And so there'll be some helpful hints in the history. So we know, I've talked about those temperatures, we know that if a patient has been, if a, little Johnny who's 18 months has pulled a cup of tea onto himself, we know that if it's freshly boiled and he's had no first aid, it's going to be a deep burn. If it's a cup of tea that's had some milk in it and that's been sitting there for 15 minutes and then he went on to have 20 minutes of burn first aid, we know the chances of that being very deep are less than if he didn't have those things. So there's some helpful hints in the history, but sometimes it just takes a little bit of time to figure out how deep it is, and it takes a little time for the burn to declare itself. And what we mean by that is we mean for any first aid to have taken effect, and the burn essentially to have settled down. And so this photo here, the series of photos down the bottom, is really to illustrate that it takes time for a burn, for burn depth to declare itself. And we talk often about 3 to 5 days to really have a good handle on how deep a burn is. And so even for patients that are admitted to the hospital, we always tell patients when they come in, we think it's this depth, but actually we need to wait a few days before we really can figure it out. And so those photos down the bottom, that's a scald burn, and on day one it doesn't look too bad. You would look at that, it's nice and pink, it doesn't look white or leathery or black from a really high temperature heat source. It's possibly got a bit of refill, hard to say, but by day 5, it's obviously a full thickness burn that will take a long time to heal or will need an operation for it to heal. So that kind of waiting a few days for the burn to declare itself is really important to get a handle on actually how deep it is. We know that most burns are a mixed depth, and the one at the top is a classic example of that mixed depth. There's some areas that you can see that have started to heal, and there's the thick eschar in the middle that really needs debriding and grafting. And this is just another example of a patient who has a scald burn on his foot, and just that example of watching and waiting. And when we look at that, you can see by his little toe, that photo on the left at the top by his little toe, you can see that's a slightly different colour. It's more of a yellowy colour. The rest of it is a pinker, more healthier looking wound bed. And so we're pretty confident that that area by his little toe was full thickness, but we just wanted to watch and wait and see how much of it would heal. And by a couple of weeks, it was pretty obvious that that last little bit was full thickness. Sometimes it's not. It's retrospectively that you diagnose burn depth, and you know that if it's not healed by 2 or 3 weeks, it's actually full thickness. It can be hard assessing a wound, but that's a bit of a no-brainer. If it's not healed by 2 weeks, it's full thickness. You don't want to get to that point, though, before you're referring into us. We like early referral, and that's because I'm sure you know when you refer patients in, it can take a long time to go through that paperwork and that triage process. If it's urgent and you need the patient seen that day, then you can call the plastics registrar on call, and they will expect some photographs, and then they will make a plan. If it's one that you're just watching and waiting and you've been doing some dressings but you think it's going to take a little while to heal, then you can just refer in for an outpatient appointment. But they do take time. Am I doing this bit? Any questions so far? Any questions from the people that were at the last session at Middlemore? No.
So we thankfully don't see too many unexplained and non-accidental injuries. You may in your areas, and it's sometimes history taking where you get a multitude of stories depending on who you're asking at what point. So the actual incidence of non-accidental injuries is unknown, and there's actually no straightforward definition. So
it's the history taking is really important, and when we have patients that we see, there'll be a number of different people taking history at different times, and you know, accidents happen. We all know that they do, and particularly in children who are very, very quick and sometimes can, you know, they're stood right next to you, but you turn your back and 2 seconds later, you know, accidents happen. So there is a continuum within the non-accidental injury process, and, you know, it goes from that scenario that I've just explained to actual neglect and then to intentional. So obviously we don't want to catch patients and families out. What we do want to do is get to the bottom of the story, because, as Deborah mentioned, we want to be able to treat that burn with in the right way. And sometimes if you're given incorrect information, it can lead your treatment path sort of like, you know, off to the side. So yeah, we're really, really hot on history taking. So the incidence actually varies, and the literature is really vague. So it goes from 1.7 to 25% of injuries, burn injuries, are actually non-accidental. Thankfully, as I said, we don't see that many. Scald burns are actually the most common, and that's usually by immersion. So deep burns to feet, hands, buttocks, and perineum. I have got some pictures on the next slide, which it shows how that could happen. You tend to get clearly demarcated lines from the injury, and lack of splash marks, where in a normal scald, you get many, many splash marks. And you can get sparing of areas as well. So soles of the feet or the buttocks, from contact against a surface as patients are held in the hot water. Contact burns is also a common non-accidental injury, and that tends to be from cigarettes, irons, and also these days hair straighteners. We've had a few patients, unfortunately, with hair straightener burns. And again, more than likely well-defined lines. So an accidental contact, you just tend to get a brush, not a complete demarcation. So these are the pictures that I talked about. So holding an infant in water, you get sparing of the buttocks, you get sparing of the soles of the feet, you get crease marks where they've sort of like folded up. And I mean, obviously, if you get somebody in with an injury like this, the series of questions that need to be asked are quite significant to try and determine whether this was accidental or non-intentional, because if we, intentional I should say, because if we find they are intentional, we have to go down the non-accidental pathway, and that just opens up a whole ream of investigations, and to make sure this patient's going to be safe. So, specific to burns, the burn pattern doesn't match the story that you're being told. And certain patterns of injury, as I've talked about, so on that bottom picture there, you can see the feet, clearly demarcated lines halfway up the leg, and then on the top one where the patient's been put in a bowl or a bath of hot water. So scald injuries generally are not that uniform. They tend to have lots and lots of splash marks. And also drilling down to when did this happen? How did this happen? As we've talked about assessing the depth of a burn, what you see on day 1 is not what you see on day 3 or day 5. So regular assessment of these wounds and working out whether, you know, what you're looking at actually did happen 2 days ago like you're being told, or was it actually a week ago? So we're very open and honest with families when we're asking these questions. For instance, if a child's brought in by a family member who's not their guardian, and parents or caregivers are nowhere to be seen, you know, brought in by an older sibling or an aunt who's not actually sure what happened, but just found the child in this condition. So there are a few red flags when we're determining this history. That's a normal skull burn on a toddler. They tend to obviously be short. They're reaching up onto something higher. They pull down a liquid onto them, and you get a non-uniform burn pattern with splash marks. So we have some markers that can identify when it's a non-accident, when and if it's a non-accidental injury. Right. Okay. Wound care. Any questions about the non-accidental injury? No? Okay, I'll keep on talking. So this session, we're going to just cover cleaning, blisters and dressings, as Deborah's mentioned. And, you know, you might ask why. I don't know about you, but when I was taught, basically, wound care was all about the cleaning. And we can't emphasize enough the fact that you need to actually clean a burn wound to be able to assess it properly. As you can see in that top picture there, that's the pre-cleaning, pre-debridement. And you need to get rid of that debris and dead tissue because it can delay wound healing. You also can't assess that wound bed properly while that dead tissue's there. So, and you, by getting rid of the dead tissue, you improve epithelialization. So, as you can see, what you see at the top is only half of what is burnt. So underneath, you can see when you've got rid of all that dead tissue, that's actually increased by another 1 to 2% in size. So that'll, you know, determine potentially your management or what product you're going to use on this area. As soon as possible. So if this patient presents to your service and you see it like that, take it off. Yeah. You're going to need some good pain relief to do that, though. It depends where the patient is. So if this patient is in ED, we've got access to most things. So we would start off with orals, and then if not, we'd escalate to IVs, Entonox. In clinic, we have less options to us, so we can only give orals. And hopefully, if this patient has been under our service, we would advocate for them to take the pain relief before they actually come to clinic, so that the pain relief will be working, and we can give it a good clean. Yeah. What would you have access to in your area? Yeah. Yeah, yeah. And I think at that point, then you consider referring in to hospital. Personally, if that came into my primary care setting, I'd refer into hospital, because you're probably not going to be able to clean that effectively enough to give it its best chance. Yeah. So we want to move any contaminants that are in that area. We talked about the patient cooling the burn, which they've probably done when it's happened at home. It may have been covered by a cloth or some clothes. there may be remnants of those things left in the area. So you want to get rid of all that contaminant. Also, burns are highly exudative. So if this is not your first dressing change and you're seeing them at, dressing change 2 or 3, you need to get rid of that superficial slough, which is the exudate that has formed over the past couple of days. Because there's no point just taking off the old dressing and putting a new dressing back on, because that wound may be contaminated, and that slough is going to just build up and build up and build up over the course of the next 10 to 14 days. And you'll literally be left with a thick scar that you'll be very, very difficult to remove. So at each dressing change, you need to give the area a good clean, and get out any, remnants of any dressing products that were on there. Again, good pain relief. Go? No? Nope. Bit of gauze. For that, definitely. Because that looks sharp. No. Mm-hmm. Yeah. Yeah. When I come on to blisters in a minute, we can talk about some other things that we would use for blisters. But for that, I would just use gauze and saline. Or even soap and water, depending on where you are.
Sometimes it's soaking, so sometimes you might put some saline on this and then lay it on and just leave it for 5 minutes just to soften and then wiping.
So, as I've mentioned, unfortunately, these videos don't work, do they? We couldn't get them to work. But there are some, sorry. Perfect. Yeah, that's great. Yeah. Yeah. That sounds like a great idea. Yeah. So, moving on nicely, ensure you've got appropriate analgesia. So, oral pain relief, if that's all you can give. Maybe if you've got access to Entonox for adults and adolescents, you could use that. But you need to be thinking about your analgesia before you're giving this area a clean. As I say, it doesn't need to be fancy cleaning stuff. Saline water, soap and water, chlorhexidine, and just gentle. And what you'll find with that blister that's already de-roofed and, slipped, it will actually come off fairly easily if it's within the first few days. If it's been left on 10, 14 days and not removed, you're going to struggle to remove that blister fluid, because that blistered skin, because it may have actually adhered back down and is stuck. So you don't want to cause any trauma to the wound bed. And I can't emphasize enough, it's just giving it a clean, just with a bit of gauze. It generally comes off very easily. So this is a patient that we had in clinic, was looked after in the community for the initial dressings, and got referred in because they were worried that this was a full thickness burn, and that this patient might need a skin graft. And I think this patient did have some comorbidities which would potentially, highlight some delayed wound healing. So we had this patient in clinic. We had a look and we gave it a clean with that saline and that gauze, and that's what we found underneath. So it was actually healed underneath that. It's just the fact that it hadn't, that blister, that devitalized tissue had not been debrided in the beginning, and it had literally just secured itself back down to the wound beds, and it was quite, that you did that one, didn't you? And it just wiped off,
We got those photos to start with. We too
Mm.
Like the sperm, we brought them into clinic, and we had intended on taking the patient to theatre the following day to have that debrided and grafted. And then when he came in, we kind of poked at it a little bit with our gloved fingers and thought that seems a bit odd. And so I literally just wiped it with some gauze, and it was literally, apart from a couple of little spots, it was healed underneath. So that was, the patient was very excited.
Yeah,
So it just was a reflection of the fact that it just needed something.
I've got next. This is a patient that should be seen in hospital, and basically that film that you can see on the top of it is not a full thickness burn. That's pseudo eschar from flamazine. So the pink area that you see, where there is no pseudo eschar, is actually the burn underneath. So it can be quite deceptive figuring out a depth of a burn that's been managed with flamazine. And to get that area to heal, our team, we would actually take that patient to theatre and remove that pseudo eschar and sort of like start again with dressing products to try and help that wound heal.
So the flamazine is the SSD.
Mm-hmm.
Some people may still use it, but it's not something that we use on a wound that we think is going to heal. And I guess the purpose of this photo too is for you, when you are changing dressings or assessing a wound, is really to have a good understanding of what dressings have been used prior, so that you've got a bit of an idea of what is going on with that wound bed. So we know that SSD, you can get the pseudo eschar. And some patients, as Jackie said, they do have to go to theatre to have it removed in theatre and scrubbed. And the other product that you may or may not use or have access to is Acticoat. And what that does is it dumps silver onto the wound bed, and that too can cause a discoloration, so that when patients are coming to us and we're trying to assess the wound bed, it can be difficult to see what's actual wound bed and what's remnants of the dressing or that discoloration of the silver. And it's fine to use those products, we would always ask the question, what has the burn been dressed with prior to us seeing it, just so we have got some clues as to what we might be looking at. So we use it sometimes with infected wounds. We use it a lot with infected donor sites. The other thing that one of our burn surgeons is starting to use it on pretty successfully is for cleaning. So if it's a wound that's got a lot of dry exudate on it, or a bit of dry skin, or facial cares that we're having trouble with, we're actually putting it on a bit of gauze and using it as a way to clean a wound bed. And that's just because of the consistency of it. It's quite good at softening skin and helping it clean. We wouldn't then put it on the wound bed as a dressing, more of a cleaning. Yeah, so those are usually, I think those are usually the...
For the Pseudomonas, the treatment of Pseudomonas, we'd only use it daily for 3 days and then we'd stop. Yeah. No, I mean, we do still see patients still do come in having had daily dressings with flamazine. Yeah, not as much these days, but yeah. No, it's not hard. It's actually quite soft and squidgy, but it's quite a big surface area, so trying to actually remove that would be painful. So that's why in our department that patient would probably go to theatre for a GA and have it cleaned properly. Yes. Yes. Yeah. I suppose for the first 24 hours it may not be, oh, has it gone off? It probably would be all right. It's that consistent use over, 10 to 14 days. That would, yeah.
Is
Sorry, I'm talking. And this picture is just a donor site. So patient came in and had their donor site had healed after they'd been discharged from hospital. Dressing's done in the community, didn't need dressing any longer. But when she came in, the donor site was really dry and itchy. And literally gave it a clean, popped some moisturiser on, and that's what it looked like 20 minutes later. Itch is a massive problem for patients with healing burns. They can scratch themselves raw. We're really mindful that even a healed wound still needs some good wound management at this stage. So cleaning, regular moisturising to get it into that condition. Anything that's not too highly perfumed that their skin will take. Yeah. That'd probably need moisturising 2 to 3 times a day at that point. So, blisters. Controversial. There is no right and wrong way to treat a blister. Every burn service tends to treat them differently. We do have some guidelines from the Australia and New Zealand Burn Association on managing blisters, and each service internationally has their own blister management as well. So literally, you could take this either way. So blisters contain many chemicals. It can lead to increased inflammation and vasoconstriction, which can impair wound healing. That blister fluid, if the blister's not deroofed and removed, also hardens over time. So it's a liquid to start with, then it turns to a gel, and then it turns quite hard before it's reabsorbed back into the body. However, blisters also contain some nice molecules that may improve healing. So depending on which literature you read, you can go either way. So, what would you do with that? Take it off? Yeah. 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 So blisters of that size in that area, we would deroof. And by deroof, I mean we would cut away all that devitalised skin. We wouldn't do that. This patient would go to theatre for that doing. It's extremely painful, is deroofing blisters. Not the actual cutting of the dead skin, but once you expose that wound bed to the air, then that's when it becomes difficult. And that's a small squidgy hand, and it's going to be hard to keep that patient still. So the aim when we're removing a blister is to get rid of any non-viable tissue. So that tissue here, this is all dead. You're not going to do anything to salvage that. That's gone. And what you see on day one as a blister, if you wrap that area up and then bring them back the next day or the day after, there may be more blisters that have formed in that area. And then when they're quite tense, if you leave them if you don't deroof them, they restrict movement. So as I said, it starts off as a liquid, it goes to a gel, and then it turns hard. So it restricts movements, particularly over joints. And how are you going to assess the depth of that with that skin still on there? You can't. I mean, there is, blisters form when there's damage between the epidermal and the dermal layers. So you've got a good idea of, which layers have been affected when you get a blister. But you actually don't know how deep that is until you take that skin off. So the recommendation, I think this is from the Victoria Burn Service, is to leave any small blisters that are less than 5 millimetres in diameter. You can leave those intact. 5 millimetres is quite small. Any bigger blisters than 5 millimetres and thick wall blisters, blisters over joints, and ruptured blisters with loose skin, you debride those. So, and that would be our recommendation. Again, you need to have good analgesia on board to do that. Because while that tissue is intact as the blister, it's actually forming, you know, good pain relief. Once you take off that skin, you're opening the wound. Its nerve endings, pain receptors will potentially be exposed. So it's going to be painful. Yeah. How did you assess how deep the burn was? Yeah. 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 And would you, like, once the skin had deflated on top of the wound, at some stage in the dressing process, would you take away that dead skin, or would? Yeah. 5 days. Yeah. And not too many problems with infection? No.
I suppose the only thing that would change management is if it's a full thickness burn. And then, so particularly for those smaller children with the Palmer aspects. Oh, okay. Okay. Yeah, so one thing to consider is, so for some patients that have particularly hand burns, we would be looking at linking them in with our scar management team right from that day of original injury and starting splinting and some hand therapy, I guess, as well. If it's one that's going to heal, though, then sure, no harm done.
So when we actually identify we're going to remove the blister, the non-viable tissue, you can do it with mechanical debridement, just with some gauze, so like say it's a hand in a bowl of water, and then just snip the dead tissue away as far as you can to the intact edge. You don't want to go too far to the intact edge because that will obviously be a bit too painful. And, you know, there are some resources on the Victoria website that actually go through how to do it. And they're really good resources, aren't they?
They're very short videos, like a matter of seconds. So that we haven't got them playing on here because we didn't have space that we could actually get them to work. So there's the videos before are of cleaning, and these ones are of how to actually snip a blister using your forceps and your curved iris scissors. If you are choosing to de-roof, these are the best tools to be using, and those videos show it very nicely.
How are we doing for time?
20 minutes.
Or the Victorian burn service. So it's the Alfred Hospital in Melbourne.
And they've got many videos. They've got a whole lot of videos around wound cleaning. Some of them won't be relevant because they're large burns, but still the concepts are the same.
Yeah. And this one is particularly good for your areas. So this is just about minor burns and blister management. And I suspect these are the types of patients that you would see in your services. So, you know, it's It's a matter of being confident about what you're looking at, and, you know, having the tools, and like as Deborah said, so literally just some forceps and a pair of small scissors is all you need. This was another patient that we saw in clinic who came to us at 10 days post-injury. It was a scald burn, and we'd had some photographs sent in from the original injury, and as you can see, 10 days later, it didn't look any different. It looked exactly the same. Very hard to know what's going on underneath that skin. It wasn't debrided. This patient, when he came into us, was in extreme pain and finding it very hard to mobilise. We couldn't get all the dressings off in the clinic because, like you, we have limited access to what pain relief we can use. So we literally wrapped him up, and we brought him back the next day, starved. So he went to theatre for a good scrub of that area. And that's what we found underneath those blisters. So those photographs, 2 photographs on the left, are what was underneath that. So you can never really tell what's going on underneath that undebrided area. He actually went on to need skin grafting. So these pictures on the right are the areas that needed skin grafting.
I'll give you a rest from Jackie. So this is another example of a situation where you look at a burn and you're just trying to figure out what's going on. So has anybody got any thoughts about how deep that might be, or what they would do with that if that patient was in front of you? Good idea. You know where to find us. Yeah, so it's a bit of a tricky one, this one, because it's a hot oil burn, and we know from experience, and you may well yourself, if you've seen hot oil burns before, they're almost always deep. Many of them go on to need a skin graft, and that's the situation with this patient. When a hand has been cooled, or a foot has been cooled in water for a little while, you know, it can get a bit macerated, a bit wrinkly. And we've had many situations where a patient has presented with a hand like that and the clinician has gone, that doesn't look too bad, it doesn't need a dressing, there's no actual wound, they can just go home and have some moisturiser put on. So that's what happens in our department. People are sent home with a hand that looks like that. Luckily this chap wasn't, he was referred in to us in hospital because it was actually a full thickness burn. So the whole of it, he went to theatre and he had all of that blister de-roofed and went on to have a skin graft. And it's a pretty significant injury in the sense that it's on a hand, it's a functional part of the body, so he's had a lot of physiotherapy, a lot of scar management, a lot of hand therapy, and he was just in not that long ago to have some more minor tweaks to that. So that's a pretty significant injury, and so one of the things to think about is that the detail of that mechanism, and so hot oil burns and flame burns are usually quite deep. So if you see any of them turning up to your practice, those are the ones that you should probably refer in pretty soon rather than hold on, because it can be quite deceiving when the skin is intact, but actually it's full thickness. So we're going to spend a little bit of time quickly talking about dressings, and there are lots of different dressings, and we're not going to tell you what dressings to use for 2 reasons. One, because everybody has access to different products, and there's no point us telling you what to put on if you don't have access to those products. So we're going to talk about some concepts and some things to think about when you're choosing your product. So there's lots of different categories, and almost, not all, but almost any of those would be okay on a burn. Not a film though, because we don't want an occlusive dressing, would be the only thing. But any of those other ones are probably okay, depending on your wound assessment. And the other thing people ask us is, what is the ideal dressing? And we ask a lot of dressings, so we want a single dressing to do all of that stuff on that list, which is quite a lot. And it goes on to this page as well. So not only do we want it to treat the wound, heal the wound quickly, we want it to be cost effective, we want it to be able to provide some protection and some the ability to range if it's on a hand. We want it to be comfortable, we want it to come off really easily and be atraumatic for the wound and the patient, and we want it to be changed infrequently because we don't like daily dressings unless there's a problem with the wound and you are either doing a series of dressings because you're wanting to gradually de-roof a blister, or if it's you think it's looking a bit mucky, not maybe some contaminants and you want to give it a regular clean, but for your wound that looks satisfactory, it looks like it's going to heal, there isn't really any place at all for a daily dressing, so we want infrequent changes. So not like an opsite or a tegaderm, a dressing that doesn't allow exudate to come through, or some sort of breathability. Yeah, so those plastic opsite sticky dressings. Back last century, we used to do that. We used to put an occlusive dressing on burns that were superficial or almost healed. And I personally have put an opsite dressing on a patient, and then that patient became septic very quickly because the wound, we saw him in clinic and the wound bed wasn't quite as healed as we thought. And in a couple of days he was back in hospital very sick. So we've moved away from a dressing that doesn't allow some sort of breathability or exudate management. Yes, a hydrocolloid, it's not really an occlusive dressing in the sense that there's a bit of spongy foaminess in between the wound bed and that raincoat kind of protective cover. The occlusive dressing is more of the opsite one, that's the primary dressing is just the opsite, yeah. So that's got a little bit of sponge and foam. Yes, absolutely. Yeah, so, yeah. And so we use a lot of MEFIX, Hyperfix when a wound is healed or practically healed, but in that acute stage we've moved away from that. And that again, it may represent the types of patients we see, of course, because we tend to see bigger burns. But I know we went through a stage where lots of patients were having Hyperfix or MEFIX put on what was thought to be erythema, and then they were presenting the next day, and it wasn't so much of the erythema, it was a partial thickness burn, and so there was lots of exudate, and then they were taking the MEFIX off and basically de-roofing all of that burn. So, you know, you have to be really confident in what you're looking at, and so we've certainly moved away from that, and I haven't seen it in an acute wound for a very long time, but certainly we've got some pictures of using it on a healed area for pressure and protection. But yeah, that was certainly quite trendy a while back as well. Look, you and I, we've seen it all. No, it's okay. So we'll skip to that if you wish. So what we know is there's no ideal dressing. So what we say to people is stop asking. Because, no, you can ask your question, but people say, what do I put on a burn? And we're like, well, it depends. So I'll show you what we put on some of our burns. So we're lucky though, we've got a whole big cupboard of stuff, and we're mindful that, but some other people have better stuff than us. Like some of the community nurses have these amazing products that we don't have access to. But what we are saying to use is your clinical judgment, use your structured approach for wound management, use your time, figure out what the wound looks like, what you're trying to achieve. Is it working? Is the wound progressing? Is it deteriorating? Do you need to change your management? But what we tend to use is these products. So we do use silver-based products, and again, it might be a reflection of the patients that we see. So I guess you could argue that if you're seeing a patient, you're fairly confident that the burn is going to heal within a week, then you could probably use something non-silver. But we tend to use the 3 products that we use the most is Acticoat, Mepilex AG, and Aquacell. And we're not at all standing here recommending that you use those. Those are just the products that we use a lot, and we use them for a number of reasons. The Mepilex AG is now our go-to product in the acute stage because it's nice and soft and gentle. It's easy to get on and off. It's got some foam that will absorb exudate, and it doesn't dump silver on the wound bed, so it doesn't discolour the wound bed. So from a wound depth assessment perspective, we like that. Has to stay dry though, so some patients don't like it, but for the initial treatment, that would be our go-to. Pardon? Mepilex AG. Yeah. And you can leave it, it's got silver in it, you can leave it, the literature or the information will tell you can leave it for 7 days. What that means is it's got enough silver in it for 7 days, but usually the wear time will vary, and we find with our patients 3 days is usually enough because of the exudate, it needs to be changed. But it's really soft and gentle on the wound bed, and for our patients that have had a number of products, they all like the feel and the comfort of the Mepilex AG over the other products that we have.
We might use Acticoat maybe a week, 10 days down the line, because patients also say that they like to shower, and obviously when you have the other dressings on, it limits the showering capability. So, you know, it's often a discussion with the patient, particularly outpatients, how and what they want out of a dressing.
And I guess because we don't know what you have access to, if it's a product that's working for that wound, then obviously you're doing the right thing. But as with any wound, I mean, a burn is just a wound, so you would always be assessing and reassessing and changing your management plan depending on what that progress is like. But again, I say, if it's slow to heal and you're worried, that's when you should refer in. And you guys can make the call, do you need the patient to be seen that day, or can they wait a week for a clinic appointment? And I guess the other thing to think about is facial burns that are tricky to manage. I'd be surprised if you kept a facial burn for a dreadfully long time. I think you probably need to at least have a discussion with plastics. It doesn't at all mean that the patient needs to come in, but it's good for us to be following them up if there's any issues long term. Things to consider too is the mechanism of injury, and do you need to involve ophthalmology? Most of our patients that come in with a burn to their face, we check their eyes for any corneal abrasions or any thermal injury to the eyes. Some of that we can do. We don't. The registrar, the doctors do down in ED, or some of them go off to Green Lane Clinical Centre to the acute eye ward there, the eye clinic, to be assessed properly. These patients are the exception to the daily wound care. In fact, they need 3 or 4 times a day wound care. So these ones, if they're not coming back to you every day, should be referred to a district nurse, and then the families will be taught how to do it for the other 3 or 4 times over the course of the day. Yeah, I think so. And the easiest way, well, the most effective way of cleaning the face, tricky for a child, but for an adult, is to tell them to get under the shower and have the water whoosh all over their face, and then just clean with a flannel is all they need. And then really putting on some moisturiser or some vitamin A or some paraffin or emulsifying ointment, because you don't want that skin to dry out. So washing and then reapplying is the trick. Otherwise you end up with a build-up of exudate. And we have had patients that have had to go to theatre for a good scrub because faces are very difficult to manage. And these are the ones that you can sometimes use a bit of SSD to literally rub and clean some of those really, those dry, crusty areas that are a little difficult to clean. Don't forget, once a burn is all healed, As it starts to heal, minimise the dressings, leave healed bits exposed so patients can moisturise. And then this is where we do use the Hyperfix on a healed area. If it's a little bit fragile, if it's a bit delicate, if we're worried about the patient knocking their hand or damaging that newly healed skin, we'll pop a piece of Hyperfix on and they can moisturise through that. So it does still, you do have the ability to moisturise. And then the patient, we just give them some extra to take home and they just replace it as it falls off. But it just gives them, particularly with the hand burns, it gives patients a bit of confidence to carry on doing what they need to do and use their hands and not worry about pain or hypersensitive areas or knocking and causing any little skin tears. And the last 5 minutes. When to refer, so we've kind of alluded to when to refer throughout this. That's the list of patients that we would expect some sort of contact. So for kids over 5%, adults over 10%, full thickness areas 5%, chemical burns, a circumferential burn, any tricky areas, so faces, genitalia, hands. Anybody that's slow to heal, so anybody that you think is going to take longer than 2 weeks, because that will need either they need an operation or they need some quite aggressive scar management, which is delivered by our occupational therapists. Anything that is really painful and you can't clean, it's certainly worth a conversation. And some patients will come into ED just for a scrub with some Entonox or some sort of conscious sedation perhaps. So they have a bit of a spruce up and then they're discharged from ET back to your care. Basically, it just means that you can potentially give a good clean that you can't give in your area. Any social issues and any of those non-accidental injuries, they should be admitted to hospital. And if you look in the literature, all the literature talks about needing a specialist burn oversight and an MDT approach and social worker and psychologists. So anything that's non-accidental, I'm sure you have your own policies and guidelines where you have a duty of care to report and all that stuff. But those are the patients that we would expect to be referred in as well. And don't forget clinical photographs. I think you'd be hard pressed now to get a patient reviewed or accepted for review without a set of photographs. Pretty obvious. And it's so much easier than trying to describe a wound. A photo's fabulous. 2 things though, make sure you clean the wound bed as much as you can. And also if it's a patient that you've put cling film on, take the cling film off to take the photo, because otherwise we can't see it. It's true. It's a thing. Absolutely. Yeah. Yeah, and while you're waiting, we use it down in ED all the time still. So patient comes in, if they haven't already got some on, we'll put some on while we wait for the ED doctors to see the patient, and then we wait for the plastics to come and see the patient, and then someone else will want to come and see the patient. So the cling film is great from a pain relief perspective, and then while they make their plan. Yep. Yeah.
And even for our bigger burns that are transferred from around the country, we recommend that you can have cling film on for about 8 hours, up to 8 hours, and then obviously if they're going to be longer than that before they transfer, they need something else.
And those are just a few take-home messages up there. Using your wound assessment framework, whatever that might look like. Regular assessment, we can't stress that enough. Understanding how your products work, some pain relief. If you can't deliver the pain relief in order to do the treatment that's required, refer in. Photographs, the early referral. Getting feedback from our patients is valuable, particularly those who have been under our care for a little while and have a variety of different wound products. They know absolutely which ones they like and which ones they will not have near them, and that's fine. And using your resources. So the National Burn Service website, that Victoria Burn Service website is really, really good. The ANSPA, the Australia New Zealand Burn Association website is good. And you can call us for help, and you can call the plastics registrar at Middlemore Hospital for help as well. That's it, I think. Oh, is it finished? Yes. Yes, absolutely. Yep. So if you're wanting to refer in acutely, because you've got a patient in front of you that you want to be seen in the next 24 hours, you can just call the plastics registrar on call, and you just, absolutely, yep, yes, yep. We get district nurses phone us all the time and say, I'm going to send you a photo, what do you think? And we'll look at it and we'll say that patient needs to be admitted to hospital. You ring the plastics registrar and send in some photos, and it's all good. And so, yes, they will take a referral from a nurse. Mm-hmm. Yeah. And if you have trouble, we can help you. We'll show someone that cares. So we have an email. We have a burn clinic email that you can email, and we can provide some advice and some direction. We don't have accepting rights, so we can't accept patients directly, but we can give lots of advice, and we have lots of nurses email us and call us about, does this look all right, or what do you think? And so we have a lot of dialogue and provide some advice and support if people want it. And then if it's something beyond us, we'll then say, actually, you need to call the plastics registrar. So we're often like just a what do you think kind of an email that we receive, and we're fine with that as well. And that's regional? Yes, regional. So from about Mercer to the top of the North Island, and everywhere in between. Yeah.
Can I get everyone to come back to your seats and we'll move on to the next presentation, please? So you can grab your certificates before you go. So introducing Dr. Paige Foley, and she's going to be talking about chiropractic care in chronic management.
Okay. Hello, everybody. You're going to have to forgive me. I am a bit of a nervous speaker and my voice is running away on me. So let's see how long I can last. So first of all, really excited to be here and to present to you about something that I'm really passionate about, chiropractic care. I don't know if this is something you already know much about or have experienced, but today we will be demystifying that process. So, there we go. So we've got a couple of topics I just wanted to run through, getting into. Oh, can you hear me now? Oh, there we go. I thought my voice was just disappearing, but there we go, we can hear me. Did anyone hear any of the first part of that? No? Okay. Well, from the top. I'm Dr. Paige Foley, and I'm here to demystify chiropractic care and how you can use it in your own lives and in the lives of the patients that you're looking after. So I thought we'd get into the science and philosophy of chiropractic, what it is we're actually aiming to achieve, and cover the different types of care that can be offered and how those can be applied to different patients. And by the end of it, I want you to feel confident that you can reliably refer patients into your local chiropractor, whether that's me or someone else in your area, or even seek chiropractic care for yourself. We can hear me now, right? That's good? Okay. So this is my practice, the Healing Centre in Remuera. So I work with 3 other chiropractors, and we're really passionate about providing affordable, safe, effective care for our patients. So something that's really important to me is making sure that my patients feel heard and feel cared for, and that they can feel very confident going about their lives at their optimal potential. Wow, my voice is really, really croaky. So what actually is, thank you. So what actually is chiropractic? A chiropractor is a primary healthcare professional, and we specialise in the health and wellness and function of the spine and how it relates to the nervous system. So this practice was officially founded in 1895, but has a long history of the use of spinal manipulation as part of healthcare. So there's now more than 100,000 chiropractors worldwide and over 700 in New Zealand alone. So with the main focus of chiropractic being the spine, many people associate it with simply back or neck pain and headaches, but there's actually a lot more to it, and that's what we're going to get into today. All right. Sorry, I have extensive notes. I have a habit of letting my brain run away with me. So to understand how it works, we have to look at what the spine's role is in the body. So the spine helps provide stability and structure for the trunk and protect the spinal cord. So there's situations where the spine needs to be flexible, for example, during running. It dissipates the forces exerted on the body and allows you to function in that way. There's also times when the spine needs to be stiff and stabilised, such as when you're lifting, and this is to protect against injury. So the flexibility and the stiffness is provided by the paraspinal musculature. There's also times when these muscles need to allow for rapid reflexive response to kick in and prevent those injuries. So daily wear and tear can have a lot of effect on these muscles and areas in the body. We want to make sure that the body is functioning in a way that is normal and appropriate. However, when we have our daily wear and tear, whether this is our posture, pause and wait for everybody to shake their shoulders, sit up straight. We've all been sitting in our chairs all day. We want to make sure that the body is not working in a dysfunctional way. Okay. So often issues such as the way that you're moving, injuries, even your posture can play quite a role on causing dysfunctional movement in the spine and dysfunction in the paraspinal muscles. So we have a lot of repetitive microtraumas that we face on a daily basis, or things like sports injuries. So the way that the spine functions, when it's not functioning at its best, it can affect the way that the brain is processing information. And we want to make sure that the sensory information is coming through clearly and effectively to provide the best motor function available. So this is going to be a fun one. The word vertebral subluxation. This is not what you think it is. This is a different term from the one subluxation. We're using this in a chiropractic sense. So this is not a dislocation or a displacement. Instead, we use this term to refer to areas of the spine that are not moving properly. We call these vertebral subluxations. So when a part of the spine is not moving in an ideal way, it can over time cause back and neck pain or cervicogenic headaches, as well as other types of dysfunctions. We make fast, gentle adjustments to these areas to help restore the normal movement patterns, and in turn this influences the way that the brain communicates with the body. Does that make sense to everybody? No one has issues with that one? Just give me a nod so I know I'm not looking at a bunch of faces. All right, so neuroplasticity. The research evidence demonstrating the impact of brain function is relatively speaking quite new. A lot of this is actually done through the New Zealand Chiropractic College, which is about 10 minutes from here and is where I studied. So the research indicates that spinal adjustments have a neuroplastic effect on the central nervous system. So our brain is constantly interpreting all of the information from our senses to create a map of our body so that it knows what's going on inside and outside. So with that never-ending supply of information about what's going on, there is a lot for you to integrate and process from your sensory, as well as information from your sensory organs. So your brain is constantly having to adapt and change every day. From one day to the next, there is complete changes going on. So your body needs to interpret all of the information from your senses and translate it into information. Sorry. I'm going to have a drink of water. Okay. Your brain needs to interpret all of the data from your senses and translates the information it receives based on what it's experiencing now, what it's experiencing in the past, and what it can predict for the future. So there's a lot of background processing that's actually going on in your brain with every movement and function. So the interesting thing here is that your brain perceives a situation, the way that your brain perceives a situation may not always be entirely accurate. Sometimes it fills in the blanks when it doesn't have a complete picture. So your experience of reality is not necessarily reality, but is instead just a perception of what is going on around you. So this is a fun little example of this. If we take a look at the image, can we tell the difference between square A and square B? Which one is darker? Looks like it's probably square A, but actually these two are exactly the same. So this is an example of your perception of reality not actually matching with true reality. So we take information about what we previously know and create an image that makes sense to us, even if it is not the truth. So how does this actually relate to what's going on in the body and in the brain? So when your brain cannot entirely tell what is going on in your body, it makes up its own information and fills in those blanks. I got to stop saying I've been told off for umming. So when there's a disconnect between what you're sensing and what you're processing, you're not able to create a totally accurate body map and direct your movements and functions. So the chiropractor comes along and opens up those pathways by getting the spine to move more appropriately and allowing that communication pathway to move more smoothly. So coming down to muscle proprioception, this is another part of your sensory organs. So beyond just your eyes, ears, mouth, nose, all of that, your brain is actually using the stretch stretch mechanism in your muscles to sense where your joints are in place. So this movement has to give very accurate information so that you can create an accurate movement plan from there. So when your brain's body map is more accurate, you can move more appropriately and respond to issues more accurately. So a very important part of this for chiropractors is the small paraspinal muscles around the upper cervical area as well as down the spine. So these give a lot of information about where your body is in place as well as how everything is moving and functioning. The chiropractic adjustments we do specifically target these muscles so that you can have clearer information about what is happening in the body. So your inner body schema is not just, so we're going to explore this with an analogy. If you imagine you've been living in a house your entire life, you know this house inside and outside. There's a long hallway, and at the end is the fuse box. One day that fuse blows, and you're pitched into darkness. Could you make it down that hallway in order to switch the lights back on? Probably, yeah. You know this house inside out, back to front. You can make it down there without all of the information. However, imagine the night before your kids left a bike in the hallway. You didn't know that bike was there. Now the lights go out. You don't have all of the information you need to get down that hallway without tripping, falling, and hurting yourself. So what the chiropractor wants to do is make sure you know that the bike is there. If not, remove the bike entirely. We want to give you a correct and appropriate perception of the world around you. So this is where the chiropractor comes in. We gently adjust the dysfunctional segments of the spine or vertebral subluxations to restore healthy spinal movement and improve the communication between the brain and the body about the environment and enhancing your sensory motor control. When your brain can accurately perceive your situation, both inside and out, it can control your body better and activate the muscles in the right order. With improved motor control comes a reduced risk of accidents and enhanced performance. So chiropractic care is really all about improving the function of your nervous system so that your patients can function at their optimal potential. So I know a lot of people often begin chiropractic care because of back pain, neck pain, and headaches. And that is very important to understand. But these symptoms don't just come out of thin air. They're often a result of long-term issues. So if we compare this to the straws on the camel's back, we load up the camel, and then the thousandth straw breaks that back. That's when we start to see those symptoms occurring. So it's the same with our symptoms. There might be a lot of ongoing issues within the body, whether that is long-term chronic health issues, it might be a postural stress or an overuse dysfunction. For many of us, it's the ways that we use our body during work. If we're doing a lot of lifting or moving or carrying, that can play a lot of importance on how our body is able to deal with stresses in the future. So another important thing to look at is how seemingly unrelated symptoms might be related to your spinal health and well-being. So, this isn't quite how I made it look. Dysfunctions in the spine can result in poor information from the brain to the leg. The leg is then impacted because it has poor movement, and this can create a chronic imbalance in the body, thus creating a self-perpetuating problem because that dysfunctional movement is then creating further issue with the spine and the nervous system. So the objective of chiropractic care is to restore healthy communication in the body, maintain it over time, and achieve better function, less accidents, and overall health. So this is by making sure that the brain and the body are communicating as effectively as possible and perceiving the world around you to create better movement patterns and better responses to issues. So a study that was recently done about feed-forward activation and how this is used to protect the body in the future. This was done at the Chiropractic College in New Zealand. So I'm going to make sure I say the details of this one right. So in this study, muscle activation patterns were measured with electromyography or EMG to ensure accurate detection of the contraction onset. The researchers in the study found that 19% of participants were not able to pre-activate their core abdominal muscles. These muscles are very vital to protecting the entire body, particularly the back, and they must be activated before you do motions in order to provide that stability. So these patients that were found to be unable to activate those muscles before movement, they were also found to have that same issue 6 months down the line, showing that this isn't a one-off issue, it's an ongoing problem that the body is not able to correct on its own. So these patients were also found to have dysfunction or vertebral subluxations within the pelvis and the lower back. So they were given 1 session of chiropractic adjustments. After this, it was found that they had 40% improvement in muscle engagement, and that's after just 1 session addressing the pelvis, no other part of the body. So something that's really important about this is that these were completely asymptomatic students. They were healthy and fit and were not, did not have a history of injuries. So it is like before the straws on the camel's back have built up to breaking point, that's where these people were at. So it's suggested that poor control of these stabilizing muscles may be the cause of people developing pain. Oops. It's suggested poor control of these stabilizing muscles may be the cause of people developing pain or sustaining an injury in the future. From prior studies, we know that people with back pain have delayed activation of these core muscles when performing various moves. We also know that their brains are much less aware of what's going on in their lower back. So this means that their brains are either not receiving the information or not able to provide the information. So the brain does not know what's going on and cannot send an accurate message about what to do further. So let's get into some cases. How can it be beneficial in acute cases? So we've likely all experienced some form of acute back or neck pain in the past. We know that it is very debilitating for you in that instance. Whether we have had a lifting accident, a sports accident, or any other issue. You might have even just woken up with a sore neck. The amount of times I hear that. So these sudden onsets of pain can disrupt our daily lives. A lot of the cases I see are just like these, whether the client comes in as soon as they've had the issue or days or weeks following that. They will have been experiencing poor movement, poor sleep, and worsening symptoms. A very common phrase I hear is, "Oh, I had this injury 2 weeks ago. I thought it would go away on its own, and it's gotten worse." Then we check and adjust them, and by the end of it, they go, "Oh, I should have come in 2 weeks ago." So try to be part of that process. If we can get people in sooner, we can have a lot faster care and quicker responses. So as a chiropractor, I check and adjust the body to make sure that it is improving the function and communication. This is going to help speed up healing. So I don't claim to directly treat the issues. I am helping to heal the body so that it can function at its best and you can heal yourself. Some common issues that I see, these are your back pain, neck pain, headaches, sports injuries, whiplash injuries, pain during pregnancy, extremity joint pain, TMJ dysfunctions, muscle spasms, acute rib pains, acute sciatica, and following falls. This is just a short list of some of the things that I've seen in the last couple of weeks. And I could go on and on about different issues that people have brought to me. So the acute care journey, this can either begin with a brand new client or with one of my existing clients. So often if it's someone new, they will have waited that 2 weeks waiting for the issue to go away on its own, and they're in a slightly worse state than they might have been. So they've been spending the last 2 weeks in pain, fed up, they're not sleeping, they're getting angry and they're getting frustrated. By comparison, the clients that I already have under care, when they experience a new accident or a new presentation, because they're already under regular care, they get that seen to straight away. It might be the day after, or it might be the day they woke up with pain. So they're in a much better state to get ahead of the game. So these people are then thoroughly assessed to determine what's actually going on and come up with a care plan that's going to get them to where they need to be. These care plans are all tailored to each individual person and the requirements of their bodies. So I will go through what an actual adjustment entails before you get scared of clicking and cracking. So these people are then potentially sent for x-ray or an external referral if they need to. Some chiropractors are able to do this within the office. Others will send out for x-rays. They are also then given their spinal adjustments, some soft tissue therapy and lifestyle recommendations that are going to help aid them on their healing journey and get them back to function at their best, as well as preventing further injuries. We are also ACC registered, so we're able to put ACC claims in directly without GP referral, so that's quite a benefit for many people. We will give them a relief care plan to begin with, and that is followed until they reach stabilisation. At that point, we can aim towards something higher, perhaps optimisation, regeneration and optimisation, to continue care if they desire. So looking into some more chronic cases, these people are often very fed up and exhausted by what's going on in their body. These can be a lot more complicated to handle and come with a lot of emotional effects as well. So these can be quite important to deal with in the right way. So people have been dealing with reduced quality of life and are in a significant amount of distress often. So these people have learnt to either live with this dysfunction and this pain or have had limited success with other therapies and have finally come to chiropractic to see if that might be the answer. These people can also be ones with chronic ongoing health issues. So just this week I've been looking after someone with ankylosing spondylitis, someone with lupus as well, and managing what is actually going on in their bodies. I'm not going to cure those issues. I'm going to help their bodies work at the best that is available to them. So these are some of the issues that you might see as well, that you might like to refer to a chiropractor. So you've got your chronic neck and back pain, your headaches and migraines, joint degeneration, fibromyalgia, scoliosis, untreated long-term injuries. Post-surgical rehab is a really big one. I've been looking after someone that she started care in order to prepare for a hysterectomy and has now followed on her care after that to help her body heal in the best way possible. Other ones are your overuse syndromes and your chronic fatigue. So the chronic care journey is going to follow fairly similar to the acute journey. You're going to have a complete assessment and care plan developed to suit them. However, this does usually take a little bit longer to achieve because there is a lot of underlying dysfunction. So there are a lot more straws on this camel's back and maybe more on top after it's already broken. So there's a lot more to uncover and clear away. These issues might also require co-management with other healthcare professionals. So I'm able to make connections with other practices around to make sure that they're getting a total well-being care plan. We're always aiming for each individual's unique optimal potential. So that is the best that your body can do with what we already have. Again, we can move through relief care to stabilisation and optimisation care. So this one is wellness care. This is a little bit different from your acute or your chronic care. These are the people that get in before the camel's back has broken. So it's not just limited to addressing the pain and the conditions, it can also be a proactive approach to healthcare and striving for optimal well-being. So some of the things that I just generally manage for my wellness patients is going to be your stress management, improving your sleep quality, improving sports performance, looking at ergonomics and posture, immune support. Mental health plays a really big one. I don't know if anyone's dealt with long-term chronic back pain, but that can have a massive effect on your mental health. Respiratory support, this was a big one following COVID, looking at rib function and diaphragm function. Support during pregnancy as well as the fertility process beforehand and the menstrual cycle as well. We're looking at injury prevention and sometimes weight loss as well, because getting people moving and functioning at their best means that they can get back to exercise, their body's able to process the food that they're eating better, and that can have a massive effect on your life as well. So what can you actually expect during care? Your first appointment with a chiropractor will typically involve a very detailed health history. This is going to cover everything that's going on for you currently and what has happened in the past. We're also going to look at current lifestyle factors that might be affecting your well-being. This is followed by a thorough physical assessment. This is going to include your neurological testing, your orthopedic testing, as well as a range of chiropractic tests as well. If it's appropriate, we may also refer for x-rays. So again, some chiropractors have this in office if they're a bigger practice, otherwise that would be referred out. And then if the situation calls for it, the adjustments would be performed on that first visit as well. So that's going to vary from chiropractor to chiropractor. Some will perform adjustments on that initial consultation, others won't. So if that is something of importance to you, I would follow up with each chiropractor as you want to communicate with them. So for x-rays, the importance there is actually looking at degeneration, structural variants and injuries so that we are safe to continue with our adjustments because the last thing we want is to make someone feel worse or be dangerous in any sort of way. Okay, so looking at the referral process, patients can refer themselves to a chiropractor, but a lot of times we actually see referrals come through from GPs, dentists, physiotherapists, massage therapists, and a lot of other specialists in order to co-manage those cases. As I said before, we have the ability to make our ACC claims ourselves, so we don't need that external referral, but we are always appreciative of that.
So phases of care. Depending on a client's presentation, the care plan will vary. We've talked a little bit about the relief care. So these are more intensive, higher frequency appointments to relieve suffering. At this stage, you might be looking at 2 to 3 appointments a week for a short period of time to really stabilize that body. As we move into optimization care, we're looking at regular appointments to heal underlying issues once the pain has been relieved. At this stage, we would be looking at a less frequent care plan. Depending on the person, this could be once a week, once a fortnight, once a month. As we move into wellness care, these are much less frequent appointments to maintain proper function and well-being. So once your body has been trained to look after itself in these new movement patterns, the regular care is able to hold those in position. If we think of it like going to the gym, if you go to the gym more frequently, you're going to see a lot faster results. If you go once or twice, you might feel different for a day or two, but you're not going to have any long-term effects. It's the same with seeing a chiropractor. We start off with our high-frequency care. That's where we're seeing the biggest changes. We start to increase that fitness. And then as we move into our optimization and our wellness care, the body has been trained to look after itself. It's able to just do what it needs to do. So a couple of different types of chiropractic care that might be important for you to look out for, whether you're referring yourself or referring a patient, because these are going to be important. I really wish that was all showing on the screen. That's my bad. Sorry. So there's different styles and different techniques. So these can be modified to suit the patient depending on issues going on in the body already. So some patients love being adjusted manually or by hand. Others prefer an approach that is a lot more gentle and doesn't include that clicking noise that is often associated with spinal manipulations. So some more specific types of care. This one here, diversified, that is the most common one you'll see, and this is the practice of adjusting by hand. So typically by hand or using a drop-assisted table. This is suitable for most people, but less appropriate for those with significant degeneration or issues with getting on and off the table. Sorry, I'm really losing my voice. Okay, so manual adjustments are used to target those specific spinal joints and restore those normal movements. So yeah, again, not so suitable for those with severe degeneration. Most chiropractors will combine this with the use of an activator. This is an adjusting tool that can provide a very specific low force adjustment to the joints. And this is going to be much more appropriate for your older clients or those who are more sensitive. So sometimes that's your people with fibromyalgia or other hypersensitivity issues. So there's other more gentle techniques as well. If you see these words about, that's what they are. So that's your sacro-occipital technique, your neuro-emotional technique, or your network spinal assessment. These look at the body as a whole picture in a holistic sense. So these ones use lower force manipulations, addressing the dysfunction through the muscles, or by using a wedged block or gentle motion patterns. So these can be very effective for those with chronic health issues, such as inflammatory joint conditions, or those with more complex emotional issues. So that's something else that can be addressed via chiropractic. So pregnancy care. I thought this would be a little bit more fun than looking at the gory burn images. That one's not one I deal with a lot. So that was quite a shocking start to the day. So most chiropractors are skilled in pregnancy and pediatric care, although some particularly specialise this, and they can provide a profound difference in the ease of carrying and birthing. So chiropractic care can be very beneficial throughout the pregnancy to support the many changes that go on in the body. So pregnancy care, clients often see alleviation of pain and discomfort, including sciatica and joint pain. They have better sleep and mobility, and effective posture support, as we're starting to carry a lot more weight in a different position from how we used to. We are focusing on the pelvic mobility and function for an easier labour, as well as the fetal position in preparation for that. So these are both very crucial when preparing for a natural delivery. And this can create a much easier labour and delivery for both mother and baby. So after the birth, chiropractors can also provide care to the baby. So supporting healthy growth and milestone achievement. We're assessing neurological and structural challenges that may be distressing for parents. I don't know how many people in the room have kids, but if you haven't seen them hitting those milestones, you can become very, very stressed. And having that chiropractor on your side, assessing those issues and helping them to function at their best and meet those milestones is very, very important. So often people come in following a traumatic or complicated birth. The process of being born is in itself very traumatic due to the squeezing of the head and the pulling and twisting through the birth canal. So common issues include trouble with feeding and sleeping, colic and digestive issues, and neurological development. Some parents also choose to bring their kids in for proactive care, helping them to achieve better wellness and proper neurological function. We've got some happy babies. So care for infants is extremely gentle and does not include those strong spinal manipulations like you would see for adults. Instead, a touch and hold approach is used, and this is typically no more pressure than you would use to put a contact in your eye. This is very, very gentle. And so a lot of work is actually done looking at the cranial function and the upper cervical region, as this is a very influential area and can affect a lot of what is going on. So some common issues that I have seen for people bringing in their kids is if baby is choosing not to feed on one side or the other due to issues in the neck, we can often look at that. A kid we saw this week was having issues banging his head a lot during the night, and his parents were having to stay up all night, every night, just to keep an eye on this kid. So just by looking after this child, he has actually reduced that banging. His parents can sleep through the night, he can sleep through the night, and we've got a happy family there. So as we move on, so further paediatric care, so looking at how we adjust children as well. So it can continue as they're growing, supporting them through all of the stages of life. So it's really not uncommon for chiropractors to look after mum during the pregnancy, through the baby as it grows into a child, and actually into that child's own pregnancy once they are a grown-up. Seeing those generational chiropractic families is a really inspiring thing, and as a young chiropractor, that's something I hope to see as well. I have spoken very fast and I've gotten to the end of my presentation. I have no idea what the time is. I'm good? All right. So last but not least, just wrapping it up, the objective of chiropractic care. So restore healthy communication in the body via the spine and the nervous system, maintain it over time, and achieve better function, less accidents, and better overall health. I'm Dr. Paige Foley from the Healing Centre in Remuera. If you would like to learn more about chiropractic or actually get under care yourself, you're more than welcome to come check me out, come meet for a coffee, meet for an adjustment, and we can get you back on track and living at your optimal potential. Thank you.
She's really good, so I do recommend her. Awesome. Perfect. Just introducing our next speaker. Sarah's just coming up. Dun, 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 dun. Almost there, guys. Amazing. Perfect. I'll hand this over to you. Do we have a clicker?
So just click that way to go through. Thank you. Hi everyone. Sorry, I'm really aware that this is your last session after a very long 2 days. So I'm actually going to be really brief, and I promise we'll be finished by 5. So my name's Sarah, and I work with the community geriatric team at Middlemore Hospital. So I've just come today to give a little bit of an introduction or overview of our service, what we do, and how to refer. If you're not from the counties area, other areas, Auckland and Waitemata, have a very similar service. So hopefully there'll be something in here that's interesting. So who are we? The Community Geriatric Service at Middlemore, we've got 6 full-time equivalent geriatric nurse specialists, we've got 2 senior geriatricians, and we've also got a community geriatric registrar. So there's quite a good group of us there, and the service has been going for a while. We cover all of the county's Manukau area, which is quite huge, all the way down to Bombay, out to Clevedon, Kawakawa, and then east to kind of Bucklands Beach, over that way. So big area. And what do we do? I guess the overall aim of our service is to provide specialist geriatric support to primary healthcare teams, and we also work a lot with the aged residential care sector, so going into private hospitals and rest homes. And our ultimate aim really is just to improve health outcomes for our older adults, both living in the community and those who have transitioned into care. And I guess if we look at why this is so important, is there's a lot of talk about how our population is ageing, and there's lots of statistics around it, but I quite like this graph because I'm quite a visual person, and you can see those changes. So the way that the population is aging between 2018 and 2034. And I guess the group that we're primarily involved with is the older age group. So people, the bulk of the people that we would be involved would be 80 or over, but particularly the frailer older adults who are 85 or older. And I guess one of the issues around all of that is that as people age and with chronic health conditions, they have greater need of healthcare services. So that's where we hopefully come in. Just change it on there too. So who do we accept for a referral, or who can be referred? And basically the criteria is really broad. So basically any patients who you feel would benefit from a comprehensive geriatric assessment. And we really focus on patients who are possibly being at home has become a little bit more tenuous. They may be needing more support. They're at risk of losing their independence. So a lot of our work is around supporting older adults to stay well, to stay healthy, and to stay living in their own home. Because that's, at the end of the day, that's what most people want to do. They want to stay in their own home for as long as they can. And some good examples of the sort of issues that we might be referred are people who have a history of falling, people who are increasingly frail, patients with memory or cognitive problems. That's a big component of the work that we do. deconditioning, so often that might be after an acute illness or a slow kind of deconditioning over time. Concerns about safety, coping, not being able to attend to daily activities in the same way, fragile supports, so people who are potentially isolated. And another big one is carer stress, because we have a lot of family members who are caring for an older adult, and sometimes that can become stressful as the person needs increasing amounts of support. We also see patients who might need a medication review. There's a lot of literature around polypharmacy and the potential harm of various medications as people age, and the different way that those medications are processed by the body. Another really big part of our work is post-discharge follow-up. Those referrals usually come from the hospital, so it might be an older adult that's come in with an illness, come in for surgery, and the team in the hospital just feel that they'd benefit from some follow-up post-discharge. And then we also do level of care assessments. So we do the assessments for entry into rest home or private hospital. And I guess the approach that we take is to, for the people that get referred to us, is to do what we call a comprehensive geriatric assessment. And there's lots of literature around this, but in summary, it's a holistic assessment to determine the medical, psychological, and functional capabilities of a frail elderly person. And then from that assessment, the development of a person-centred care plan. And the ultimate aim is to reduce functional decline, support the person to maintain their independence for as long as is possible, and to improve quality of life. Let's flick that one on there as well. And the key elements of a comprehensive geriatric assessment, it is a very broad assessment, and I feel that one of the areas that our team is really lucky in is that we do get to spend a decent amount of time with the people that we go out to see. So we go out, meet them in their homes, and probably have around about an hour with them to go through kind of a lot of different aspects. So we'd look initially at the medical side, you know, what comorbidities do they have, what medications they're on, nutrition. And then we look really closely at that person's function. Are they able to attend to their basic activities of daily living, the instrumental activities of daily living? We look a lot at gait and at balance, and at how active that person is and what might be preventing them from being active or being able to exercise. We also look at psychological function. So I guess as part of that we do a lot of cognitive testing, so different memory tests. We also assess for mood, and we work quite closely with the mental health services for older people team. We look at the social aspect, how well is that person supported, do they live alone, do they have family, and then cultural supports or cultural needs. And then I guess an environmental assessment as well. So is the place that they're living suited to them? Are there stairs? Do they have a medical alarm? So again, it does feel like a real luxury to be able to look quite broadly at all of these things. And then from that, we develop, I guess, a plan of care. At the moment, our model is just to go in once, to do a comprehensive assessment, and then to do a plan. So we would look at whether the person needs to have a needs assessment. Do they need home-based support services? Do they need cultural support? Are the district nurses needed, for wounds or for a continence review? We work really closely with the community community health services, so occupational therapists, physiotherapists, social workers, And then we also work with other support services that aren't associated with the DHB. Sorry, I shouldn't say DHB anymore. With Te Whatu Ora, so Age Concern, Toa Pacifica, we refer to a lot, Dementia Auckland, Shanti Niwas, and there's a whole group of others. That was just a kind of few to kind of add in there. So trying to work out what support this person needs and how we can help them. And then we send a letter to the person's GP, letting them know that we've been out, summarising the assessment and what we've kind of recommended or put in place to assist this person. So how to refer? E-referrals via Care Connect, I think. Is that what you guys all use? Yep. So for counties, you just look under health of older people and then under community geriatric service. And very happy for practice nurses to refer. Often you're probably the group of people that pick up a lot of this stuff, that might have a little bit more time with the person or who might be taking calls. Really problems or is falling a lot or has a kind of an age-related or does it make sense? Yes, so we do talk about that younger age group that you can have a 65-year-old that has a similar issues to an 85-year-old and if that person has aged early in practice. Do you guys use the health pathways? Yeah. I use them often for older adults. There is such good information there, and I'm constantly kind of going back to it. So I would really encourage you to actively use that. So I just popped the older adults health one up there, and then I think this one was around. I just randomly picked one, but about medications and older adults and that need to try to minimise polypharmacy or potentially reduce medications as people get older. We had somebody that we saw recently that was on 3 different blood pressure lowering medications and they were falling a lot. And, possibly, I'm sure at some point in their life they probably needed a couple of agents to manage their blood pressure. But now that they were older and more frail, 3 had become sort of inappropriate. So that's a really helpful one. And there's some really good guidance on there on screening for memory problems in primary care. Minimal also has a memory team so you can refer separately to the memory team. Not all areas have that, but Middlemore does. So if the problem is, very specifically around memory, then you can refer separately to the memory team. But we also do memory, so if, for example, it's sort of memory and falling and some medical issues, then general geriatrics might be the better way to refer in that case. That was a very quick run through. Sorry, I've got you've got 2 minutes till 5 o'clock. Does anyone have any questions? Yeah, definitely a combination. So ideally, if you're able to do it first in primary care, it gives us a real head start. So the best quick ones are, there's a few, but there's the GP pod. Does anyone use that? So Mini ACE is perfect. Yep, absolutely. And then the RUDAS if the person has English as a second language, the RUDAS is great, and it's a similar length to the Mini ACE. It's also scored out of 30, and that just gives us a little bit of a head start. Any other questions? Thank you, and nothing else? No, good. Enjoy your awards. I think that's next.
One more presentation.
Oh, one more presentation.
You're welcome. Lucky last, Roxanne. Thank you so much for coming out.
Sorry
I really do appreciate it.
Spoke very quickly.
What I'll do is I will collate all the feedback and I will send that to you. So thank you so much. Oh, cool. It's dead. It just died.
All right, loud voice. Okay.
No, he'll get that sorted for you. You have it. And as you told you, very engaging. Which one?
Hello everybody, hi, my name's Roxanne. It won't be an hour long, I promise, okay? You'll be okay to go home. For those of you who might know me, I'm one of the urgent care doctors. I predominantly work in Ascot, but I've been in every single White Cross clinic. So if you work over there, you probably might recognize me. Hello everyone. So basically today I'm going to be talking to you guys about reading ECGs, reg file presentations. I say urgent care setting. That's more the acute patient. I know local doctors, you get just as many acute patients as we do, and you've got also combined clinics, so you have plenty of urgent care for you guys as well. Now, out of everybody in this room, just a show of hands, who deals with ECGs in any way, shape, or form at work? Pretty much everyone. Who likes looking at them? Okay. Who doesn't like them sometimes? Who doesn't like looking at them? That's okay. Hopefully at the end of this session, a few more will say yes, that you enjoy looking at them, alrighty? So what we are going to do is going to go back to basics a little bit. If you understand how the heart works and what it does, it's a lot easier to understand what an ECG actually is and what it actually shows, because all it does is reflect the heart and its mechanisms. We'll then look at a couple of red flag ECGs that we commonly see, and I'm going to give you guys just a little bit of a framework that you can always use. At the end of the day, nursing staff are always the first pair of eyes on an ECG. So just a couple of questions that you can always ask yourself if you're stuck and worried, and how to recognize an ECG. Even if you don't spot diagnose, see if something's wrong, you can try and figure out if it's normal or not. And then we'll just talk a little bit about red flag presentations, who needs ECGs and why, etc. So, to begin with, the cardiac cycle. So, It's involved of two parts. So the first part is something called systole, and the second part is something called diastole. Systole is contraction of the heart. Diastole is relaxation of the heart. That's all you need to remember. The heart has to contract to pump the blood, and it has to relax to enable the blood to come into its chambers. So a little bit of a refresher on cardiac blood flow. Right side of the heart, we probably already know, is responsible for taking blood from the body to the heart. It takes all the deoxygenated blood that we've been using, takes it up to the center of the body. That is essentially what you've got is you've got your SVC and IVC, they're your largest veins in the body. They take it into the right atrium. From the right atrium, it goes through to the tricuspid valve, goes into the ventricles, and then that pumps it up through the pulmonary valve into the pulmonary artery, which then goes to the lungs. A refresher on the left side of the heart. Now, the left side of the heart takes all of that oxygenated blood from the lungs, and it takes it to the rest of the body so that we can actually function. Now, this works via the pulmonary vein, goes into the left atrium, through the mitral valve. I should use this, I forgot this works. Through the mitral valve, into the ventricle, into the aortic valve, and then up through the aorta, and then onwards to the rest of the body. I'm sure we already probably remember that, but I thought it's worth to have a refresher. Now, cardiac conduction. So cardiac conduction is basically the electrical activity of the heart. There's two things you need to know about how this works. The heart has two types of cells. It's got pacemaker cells, and it's got contract cells. Pacemaker cells are pretty amazing. They're unique in their whole body in terms of they generate their own action potential. That means they generate their own electricity potential to work and fire off signals. Those are these ones. So they're involved in the actual electric process. And then you've got your contractile cells. They make up the 99% of the heart. They just respond to the pacemaker cells, and they contract, helping the blood go around. So the bits that you need to know and the bits that are important, first is the SA node. So that is the original pacemaker. So people who have pacemaker replacements, that's what the new piece of kit does for them, alrighty? So it sets off the heartbeat. So then that goes down from the SA node, you go down to the AV node, so we're following these yellow lines here. SA node, that starts in the atrium, down into the AV nodes, goes through into the bundle of His, down into the Purkinje fibers, and then that contracts the whole heart. Oh, gosh, sorry. There we go. Sorry, I pressed too hard. Alrighty, so these are the only 4 pieces of the pathway you need to remember. There's tons more, but it's needless. You don't need to remember the rest of that. It's not important. These are the most important parts of it for you to understand how it works. So, back to diastole and systole. What was systole? Contraction. Awesome. And diastole? Boom. Exactly. Rightio. So, in early diastole, so this is right at the beginning of the heartbeat ticking off, blood flows from the veins into the right atrium, and it flows from the pulmonary vein into the left atrium. This is done passively. So that's gone through. In this stage, the pressure in the ventricles are really low. So the ventricles are just relaxed, they're sitting, they're chilling, they're not doing anything. And the atrium are being filled with blood. In the middle of diastole, now this is where you get where the atrium is being filled with blood, the pressure's going up. As the blood fills, like a balloon, the pressure increases, right? So the pressure's increasing the atrium. So slowly the pressure in the atrium overtakes the pressure in the ventricles. What does that mean? It means that blood can then slowly start to push through these valves into the ventricles. So this is a passive process still. It's all about pressures. Towards the end of diastole, though, you've got pretty much a similar amount of blood in the ventricles as you have in the atriums. Because there's no longer a pressure difference. They're both got a decent amount of blood in them. And that's when the atrium needs a little bit of help to push through that last little bit of blood into the ventricles. That's when the SA node kicks in. Alrighty? So the SA node sends off a little action potential, and that causes the atrium to contract more. That action potential goes from the SA node to the AV node. And what the AV node does is it just slows down that little bit of electrical activity. That gives the atrium time to really empty out all the blood that it has into the ventricle, because if that action potential went straight from the atrium to the ventricle, they'd both contract together. You don't want that. It's not going to actually help the passage of blood. So that what the AV node does is it just slows it down and gives that ventricle enough time to fully contract. And then when the atrium's finished contracting, all the blood's in the ventricles, it's the ventricle's time to contract. So this is what we call systole. When we talk about systole and diastole in terms of the heart, we're always talking about the ventricles. So now for the ventricles to contract, the AV node lets that action potential run down through the bundle of His that runs down the heart septum in between the two ventricles. Then this action potential runs up through the sides of the ventricles, and then that causes the ventricles to then contract. When they're doing this, the pressure increases between the two valves, the tricuspid and mitral valves, they close, and then your pulmonary and aortic valves open up, and then they let the heart push out the blood from the inside, either to the aorta or to the pulmonary artery. So this is just an extension of that. So once that's happened, so we've finished the electric cycle, both the ventricles and the atriums relax, and then that lets the cycle start all over again. Any questions? Happy? Awesome. Alrighty, so now we're going to get on to the ECG portion. So we've spoken about how an ECG is a reflection of the electrical activity of the heart. Alrighty? So if I tell you that this PR interval it's atrial systole. So it's when the atrium is contracting. What does that make this little P bump? What do you think that is? Yeah, it's the P wave, but what is it in the electrical system? The SA node, correct. So that's the little SA node making it start off. What do you think that makes that PR interval? What comes after the SA node? AV node, exactly. So this is the AV node slowing down that action potential. And then your QT interval, that's your ventricular systole, so that's your ventricular contraction, right? So what do you think that makes the QRS portion? What comes after the AV node? Bundle of His, exactly. So that's your bundle of His portion, and that continues on to just this little area, the ST portion as well. So that's your bundle of His going into the Purkinje fibers, passing that action potential over the ventricles, causing the ventricles to finish contracting. That T wave, so that's just the recovery wave, okay? So that's the bit where both ventricles are relaxing, atrium's relaxing, we're going to start all over again. Does that help make a little bit of sense? Any questions thus far? Yes? Yes, okay, so PR interval, that's the contraction of the atrium. QT interval, that's the contraction of the ventricles. P wave is the SA node. The PR segment is the AV node. The QRS is the portion of the bundle of His and Purkinje fibers. It's the contraction of the ventricle starting. ST segment is that traveling around that ventricle portion. And then the T wave, that's just the repolarization. So that's just the relaxation, again, of the ventricles. Perfect. Alrighty. So we're going to link this knowledge to red flags, because now you know what the ECG shows, right? Okay, so do you remember I told you I'm going to teach you a couple of questions that even if you can't figure out what's wrong with the ECG, you can figure out if it's a bad or good ECG, correct? So, number one question. There's going to be 4 of them, okay? Number one question, is the rhythm regular? So, are we seeing a full heart cycle? Yes. First one, yes. Second one, no. Exactly. So that's just your sinus rhythm. That's AF. Now, AF doesn't look, sometimes it's a little bit more obvious than this. Sometimes you're missing P waves. Does anybody know what AF is? Exactly. Now, atrial AF is essentially, it's just this SA node being like, I don't know how to keep pace anymore. So it sometimes fires, it doesn't fire, it's a bit all over the place. So you'd get irregular heart rates, and then you get P waves, and you don't get P waves. What other rhythms can give you irregular heart rates, apart from AF? Atrial flutter, yes. Sinus arrhythmia, yes. Ectopics, exactly. Heart blocks, yes, absolutely. So they're really what you're thinking of when you see those things. The second one, is the rhythm fast or slow? That means, is the pacemaker pacing properly? You've got your fast one here. Does anybody know what this would look like? Do you know what we might call this? Sinus tachy, exactly. And then here you've got your slow heart rate, your bradycardia. What would you say is bradycardia? Under 60, correct. Who are the exceptions to that rule? Athletes. Exactly. Beta blockers, young people, athletes. So clinically, under 40, go grab the doctor ASAP. Up to 50 is still run it by the doctor, but if they're fit and they're healthy, just mention that, because that's a bit more forgivable. Alrighty, so the third question, if it's fast, is the QRS broad or narrow? What does the QRS represent? Exactly. So, if the QRS is normal, do we know what that might mean then? So the QRS is normal, but the heart rate's fast. Where's the problem coming from? Exactly. So that already helps you figure out your differentials. It's nothing to do with the ventricles, so it's the other problems. What is this top one? Does anybody know? Sinus tachy, exactly. So that means it means it's before the ventricles. What's a common cause of sinus tachycardia? Dehydration. Yes. If I said we have a fever, we've got a high heart rate and a fever, what would be worried about? Sepsis, exactly, yeah. What's this one? Atrial flutter, yes. Now, the thing with the atrial flutter and AF is with the atrial flutter, you see this classic, this is what we call sawtoothing. That's your classic atrial flutter. That wouldn't need to go to a hospital. We're not going to do anything for that in the clinic. What's this one? SVT, exactly. Clinically, how high does the heart rate have to be for it to technically be SVT? 200? Not 200. How many? 180, not 180. Up from 140? 150, yeah. 150 and above, you're really looking at SVTs. Below that, you're still in that sinus tachycardia range or AF, fast AF range. BTAC, exactly. BF, yes. Now, if you see these two on the monitor when you hook up a patient, what are you going to do? Just leave them. You don't need them. No. What are you going to do? 2 things you're going to do. Pads and... Are you going to pull the doctor in, or are you going to do something else? Press the bell. You're not going to leave that patient. You're going to pull that bell, all right? Don't go grab a doctor, no knocking on doors. You're going to pull that bell, all righty? All righty. So, any questions? Sorry, I should have asked any questions thus far. We're happy to keep going. Awesome, right. So, the fourth and final question you're going to ask yourself, we've gone through all those questions, everything's normal, is the ST segment normal? What does this look like? ST elevation, exactly, is STEMI. What does this look like? Depression, exactly, and end STEMI. What are you going to do with these two patients? Go grab the doctor. Alrighty, awesome. So just to recap your 4 questions that you're always going to ask yourself, and you'll always figure out if it's a bad ECG or something that you can just slowly walk to the doctor quite leisurely and ask them what they think. Is the rhythm regular? Is it fast or slow? If it's fast, what does the QRS look like? Is it narrow or broad? And finally, is the ST segment normal? You ask these 4 questions, you're not going to go far wrong. There is obviously still a very complex, weird, and wonderful ECGs, but they're not going to be bell-worthy. Alrighty. Okay. Other red flag spot diagnosis ECGs, these are just common things that I say common, they're not super common, but they're worth knowing because they're also things that you should probably push that doctor who sat at the computer and won't get up to go see your patient. You should probably push them a little bit for. Does anybody know what this is? I'm going to point, you can take your time looking at it. I'm going to point to the little clue with my very shaky hand. Pardon? Flat T wave? No. Peak T wave. What does a peak T wave mean? Potassium, exactly. So remember this little hand diagram for you. So high potassium causes these high peaked T waves. Low potassium, low T waves with a bit of ST depression can be hypokalemia. This is incredibly rare, I have to admit. I've seen this I've never seen it in urgent care. I've seen it in the hospital a few times, but I've never seen this one. So pretty rare if you do end up seeing it. Does anybody know what this is? This one's a bit mean, so I apologize, but it's worth learning about because you might hear doctors like throw it out every once in a while. Mean, I'm sorry. Maybe if I point to, I'm going to keep my hand steady. Do you kind of see that bit? Yes, it's to do with the PR, very correct. So I'll put you guys out of your misery if you want. Pardon? Yeah, not quite. It's to do with the PR. It's something to do with the PR. You get these, if I told you the patient who's come in, typical patient, young teenager, sudden loss of consciousness. Oh, good try, but no. I see where you. Good thought process. That's not far off. It's mean. I'm sorry. So this is Wolff-Parkinson-White syndrome. Alrighty. So this is what you call the delta wave right there. So basically what happens in Wolff-Parkinson-White syndrome, so in a normal person, from your SA node, it goes to your AV node, down the bundle of His, up to the Purkinje fibers. With Wolff-Parkinson-White syndrome, they have these weird accessory pathways. So when they set off the action potential from the SA node, they can bypass the AV node, and it just jumps straight into the ventricle. The reason that this is significant is, if these patients develop AF, and especially if we give them things like beta blockers, calcium channel blockers that affect that SA node, it can cause that misfiring to happen so frequently that they actually can end up in VF and VT. So it can be fatal. So that's why we care about these patients, is that we need to know about them and they need to know about what they have as well. So that's just by the by. That's why on all the young kids who come in with query fainting, you might get the ECG doctor being like, can you get an ECG? But why? Just fainted. Alrighty. This one. This is another mean. Some of these are a bit mean, but I just thought they'd be good for you guys to know about. Yes. No, they're almost always, you can see it. Yeah. I'm going to point to the area. I'm really sorry if it's small for you guys in the back. I should have done handouts. I do sincerely apologize. I can make a handout and give it to Natasha that you guys can take home with you at a later date if you would like. Do you see this? It's something called, yes, Scoopy. Yes, exactly. We don't know what it's called. It's Scoopy and elevated. It's exactly that. It looks a little bit like a horse's saddle. Have you ever heard the term saddle-shaped? Anybody heard it before? Saddle-shaped? No. So this is pericarditis. You get this saddle shape. So you get an elevated ST saddle shapes, and then you get this drop in PR. Pericarditis is important. It's normally secondary to a couple of things: chest trauma, infection, or surgery. The thing about pericarditis and the reason why it's important is you can end up with essentially swelling in the you get swelling in the pericardial sac. That can lead to inflammation within the sac, and that can lead to buildup of fluid in the sac. So that buildup of fluid in that sac can then put pressure on the heart, and it stops the heart from being able to essentially function and contract properly. What is the common clinical symptom that the most worrying symptom that a patient would have if they had this ECG and you're going to make the doctor want to cry because they're really, really worried for that patient? Does anybody know what clinical sign they would have by any chance? Yes. Correct, incredibly correct, yes. So chest pain, it worsens with motion, especially sitting forward. What clinical sign in the observations? It's one of the observations that if you have this and you have this ECG, you're going to be a little bit worried. Fever, no, good try. But they'll often come in with fever too. Heart sounds, yes, muffled heart sounds is the clinical finding that would worry you a lot. What would muffled heart sounds, what might that mean? It's okay, but you're on the right track. The clinical sign would be muffled sounds. What would be the observation that would worry you? It's in the observations. Which observation would really worry you? Blood pressure. Their blood pressure tanks. Similar to if you've got a tension pneumothorax. They get a built-up of pressure in the heart. You're not getting enough blood volume to go around the body, the blood pressure tanks. That is worrying because that means that they're going towards cardiac tamponade. So that's why you're scared, and it's fatal, and they need a needle into their heart. Hopefully you'll never have one of these. It's an incredibly late sign, and it's, again, I've seen it once in A&E, once. It's not common. It's just terrifying if it does happen. Alrighty, the last ECG. Does anybody know this? If anybody happens to work with Mark Curtis, he mentions it a lot when he reads ECGs. I'm just looking at the Ascot table here. Do you know why? You just said it because I said Mark, right? Yeah. So this is Brugada syndrome, basically. So Brugada, you get, one second. So Brugada, you get this coved ST and this T-wave inversion. Now, Brugada, I didn't hear that much about when I was actually in the UK. When I've come here, we hear about it a lot because it's very, it's mainly in the Southeast Asian population. It's so common in that population that they actually used to have colloquial terms for it. So I found this was quite interesting. I don't know if anybody recognizes. So in the Philippines, you call it bangungut. I hope I've said that right. To rise and moan in sleep. And in Japan, pakuri, sudden and unexpected seized phenomena. And in Thailand, as lei tai, death during sleep. This. So brigada sign. So you get this coved ST and this inverted T wave. Yeah, so it's always in V1 to V3, always. The problem with Brugada syndrome is it comes and goes. You might not get it on the ECG, it's really difficult. It comes and goes, it's a cause of sudden death. They say that peak death is at around the age of 41. It's mean, and diagnosis has happened in somebody as young as 2 and somebody as old as 84. So you can live a completely normal life with this syndrome. It's just difficult to pick up. But yeah, so something to know about because it's potentially fatal. So this is something you never want to miss, but rare. Any questions? I'll go back. Any questions this far? No? Cool. Alrighty. Who should you perform ECGs on? Throw the presentations at me. Who do you perform ECGs on without asking the doctor? Who are you guys are like, they need an ECG? Yes. Chest pain, diaphoretic, yes. Yes. Jaw pain, arm pain. Palpitations, yes. Yes. Collapse, definitely. Tachycardic, yes. Tachycardic, 120, exactly, bullseye. Anybody over 120, I don't care what other symptoms they come in with, they're getting an ECG. Even if they sound septic, they're getting an ECG. Alrighty, anybody else? Sorry, we had some more. Central back pain, yes. Anyone else? I heard somebody from around here. Tachy, we've said, yeah, tachy, above 120. Pardon? Yeah, if they feel like the heartbeat's irregular, absolutely. We're worried that they're having a bit of arrhythmias. Anyone else? Ooh. Ooh, probably. That would be worrying. Anyone else? Bradycardia? Absolutely, with bradycardia, yep. Irregular pulses. I'll give you the list. Chest pain, shortness of breath, even those coming in with discomfort, pleuritic pain. What would we be thinking if somebody comes in with pleuritic pain and tachycardia? What's your number one diagnosis until proven otherwise? Could be, but not your number one diagnosis. Huh? Not pericarditis, pleuritic chest pain, and tachycardia? No. Pneumonia? No, but it's to do with the lungs. It's a lung problem. PE, exactly. Yeah, PE. You can actually get PE changes on an ECG. Again, so rare. I've maybe seen it once, but you can get it on an ECG. So you definitely want a PE, and you want to keep these people on monitoring, especially until the AMBO comes, because then they're going to put them on monitoring and take them. Jaw and arm pain. This is the one that everyone always forgets about. Diabetics with epigastric chest pain. It's a silent killer of this group of people. Diabetics just don't present typically very frequently with MIs. So if you have a diabetic who's coming in with really burny central chest pain that isn't their gourd, they definitely need an ECG to rule out anything worrying. Your loss of conscious patients and your dizzy patients. Any dizzy patients, especially most of the old dizzy patients, it's like my number one task that I put back up to the nurses. I haven't even seen them. Back up to the nurses. ECG, and what else might you ask for? Pardon? Blood sugar, yes. Lying and standing, absolutely. So if you ever work in a clinic with me, it's just going to go back up to the nurses until those things are done. I apologize. Alrighty. And who do you keep on monitoring? What types of patients do you keep on monitoring? Anybody that you're worried about? Yes. Tachycardic, exactly. Any ECGs that you're worried about. If you're going to do an intervention, what one intervention do we see? We see it very frequently in our clinics, that before we do something to them, we need to make sure they're on monitoring. It's an emergency, mainly to do with airways often, especially if they've been to a restaurant somewhere. Yeah, absolutely. Yeah, so people with anaphylaxis, if you're worried about anybody with anaphylaxis, you want to get them on monitoring. There is something, again, rare, it's called Kuhn syndrome, where we can actually give them an MI by giving them adrenaline. Super, super rare. But there's two ways people with anaphylaxis end up with MIs. They end up with MIs because of the anaphylaxis itself, and secondary because we give them adrenaline. So it's just something that people often forget. But if you're going to give adrenaline, get them on monitoring. Rare, doesn't happen often, but just do it. It's better for everyone. Alrighty. So take home points from today. ECGs can be easy when you know what they measure and what it means. Who's going to enjoy looking at ECGs from today? Come on. Alrighty. If in doubt, ask these 4 questions. You will not miss any of the big stuff, really, if you ask these 4. It doesn't matter if you know the answer or not. It just tells you, oh, no, I'm worried about this person. This doesn't look right. If there is ever anyone that you're concerned about, the doctor is only a few steps away. Don't be afraid to ask, especially if they're unwell. And if they're unwell, don't leave it up to the doctor. Walk in and say, I am worried about this patient. I want you to see them. Tell them. If they fight back, okay. But just tell them. Don't be like, oh, I think maybe. Be proud, be confident if you're worried. And then if you're ever worried, use the crash buzzer. I would much rather every single time you use a crash buzzer when you didn't need to than not use one when you did need to. Always, always, always. So if you're ever worried, pull it. And help should come. Should. Alrighty. Thank you, everyone. Oh, gosh. Is everything? Thank you. I hope that was useful. Any questions? Any questions from now? No? If not, feel free to email me if you've got any queries, concerns, whatever. Thank you.
Joanne, Reshmi. Okay, last bit, guys, and then you're free to go home. What would you like to do? Yeah? Okay, we're just going to present some awards. This was very difficult to pick, I'm just letting you know now. So we've got 3 awards for our White Cross team, and we've got 3 awards for our local doctors team. I'm going to start with the person that's not here. Okay. And I can say her name.
You read those 2 and then I'll read that one.
Okay.
You can read more.
No, actually. You can read this.
Okay. I'm not sure whether or not people know that they were nominated. Do they? Did they? Anyway, we'll find out. Amanda is still there, that's good to hand them out. So the first one is for Helen Lappin for Clinical Excellence in Practice. And the comment that was made with the nomination is, So Helen Lappin, Clinical Excellence in Practice. Helen is a highly valued nurse and important team member. She directs and guides staff, helps coach them in new skills, and oversees the flow of patients through the clinic. She's very approachable and will take the time to ensure staff feel welcome and heard. She has the ability to bring the team together and rally through challenging times and brings a positive attitude that uplifts the team. She's a wonderful asset and we're very lucky to have her. Congratulations, Helen. Amanda, would you mind? Thank you, Amanda, for accepting that and passing on to Helen. The next person who's not here is Namrata Singh,
Also for clinical excellence in practice, can you hear me? Nimrata is always eager to learn, and the knowledge she gains is reflected in her nursing practice. In 22, Nimrata became the first community nurse prescriber within the White Cross group. This extended practice role has been invaluable during this time of staffing shortage and long wait times, giving it an alternative model of care to a number of our patients. Nimrata is currently looking to extend her scope of practice in this area with further training. She's also assumed the role of acting charge nurse during Carol's leave. She's proved a natural leader, and Carol is confident in her ability to perform this role with professionalism, and she has the support of the nursing team. Congratulations, Nimrata. Carol's not, we'll work that one out. Christine, are you at work Monday? I think the clinic's closed tomorrow, isn't it? For something new. Okay. You happy to do that? Are you happy to do that? Thank you, Christine. And the third recipient who is actually here is Tracy Young, also nominated for Clinical Excellence in Practice. Tracy is by and large the most clinically competent nurse I have come across within the network. Who wrote this? I'm just checking, Tracy, because I didn't write it. I'm assuming that it was Emma who nominated you. Her clinical acumen is impeccable and her knowledge for interventions is unmatched. She continuously aims to further her learning and understanding in all aspects of the clinic. She always works incredibly hard and is a pleasure to work with, a true team player. Congratulations, Tracy.
Perfect. Awesome. All right. Would you like to read? You want me to read? Okay, so we'll start with this one. Awesome. So this amazing person is actually here. So Robin, you're nominated twice. So she is the nomination says she was our go-to exceptional nurse. She makes all patients feel important and is incredibly kind and compassionate. Robin goes the extra mile and has been the mother to many of our patients. They treasure her years of experience and her helpfulness. Robin is truly an epitome of a practice nurse. So many patients ask for only Robin to vaccinate their babies, and now so many of the children she has cared for are bringing their babies to be vaccinated by her. I cannot express what an amazing nurse Robin is, and without her we feel a bit lost, and the surgery feels like something is missing. Robin epitomizes the term team player. She always has the patient's best interests at heart and doesn't shy away from passing on advice that they may not be so keen on, but she will always offer support. She has always provided a caring ear for many patients or staff who need it. She has been at Lebank a long time and knows the majority of her patients. She is our go-to in writing cards for bereaved families. She is a problem solver and camp mother. Her nursing skills and bedside manner are top-notch. She cares for her profession, and the job she does here a very rare and experience. So congratulations, Robin. Awesome. This person had the most nominations, which was 6. And it is for our lovely Shruti. She is an excellent nurse who practices at the top of her scope of practice, demonstrates a high level of clinical knowledge and skill, and always happy to share that with her fellow nurses, and happy to teach all new staff of all her knowledge. Patient and humble to all staff, very approachable and empathetic to patients. sorry, Shruti, I'm fumbling. A role model to us all and has potential to grow into a leadership role. A nurse prescriber always happy to help the walk-in patients and very happy to be part of her team and get to know them. For sure, she needs appreciation for her work and to be acknowledged. Sorry, there was a lot of comments. I'm just trying to get through them all. Thanks for the excellent skills and practice and theory. Always happy to help her staff and new nurses when they need. Excellent with time management and very diligent at her work. She's an excellent team player and provides support and training to all nurses. She's very capable, intelligent, and approachable. Awesome. This last one is for Saju, who isn't here, but I'll read out his nomination, and he also had 4 nominations. So Saju is able to show his excellent level of knowledge, techniques, and education to all future nursing staff of Tamaki Health. I am honoured to work with Saju as he is able to not only educate us nurses, but also guide us with our daily tasks at work. As an employee that has worked in the company as a healthcare assistant, now a graduate nurse, I am grateful to have Saju as not only a colleague, but as a role model and mentor at work. He's really good at communication and helps with education, gives feedback, and is a team player to all. Supports the nursing team in all areas of nursing and supports the members in their daily practice and updating their clinical skills to enhance clinical outcomes. He acts as a team lead to support the team members and is a well-known team player. Awesome. We'll track him down. Thank you.
Anyone from Dolphin Lodge?
No one from Dolphin Lodge? Maybe. Oh. Very last thing, I ran through all the participants from today through a randomizer to win a gift certificate for a photography package, and the winner of that was Paloma. You go. You guys are all free to go. Thank you all so much for attending today. Please, if you can, make sure you do your evaluation forms to leave it for us to give to my speakers. If you haven't collected your certificates yet, they're all at the back. If you haven't signed in, please do come and hunt me down now. Thank you all.